देख देख दीवान का दर्शन, देख देख दीवान का दर्शन, देख देख गुर के चरण तोए तोए पीवा, गुर के चरण तोए पीवा, गुर के चरण तोए तोए पीवा, गुर के चरण तोए तोए पीवा, गुर का दर्शन देख देख जीवा, 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 गुर का दर्शन देख देख जीवा। सखियो सहेलड़ियो मेरा पीरवन जाना, सखियो सहेलड़ियो मेरा पीरवन जाना, पीरवन जाना, पीरवन जाना, पीरवन जाना, पीरवन जाना, सखियो सहेलड़ियो मेरा पीरवन जाना, सखियो सहेलड़ियो मेरा पीरवन जाना, पीरवन जाना, पीरवन जाना, पीरवन जाना, पीरवन जाना, सखियो सहेलड़ियो मेरा पीरवन जाना, सखियो सहेलड़ियो मेरा पीरवन जाना। हर नाम जड़िया रस मोल हर नाम जड़िया रस मोल रस मोल पारा, सखियो सहेलड़ियो मेरा पीरवन जाना, सखियो सहेलड़ियो मेरा पीरवन जाना। मोल मोलो सच कर टोल तब पाए था मुंद फली, मोल मोलो सच कर टोल तब पाए था मुंद फली, एक संग हर के करलिया हम कारी कर खली, एक संग हर के करलिया हम कारी कर खली, हम कारी कर खली, सखियो सहेलड़ियो श्रीधर आप कारज सारे। करण करण सम्राट स्वामी आप कारज सारे। करण करण सम्राट श्रीधर आप कारज सारे। करण करण सम्राट श्रीधर आप कारज सारे। नानक नगरी तन सुहागन शब्द बसावे। नानक नगरी तन सुहागन शब्द बसावे। शब्द बसावे। सखियो सहेलियो मेरा पीर बन जा रहा। सखियो सहेलियो मेरा पीर बन जा रहा। 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 सखियो सहेलियो मेरा पीर बन जा रहा। सखियो सहेलियो मेरा पीर बन जा रहा। हर नाम जुड़िया रस मोल हर नाम
जो
दोस्तों, कहते हैं खूबसूरत से एक पल का किस्सा बन जाता है। जाने कब कौन जिंदगी का हिस्सा बन जाता है।
खास लोग मिलते हैं जिंदगी में, कुछ खास लोग मिलते हैं जिंदगी में, जिनसे कभी ना बिछड़ने वाला रिश्ता बन जाता है।
नमस्कार, आदाब, सत श्री अकाल। A very good morning to all honorable dignitaries, learned delegates, and lovely students. Warm greetings to all of you. Welcome to the 4th International and 20th National Oncology Nursing Conference based on the theme One Team, One Dream. Let uplift healing and caring across the cancer continuum.
We feel extremely privileged to have been given the opportunity to kickstart today's program or in this prestigious event. This day could not have been more special without all of you gathered here today. I, Akshpreet Kaur, with my co-host Kiranpreet Kaur, on behalf of Shri Guru Ramdas University of Health Sciences, Shri Amritsar, welcome you all whom have traveled so far and to be with us today. We are grateful to have all of you for gracing this special occasion for your esteemed presence. Welcome, everyone.
Without taking much more time, let's proceed with today's program. Let's have the pleasure of listening to opening remarks of Honorable Dr. Isabella White, Head of Clinical and Psychosexual Therapy Lead, London. Ma'am, please come forward and share your knowledge on urogenital cancer and sexuality. Please, ma'am. Dr. Isabella White, that Head of Clinical Services, Percy Health Department, Health Limited, London, provide clinical leadership and oversight for professional activity on this supportive cancer care digital services platform, guide development of internal processes and policies, ensure the highest level of clinical governance and continuously monitor and improve patient outcomes.
Can you hear me okay? I'd like to say namaste to the conference organisers and the Oncology Nursing Association of India for inviting me to speak to you today. And huge congratulations on the establishment of the ONAI Punjab chapter. I wish you every success with this endeavour. This talk will actually use the case of prostate and cervical cancer to illustrate the high level of treatment, sexual concerns and difficulties that arise as a direct result of cancer treatment, and how that impacts on individuals and couples that are actually living with and beyond cancer. And most importantly, what we can do as healthcare professionals to begin talking about this taboo subject and challenging topic in practice. I'd like to start off a little bit by kind of looking really at the kind of Indian cancer context. And I think it's important to recognize that cancer can actually cause problems with sexual difficulties irrespective of the actual cancer site. But if you look at, for example, the prevalence of cancer in males in India, Obviously, lung cancer is number one, but you can see there that prostate cancer is the 5th most prevalent cancer overall within India. But it varies a lot by region, from being 2nd most prevalent cancer through to 23rd, and it's number 2 in 5 regions in India. Bladder cancer, again, if you think about it, is actually varies between 8th and 36th across different regions, and it's number 7 in northern, eastern, and Kolkata districts. And then if we look at women affected by cancer, breast, again, overall is your number 1 cancer prevalence. And there's a very high prevalence of sexual difficulties associated with breast cancer and pelvic malignancies, particularly, especially if you actually consider women who are receiving endocrine therapy for breast cancer. With cervical cancer, obviously, again, from a urogenital cancer point of view, being number 2 overall within India in terms of prevalence, and varying again between number 1 and number 5 in prevalence by district. Number 1 in 7 different districts in India. So what you can see is that if you're thinking about the overall cancer burden and you're looking at the high prevalence of sexual difficulties, you're likely to see a large number of people affected in terms of sexual consequences of treatment when they're being treated either for breast cancer or indeed for pelvic malignancies, whether that's a genitourinary cancer or whether that's colorectal cancer, for example. I think it's also worthwhile saying that when you're using treatments in combination, again, if you're using more than one treatment to treat cancer, which we generally do nowadays, again, you're more likely to see a higher incidence of sexual difficulties as a consequence. So that's something worthwhile bearing in mind. If we then look at some of the literature that's perhaps talked about sexual difficulties in different types of cancer, again, we have a systematic review of erectile dysfunction after cancer overall. You can see that there's a prevalence after cancer treatment that goes around 42.7%. And 30% of men actually reporting ejaculation and orgasm difficulties after cancer treatment. If we think about women, again, breast cancer tends to be certainly the biggest prevalence across the globe in terms of female cancers. And again, 56% of women that are receiving aromatase inhibitors as endocrine therapy, and 31% receiving tamoxifen as endocrine therapy for breast cancer will experience sexual pain as a consequence. 75.2% of Indian women after chemoradiation for cervical cancer develop vaginal stenosis or narrowing, and 39.2% of them experience sexual pain as a direct consequence of this. Would adversely affect their sexual well-being. And 70% of women experience sexual problems after treatment for bladder cancer, and actually 3/4 of the women in this study were sexually inactive after cancer treatment. So it's worthwhile us remembering that there are a large number of people that are actually affected with sexual consequences of treatment, but many of them will not necessarily bring that topic to your attention because of embarrassment and difficulties in actually raising the topic with you. I wanted to put this slide up because what this is showing us also that cancer treatment can impact on all the different phases of the human sexual response cycle. So the human sexual response cycle was first considered in the 1960s by 2 American researchers called Masters and Johnson, who specialized in sexual issues, not related to cancer, but more broadly. So we might, for example, be focused very much within oncology on men experiencing erectile difficulties after cancer treatment. But we must remember that cancer and its treatment affects all different phases, not just the arousal phase, which is the one that we would mainly focus on clinically. So when you're being treated for cancer and you have physical side effects of treatment and you have psychological distress associated with your diagnosis and with being frightened about the future, that will also have an adverse effect, for example, on sexual desire. And if you don't actually feel that you have sexual desire or sexual interest, that then has an adverse impact on different aspects of your sexual well-being. So if you can't feel any desire or interest in sex because of your cancer treatment and your emotional impact, you're unlikely to then go on to actually feel any sexual arousal. You won't be able to achieve a climax or an orgasm, and you're not likely to then enjoy sex or have sexual satisfaction. Your motivation to continue to be sexual by yourself or with a partner will be adversely affected by those experiences. And you can see here that it's not just the treatment that has an adverse impact on different phases of the sexual response cycle. You're also looking at psychological impacts such as anxiety and depression, which we know are higher in people living with cancer than they are in the general population. And it's worthwhile remembering also that, again, if you're using treatments in combination, that you can have nerve damage, you can have vascular damage, as well as the psychological sequelae that all come together to actually create sexual difficulties. So they're usually multifactorial in origin rather than being purely related to one particular mechanism. I think the thing that all of us here, and myself included, will certainly bear in mind when I'm working clinically with my colleagues in oncology is that there are lots of barriers to us talking about sex. And we can look at those barriers in two main domains. We can say, well, what are the individual factors that affect us as healthcare professionals and as people? And what are the factors that also affect the patients that may be reluctant to bring up this topic with us? So the individual factors that are very prevalent within the literature are things like what we would call ageism. So the assumption that when people are over a certain age, they are no longer interested in sex. As I get older, the age at which I put as that barrier tends to go up as well. So I'm now in my 60s. So I say, well, then I would expect people to still be interested in sex when they're in their 60s, because I'm still interested in sex in my 60s. And I would say that with the patients that I meet. I have met, the oldest patient that I worked with was 92, and the youngest patient was 17. So you can see right across the age range that depending on their orientation and depending on their interest, depending on their relationship status, they may well be interested in still being sexually active. Again, it's also difficult when you're looking at what we call opposite gender consultations. So if you're a female nurse and you're talking to a male patient, that may be a barrier. They may be embarrassed at talking, especially if they're an older man, talking to a young nurse about something that's very personal and very private. There are cultural and religious considerations. So obviously from our religious teachings, no matter what our religious background is, if we've been brought up in quite a strict religious context, again, that can adversely affect our ability to open and be comfortable talking about a very private aspect of our lives. Many nurses are frightened that they will embarrass patients, and many patients are frightened that they will embarrass nurses or doctors. So again, the ability to actually start the conversation can be quite challenging, not just from the patient's point of view, but from our point of view as well. And then certainly in the UK and in Western countries, I don't know what it's like in India, I hope you will tell me, there is a certain sexual stereotyping and harassment of female nurses, certainly within the UK. So an unwillingness to talk about something very personal when we're also delivering very close, intimate physical care to somebody and touching parts of their bodies that as a nurse we have permission to touch in a clinical setting, but we would not do that in a personal setting, for example. There are challenges with that in terms of how that might inhibit us. And a lack of training. If we've not been trained or taught about how to open up the conversation, how to actually talk to people about sexual consequences of cancer treatment, that is a big inhibitor in terms of the confidence that we need in order to take that topic forward. From an organizational point of view, if we look at structures within hospitals, again, there's often a lack of privacy. And I understand that because of the very large number of people that you will care for, that sometimes it's very difficult for you to have a private space in your hospitals to actually have a private conversation with somebody. And it's unlikely that someone is going to ask you very personal questions about such a private part of their life if there's lots of other people nearby who are going to overhear that conversation. No one is going to open up and have that conversation with you. And we have the same experience in the UK, but perhaps to a greater extent, we have private consultation rooms where people can begin to have those conversations. There's lack of time. All of us are very busy. All of us are time poor. So if you're very busy and your average consultation time is 5 to 10 minutes, we talk about Pandora's box. People don't want to open up a conversation that might lead to something very complex and personal being discussed if we haven't got the time to finish the conversation. So quite often it's about giving someone a leaflet, saying to you, I want to make you aware that I'm willing to talk about this with you, that this may be a problem after your treatment, but actually We might need to book another appointment to meet together somewhere else in order to be able to carry on the conversation, because we can't have all that full conversation right now. But it's time for you to think about it. Then a big, big barrier for all of us is the lack of services and ability to refer people. You're not going to start a conversation about sexual impact of treatment if you don't know what to do with the answers you might get from that person. So again, it's thinking about, how can I link with my medical colleagues? How can I link with other services to actually help with that situation so that I know where to send somebody if they tell me they have a problem? I'm not going to start a conversation if I feel I can't then help them practically. And again, some professionals may say, well, it's not my job. It's not my role. This is not something that I'm comfortable talking about. But again, as the number of people that are living with cancer and are surviving cancer increases, I think we have a duty of care to care about every aspect of their well-being, and their sexual well-being and their relationship with their partners is part of that agenda. I'm going to show you a few slides now that were research that I've conducted in London, where we observed follow-up clinics. And this is data from a prostate cancer follow-up clinic in 2 different settings. One was a radiotherapy setting and one was a surgical clinic. And you can see there that it's mainly doctors that are actually raising the topic of sexual concerns. So in radiotherapy, 48% of the consultations, it was a doctor who raised the concern. And in urology, 30% of the consultations, it was a doctor who raised the concern. And if you look at the number of times that patients raise concerns, you can see how low those numbers are. Admittedly, this was only a small number of observed consultations. But again, it's to illustrate the point that we are the people as health professionals who need to learn to ask the question. We cannot expect our patients, with everything they're already dealing with, for them to be the person to bring the topic to us. So it's our duty of care, it's our professional responsibility to learn the ability to have those conversations. Not easy, quite challenging, and it's taken me many years to learn to be comfortable having those conversations with people. But again, if you are interested in this topic area, that's something that you can all have that opportunity to learn. But you can see also in that table that in almost half of the consultations, no mention of sexual impact happened at all. Bearing in mind this is men with prostate cancer who have a very high prevalence of sexual problems after treatment. Also, if you look at the sort of topics that were discussed, again, the main emphasis is on erectile dysfunction, but it's important for us to understand that when you're treating prostate cancer, it's not just erectile function that is adversely impacted by the treatment. You also have difficulties with, especially after surgery, of the penis actually shrinking in length because of the lack of function, the lack of nerve function. And that's something from a man's point of view that, again, is very devastating to their body image and their masculinity when the penis is considerably shorter than it was prior to treatment. Likewise, you have difficulties with desire because, again, if you're not able to get and keep an erection in order to have penetrative sexual intercourse, then again, your confidence and your ability to be interested in sex also diminishes. This is data from a gynae-oncology setting. So again, observing medical follow-up clinics in gynae-oncology in 2 London hospitals. And again, you can see that there are lots of other topics that were discussed and that sexuality is not actually discussed very often within these consultations in UK hospitals. You can see there that actually the dominant issues are actually about bowel and bladder toxicity, which of course you would understand given that this is radical pelvic radiotherapy patients that we're talking about. Sexual issues were then only discussed in 26% of the consultations that were observed. So again, quite a low level of sexual discussions in the UK. So we're not alone. And this is a challenging topic across the globe, no matter what country and what culture you come from. Let's think then about the kind of socio-cultural elements of sexuality, both from an individual point of view and from an organizational and systems point of view. Sexuality is universal. We all have sexuality in our personal context, but how we express our sexuality will differ both across countries and cultures and within countries and cultures. So there's a lot of individualism. Cultural and religious norms definitely influence both the way we relate to each other in a couple relationship and the gender role expectations that there are sexually within that relationship. And the acceptability and visibility of sex and how sex can be very diverse in terms of there being same-sex partnerships as well as opposite-sex partnerships, again, differs across and within different cultures. So that also the meaning of different sexual problems differs again in different cultural areas. So for example, vaginal dryness, certainly, I don't know about here in India, but in the UK and in America and Canada and Australia, vaginal dryness is seen as a real problem for women post-pelvic radiotherapy, for example. But actually in sub-Saharan African countries, vaginal dryness is valued and considered positive rather than negative. And the acceptability of different treatment options to treat sexual problems, again, differs. So in some countries, the main approach will be a biomedical approach or a drug-related approach, and that might well be the case here in India, where in other cultures and countries, there's more of an acceptance of what we would call talking therapies, or indeed my kind of specialist area as a therapist in terms of what we call psychosexual therapy, which is a talking approach, which we'll talk through in a little bit more detail in a moment. And then, obviously, and most importantly, we have to think about your healthcare resource. So the healthcare resource availability and the priorities where you spend your money as a healthcare setting will differ hugely from country to country between high and low resource or lower resource countries. So let's think about what we need for good sex. This is a very interesting thing to be talking about at 20 past 10 in the morning, isn't it? So first of all, you need blood vessels that work, okay? And this is the main mechanism, obviously, that we damage when we surgically treat cancers in the pelvis and we adversely affect, through radiotherapy, the actual blood vessels and they become fibrosed. So we need blood vessels that work. We need nerves that work. Again, directly, you have impacts from both prostate radiotherapy and prostate surgery that will adversely affect nerve function. We need the right levels of male and female hormones. So if you think when we treat people with prostate cancer, we're depressing often their androgens, that will have a dramatic impact on their sexual well-being and sexual function. From a female point of view, if we've got women who are actually have a treatment-induced menopause because of pelvic radiotherapy or because of systemic chemotherapy, again, the loss of estrogen has a dramatic impact on their sexual desire and on their ability to get aroused and actually achieve climax and enjoy and have sexual satisfaction. We need to feel okay or relatively good emotionally. So again, if we're anxious or depressed, that will adversely affect our sexual well-being. We also need to be with a supportive partner. If we're not in a supportive and helpful relationship, that will have an adverse impact on sexual well-being as well. It's not just about the person with cancer, but also their partnership. I'm now going to talk in a little bit more detail clinically about the different treatments for particularly cervical and endometrial cancer and prostate cancer as examples of urogenital cancers where there's a very high incidence of sexual disruption. So again, if you look at the range of treatments, again, I'm sorry, I don't know whether all of these treatments are available in the Indian context, but these are treatments that are certainly available in high-resource countries where we are looking at robot-assisted radical prostatectomy being obviously the treatment of choice for localized, lower grade and intermediate grade prostate cancer. Prostate brachytherapy, where you've actually got iodine seeds that are put into the prostate gland to irradiate locally. HIFU, which is a type of ultrasound that's used with very good prognosis in small tumors. External beam radiotherapy, which we use for locally advanced tumors and for people who've got higher risk prostate cancer or who are older and can't have surgery. And again, androgen deprivation therapy, which is used for people with metastatic disease and those with high risk locally advanced disease. If we look at erectile dysfunction, particularly being caused by these different treatments, erection dysfunction rates after robotic prostatectomy actually vary markedly in the different studies that you'll read, from 10% to 90%. But again, it really depends on what patients we're including in the studies. it depends on the surgical status. So again, we're looking at whether has that surgery been nerve sparing, or has that surgery not been nerve sparing because the prostate gland was too big and the nerves had to be sacrificed. Because obviously if you have to sacrifice the nerves, then you're not likely to get good erectile recovery as you would if you're able to preserve the nerve function. The main difficulties after surgery and radiotherapy for prostate cancer is that you have what we call neurogenic erectile dysfunction caused by damage to the nerves that supply the penis. So the men will lose the ability to have nighttime erections and waking erections due to the nerve praxis. And there's also a failure of oxygenation of the cavernous tissues, the loss of smooth muscle within the penis, and an increase in collagen within what's called the corpora cavernosum. And all of those mechanisms adversely affect the ability of the penis to become erect and to stay erect when stimulated sexually. Overall, if you actually look at people after prostate surgery, the actual prevalence of erectile dysfunction long term is actually quite high. So the likelihood of having adequate erectile function after prostatectomy is as low as 35%. And the factors that particularly determine the outcomes are whether you had good erectile function before surgery. The younger age man will do better than men who are older. Whether you have any comorbidities such as cardiovascular disease or diabetes, and whether you've had surgical nerve sparing as your surgery. After pelvic radiotherapy, you can see that the erectile dysfunction rates vary from 30 to 40% to as high as 70% at 1 to 2 years after pelvic radiotherapy. Remember, the mechanisms and the timing of when erection difficulties happen are different between surgery and radiotherapy. After surgery, you have immediate nerve praxis. So the erectile dysfunction is immediate after surgery and can take up to 2 years for nerve recovery to occur, which is a very long time for men to have to actually sustain not being able to have sex if that's something that they want. Whereas with radiotherapy, because the mechanism that causes the damage is different, there you've got progressive development of fibrosis and narrowing of the arteries that supply the penis caused by radiation-induced fibrosis. And that develops over a period of 2 years. Usually, once you get to 2 years post-radiotherapy, that will be the maximum level of fibrotic changes and damage. So again, a man might say to you after radiotherapy 6 months later, well, I feel that's great, I'm still able to get and keep an erection, but actually he may still lose his erectile function as he's further out from treatment. And you can see also that about a third of men develop painful ejaculation after radiotherapy, and about 10% of them are not able to have a climax. They don't feel that positive, enjoyable sexual sensation anymore. And about 27.8% of them have difficulty in achieving orgasm after pelvic radiotherapy. Not just the erectile function that's adversely affected, but other sexual mechanisms as well. And then if we look at the impact of androgen deprivation therapy, well, androgen deprivation therapy is probably the most serious treatment in terms of causing problems sexually across all phases of the sexual response cycle. So it reduces or eliminates men's desire or interest in sex. It causes problems in not being able to get and maintain an erection. And again, it prevents men from being able to achieve orgasm as well. But you can see from this list that there are lots of side effects of androgen deprivation therapy. So although the men may view the treatment as an easy treatment to take because they take it as a tablet by and large, or they may be having injections to actually help suppress their androgen levels, the actual impact it has on their masculinity and on their sexual well-being is immense. Let's think now about pelvic radiotherapy in women as well. Here you can see from this study that 24% of women and 53% of men who'd had either primary or adjuvant pelvic radiotherapy stated that that treatment had an adverse effect on their sexual health and their sexual relationship. And the good thing to remember too is that the treatment-related sexual difficulties were as frequent early post-treatment between 1 and 5 years post-treatment as it was 6 to 11 years post-treatment. So when you develop sexual difficulties, they don't necessarily get better over time. which again is why we as healthcare professionals need to consider how we might step in and support and help people with what might be permanent changes to their sexual health. And the principal mechanisms of injury, as I've said previously, that happen between 12 months and 36 months post-radiotherapy are progressive fibrosis that affects the tissues in the pelvis, particularly the vasculature, the arteries especially, damage and inflammatory changes, ischemia and necrosis, and that affects the vasculature and the nerves in the pelvic area. We think now, moving over to look particularly at women, if you think about sexual function after pelvic radiotherapy for cervical or endometrial cancer particularly, again, you can see between 1/3 and 2/3 of women who have pelvic radiotherapy will develop sexual difficulty. This is immensely high. And so again, it's such a challenge for us because it's a difficult and challenging topic to talk about. But that means 1/3 to 2/3 of the women that we treat have sexual difficulties, but they will probably never bring those to your attention unless you're in a position to be them about it first, because of embarrassment, and again, because of cultural norms about it not being seemly or appropriate for many women to talk about such an intimate and private aspect of their lives, particularly to someone who may be a male healthcare professional rather than a 62 to 88% of women develop what we refer to as vaginal agglutination, where the actual vaginal walls stick together after pelvic radiotherapy and cause narrowing or stenosis of the vaginal vault. And that's why we think very strongly about the importance of vaginal dilator use to try and prevent that from happening. 55% of them will experience what we call dyspareunia, which is otherwise referred to as sexual pain. Only about half of the women after pelvic radiotherapy will still remain sexually active. That means 50% of them will no longer be sexually active because of their treatment. And many of them will experience also loss of desire, fear of pain, and fear of actually being incontinent of urine and feces during sex, which is something that again will inhibit them from being sexually active. So what do we do about it? I mean, one of the things that I said to you at the beginning, and I acknowledge is a problem across the globe, is how do we talk about sexual issues, such a private aspect of people's lives? I find that sometimes what's helpful is if we've actually got the ability to use patient-reported outcome measures that are already developed and validated in oncology to help us have a language. Because sometimes it's about finding the right words. And here I'm not talking about, you know, whether the language is Punjab, whether it's Hindi, whether it's English. I'm talking about in any language, how do we find the right words to use in a clinical conversation about sex? Because we want to have a professional conversation and one that doesn't embarrass us or embarrass the person that we're talking to. And what I would say is that we can sometimes find that if we use a patient-reported outcome measure, that gives us what I would call a vehicle to begin the conversation. So we can give the patient-reported outcome measure or questionnaire to the patient, they fill it in before they have their consultation, and then we can use that as a structured conversation with them when we're in the clinical consultation, or when, if it's too busy a medical consultation to have the conversation then, we can take them to one side somewhere private and try and have that conversation with them. But we can use the questionnaire as a structured conversation rather than trying to find the language ourselves. Because I was someone who had to learn as a sex therapist how to have conversations about sex. That took me 2 years to train as a sex therapist. And I'm not expecting anyone here to necessarily want to go to that level of detail. But as a nurse, I can use a patient-reported outcome measure to help begin the conversation, to identify what the problems are that that person might be experiencing. And this is an example from the European Organization for the Research and Treatment of Cancer. And they've developed a sexual health questionnaire, which is what SHQ stands for. C22 means that there are 22 questions in this questionnaire. It's been validated only in cancer patients, so it's valid and reliable for use in cancer patients, and it can be used in research studies and can be used clinically. So there are 15 questions that are generic, which look at different aspects of sexual well-being that might be affected by cancer treatment, from sexual desire and interest to sexual enjoyment, the importance of sex to the individual, the ability to reach orgasm or climax, fear of incontinence, fear of sexual pain or actually experiencing sexual pain, and whether you're satisfied with the level of intimacy in your relationship post-treatment, whether you're insecure about being able to satisfy your partner's wishes, and again, whether your communication with healthcare professionals about sex is satisfactory to you or not. And these items can all be rated on a Likert scale from 0 to 4 in terms of how happy they are with that aspect of their sexual well-being. And then you can see that there are some specific questions for men, such as have they been sexually active, have they been sexually confident about obtaining and maintaining an erection in the last 4 weeks? And have they felt less masculine as a result of their treatment in the last 4 weeks? And again, for women, have they experienced dry vagina, which is a common problem associated with pelvic radiotherapy and with endocrine treatment, and can also be a problem after chemotherapy alone? And again, have they felt less feminine as a result of their cancer treatment? If you want to go for an even shorter instrument and you're working mainly with men, you can actually use this, which is a sexual health inventory for men, or what's called the International Index of Erectile Function 5, which is a very short 5-item questionnaire. So again, the ability to fill in a questionnaire like that can only take 5 to 10 minutes, and then being able to use that to hold as your discussion, again, can help begin that conversation and begin to establish what are the main difficulties that that person is experiencing. Then you have, from a female point of view, the Female Sexual Function Index. This is a 19-question questionnaire that's been validated in breast cancer and in hematology patients who are female. But also there is now a 6-item version, so a 6-question questionnaire version as well, which again is quicker and easier to actually fill in. Because if you think about it clinically, and this has been my focus certainly here in the UK and when I speak at conferences, is that if we don't assess for the problem and we don't find it easy to have the conversation, how can we intervene or actually treat people in terms of their sexual difficulties? Someone somewhere has to begin the conversation. So I guess that's your challenge in thinking about it today, is one of you going to be the person who begins that conversation with someone. Now we're going to go and have a quick look at management in the sort of remaining 20-25 minutes that we have. So how do we actually manage the difficulties that are brought about by cancer treatment? The key thing, if you're thinking about erectile dysfunction management, or often abbreviated as E in the literature, is that pre-treatment erectile function is the single most important thing that determines post-treatment recovery. So if you meet with a gentleman and you're able to ask them, what was your sexual well-being like before your cancer treatment? And they tell you that they often had difficulty getting an erection or keeping an erection, or they'd already been to their doctor and were getting tablets to help with erection. That gentleman will not do as well post-cancer treatment as someone who had normal sexual function at the baseline. So if you're younger or you've had nerve-sparing surgery, and again, if you use medications such as sildenafil or tadalafil, which the trade names are Viagra or Cialis, if you use medication like that very early, post-operatively, and you're using that regularly, again, your chances of recovery are greater than if it's many months or maybe even a year or more before you actually seek medical help to get medication to help with your erectile difficulties. But remember that the sexual nerve recovery can take up to 2 years post-surgery to reach its maximum potential. So again, a lot of our work is supporting a man who's trying to become sexually well and healthy again over that 2-year period post-surgery. Androgen deprivation therapy, again, really important to remember, has an adverse effect on the ability of the man to respond to medication. So men on androgen deprivation therapy tend not to get a good response from medication that helps with erectile function. And the other thing to say about medication is, again, encouraging the men to use these drugs at maximum dose on at least 8 occasions before they give up, because it might not work initially. Because again, if they're very anxious or worried about it working, or they get the timing of the drug prior to intercourse wrong, they need time to actually use those drugs appropriately, will actually then help them get a better result from the drug therapy. The biomedical management of erectile dysfunction, again, I'm imagining that a number of these drugs are available here in India. But sildenafil, tadalafil, vardenafil, and avanafil are the drugs we most often use to help with erectile function post-pelvic treatment. If the oral medication doesn't work, we then move on to a drug called alprostadil, which can either be administered by injection into the base of the penis. We teach the man how to do that. And that is a vasoactive drug that brings extra blood into the corpus cavernosum and thereby actually creates erection. It can also be administered as a urethral pellet. And again, we teach the man how to actually insert this little stick into the tip of the urethra. They press the little button at the top, and a tiny little pellet about the size of a grain of rice gets deposited in the urethra. Then we ask the man to massage his penis between his hands, help it dissolve, and then that again will bring extra blood into the. And then last but by no means least, for men who don't want to use other things or where those other things don't work, we will use a vacuum device or a vacuum constriction device, where it uses a vacuum to actually bring blood into the penis and then pull a constriction ring round the base of the penis to actually trap the blood in there, a bit like an elastic band, which allows the man to then have a functional erection, which he can then use for penetrative sex. And then if all of those things don't work, we then consider surgery and consider the insertion of a penile implant. So a penile prosthesis or a penile implant is only offered certainly in the UK and in high-resource countries once we've tried other therapies and they haven't worked. Because if you're going to insert a penile implant, you have to take out any functional erectile tissue to create the space to put the implant in. So obviously, you want to make sure that you're not actually causing permanent damage to the person and them only being reliant then on an implant for their erection. You have to manage the expectations of the man and the partner, because obviously this is a very changed sexual function that is permanent. And again, you might need to offer them the opportunity to meet other men who've actually had that operation and had it successfully. And they may need some psychosexual counselling to actually help them adjust to the use of a penile implant for sex. These are just pictures or diagrams of different types of penile implants. The three that are available are a three-piece or a two-piece inflatable implant, where there's a little button this is all internal. So the little button is actually in the scrotum, and the man can feel the little button, and he can press the little button like this and pump fluid from the reservoir, which is just over his pubic bone, again under the skin. And that moves the fluid up through these little channels into the actual reservoirs, which go up either side of the urethra inside the penis, and then create a natural looking erection. And then when he's finished making love, he can then depress the valve properly, and again the fluid goes back into the reservoir and the penis goes down again. It's a very effective treatment for men for whom the other treatments haven't worked. Or if he isn't able to have that, again, in lower resource countries, quite often we will use the malleable implant, which is like bendy kind of rods that go inside, again, up either side of the urethra. So they push the rods down when they are not wanting to be erect, and they pull the rods up when they want to be erect. Now, again, a very effective treatment. Climacturia is, again, something that affects men, particularly after prostate surgery, where when they ejaculate, urine comes out instead of ejaculation. Remember, when you do a radical prostatectomy, you take away the seminal vesicles, and so basically you have a dry ejaculation or a dry orgasm. But instead, because the bladder neck sphincter is adversely affected by the surgery, some of the men, until they get good pelvic floor function from their musculature, they may actually then ejaculate urine instead, and that can be embarrassing and difficult for them and for their partners. So what we teach them are, first of all, that urine is sterile and not harmful to them or their partner. We teach them to empty their bladder before they make love, so that there isn't urine in the bladder that will then come out. That can help. We teach them how to massage the penis up and forward, so that helps empty the little U-bend in the urethra where the urine tends to. And again, that means it's less likely to come out when they have their ejaculation. We sometimes can say to men, if they wish to use a condom, that can catch the urine. So some men are willing to do that. Or we sometimes teach them to use a constriction ring, because if they have a constriction ring that's helping them keep the erection, that also prevents urine from coming out the tip of the penis at the point of orgasm. And we also advocate pelvic floor physiotherapy to strengthen their pelvic floor muscle to, again, give them better bladder control. What about the women? I never forget the women. So really important that particularly if they're not allowed to have hormones because it might cause growth of their cancer. This is particularly a problem in breast cancer, but I guess there are some hormone sensitive pelvic malignancies in terms of some endometrial cancers as well, and ovarian cancers. We will give non-hormonal vaginal moisturizers. So they're very safe to use. They're used 2 to 3 times a week. And they're inserted into the vagina, usually at night time, so that they stay where they're put. And that helps moisturize the vaginal walls and actually plump up the tissues and enable the woman to have a better vaginal health and less vaginal dryness, which of course is a main cause of sexual pain post-treatment. We also advise them to use, in addition, an intimate lubricant that's designed to help reduce friction when they're having sexual intercourse. And that's something that they will apply or apply to their partner's penis immediately prior to actually having intercourse or making love. If they're allowed to have hormone replacement therapy and they've had treatment in menopause, again, that can be immensely important in helping with both vaginal health and with sexual desire. So again, if you've got a young woman who's premenopausal at the time of her cervical cancer treatment, who's put into a radiation-induced menopause, it's really important to replace her hormones for sexual reasons, but also for bone health and psychological well-being. We will use vaginal dilators to help stretch and open up the vaginal vault to prevent stenosis, again, to prevent the likelihood of there then being narrowing and shortening of the vagina due to fibrosis after radiotherapy. And if the woman wants, we can use vibrators instead of dilators. So where you've got an actual vibratory stimulus, which again can be enjoyable from a sexual sensation point of view, that can actually help with arousal and sexual enjoyment, rather than just using a dilator, which is really just a medical instrument for inserting into the vagina. Pelvic floor exercises are important for women too, again, to actually help them regain continence and help them be confident with pelvic floor control. And certainly in high-income countries and in the private sector, some women will have laser treatment to help with vaginal atrophy that's caused by cancer treatment. Just an example of vibrators and dilators. So the graduated vibrators there on the left-hand side, they are static dilators on their own made from silicon, but you can put a little vibratory bullet inside the hollow silicon tube, and that can turn it into a vibrator, which again can be sexually more enjoyable for women if that is something that's acceptable to. I appreciate that for some women, they would prefer not to use something that has other sexual connotations or beliefs for them. But also you can get vibrators where you're just using them externally rather than internally. And again, that can be helpful in terms of stimulating the clitoris and actually causing then some arousal and orgasm for the woman so that she can enjoy sexual engagement with her partner. Vaginal dilation, again, I don't know what the approach you use here in India is after pelvic radiotherapy, but certainly in the UK, every woman who believes that they're either going to be sexually active, and even some older women who are no longer sexually active, but they want to have comfortable vaginal examinations in terms of their vaginal examinations in follow-up, will be taught how to use a vaginal dilator, usually for 6 to 12 months after pelvic radiotherapy, to help prevent vaginal stenosis, which we know is a real problem after pelvic radiotherapy. And again, this is something that oncology nurses can really help with in terms of helping support women to use these dilators and teaching them how to actually use them appropriately after their radiotherapy is complete. Just talking a little bit now about talking therapies and psychosexual therapy in the last sort of 10-15 minutes. This is a Canadian study by a lady called Laurie Brotto, who is a psychologist. And she did a literature review of psychological interventions for the sexual impact of cancer. She looked at 27 studies, and the evidence ranged from 1B to 4, 4 being just expert opinion and 1B being a randomized controlled trial base of evidence. She found that 19 out of the 27 studies that were published up until that date were actually level 1B, so that's reasonably good randomized control trial evidence for the benefits of psychological interventions. And the analysis suggested that there is a moderate support for the effectiveness and the feasibility of sexual counseling after cancer in terms of helping with sexual difficulties. So what is psychosexual therapy? I don't know. I believe from speaking to colleagues here in India that psychosexual therapy is available usually by psychologists in mainly private hospitals here in India rather than in the public hospital system. And again, that is also the case in the UK. There is a small amount of psychological help in sexual difficulties based within the health service in the UK, but actually most of it is provided still in the private sector only. Psychosexual therapy is what we call a brief therapy, which means we're usually working between 6 and 10 or 12 sessions maximum. And it addresses 3 key components that are very relevant within oncology. So we look at the physical function that affects sex, how that's been affected by cancer and its treatment. We look at the emotional response to those physical treatments. And we look at the couple interaction to see whether or not there are couple dynamics that are actually creating problems or maintaining the sexual difficulty, preventing them from being overcome. And we use a behavioral framework of exercises called sensate focus to actually help people begin to be sexually intimate again after treatment. The principles of the sensate focus behavioral approach are that each partner takes responsibility for sharing when to initiate intimate contact sexually between them, rather than it being left to one person, which tends to be the man. But obviously, if the man is the person who's had cancer treatment, he may lose confidence in initiating intimacy with his female partner or with his male partner. And in those circumstances, he may need support and help from his partner sexually, which he may not have required pre-treatment. We help provide education and information about sexual function and sexual activity. So we would call that psychoeducation. Again, teaching them about the mechanisms and why their sexual function has been affected by their treatment for cancer and how to overcome some of those elements if they can. And we help them change their attitudes about sex and be more open in the way they communicate with their partners. We help by trying to reduce their sexual performance anxiety with each other. And we help them improve talking about sex with each other, which often can be quite difficult for couples, because again, it's an embarrassing topic even for couples who've been together for many years, talking about something so private in their lives together. We also give them homework for them to do at home in privacy, which they can then come back to therapy and talk about what exercises they've tried at home and whether they've worked or if they've had any difficulties. And that helps us actually diagnose the way forward. I think the other thing to think about here in the Indian context is whether you might want to think about your own environments and actually looking at a national organisation such as the Oncology Nursing Association of India, or working in conjunction with your colleagues in urology or in gynaecology to develop national guidelines for India about how you would approach sexual difficulties in your context, which might be very different from those, for example, of the American Society of Clinical Oncology or indeed the British Society of Sexual Medicine guidelines. So thinking about what you need within your context to support professional practice, because it has to be relevant to your services, to what's available in your country, not something that's just adopted from other countries where it might not work in your culture and in your resource availability within your hospital. But I would like to think that you could begin to consider a service provision model that might not have all of these elements, but perhaps starting particularly with the first 2 levels. So the first level is really, how do we initiate self-care and support and management for the people that we care for? So here we're looking at providing permission giving. So how do we create permission for people affected by cancer to approach us to ask the question? How do they know that it's a topic that's okay for them to ask us about if we don't actually make them aware that we're happy to hear their problems? So here, I think it's very much about communication skills development. It's very much about using patient-reported outcome measures to help us with that conversation. Again, I think it's helpful to learn how to teach about vaginal dilation and being able to find the ability to provide vaginal dilators free to people. They don't cost as much money as they used to, and you can buy plastic dilators quite readily. But again, it's thinking about what can we give them advice about that will actually help their sexual well-being, even if we're not able to offer them every element. So here we might talk about vaginal dilators, talk about the use of lubricants, use of a vaginal moisturizer, and education about contraception, about sexual health, and about safe sex. We may also be able to go to level 2, where it's high-risk case management in people who've got more complex difficulties, such as being able to, again, look to our medical colleagues to make sure that hormone replacement therapy has been prescribed and is being taken appropriately and is helping at the right level of dose. The PD5 inhibitor medication, which is the Viagras and the Cialis tablets, again, being prescribed by medical colleagues. Again, are they taking it appropriately? Are they using it in the right way with their partners? And other erectile dysfunction treatments. And again, teaching, again, we need to learn this first, but teaching about changes to sexual positions that might help, and the use of different devices that might also help them with their sexual well-being. And then the last or third level, again, might not be available in the public hospitals here, but might be available in some of the private hospitals that you might work in, where again, you're looking at people who've got psychological challenges associated with their cancer treatment. They may have other comorbidities, such as cardiovascular disease or diabetes, again, or they have greater complexity and they need psychosexual counselling or therapy. My last slide is very much, how do we prioritise what is going to help sexual rehabilitation in oncology? And I think, first of all, we look to our medical colleagues to look at how do we prevent and reduce the level of difficulties that we're actually seeing in our patients. So we might want to look at how we can actually increase the use of nerve-sparing surgery, how we can actually develop much more precision-targeted radiotherapy so that it's actually irradiating less tissue and then causing less damage in the pelvic structures in terms of vascular and nerve damage. And also making sure that we get hormone replacement therapy for the patients who are able to take it, particularly those younger women with cervical cancer who've been treated but may not be given hormone replacement therapy because we don't remember to do that, and they're put into an early menopause, which has negative effects on their overall health as well as their sexual health. We need to raise the profile about the level of sexual problems that people are experiencing. And we need to do that through developing communication training for health professionals like ourselves. We need to increase the use of questionnaires in clinical practice to help support those difficult conversations that we might need to have with our patients. We need to develop and improve service access, but we need to do that at low a cost as possible so that it's affordable to our health systems. Again, we might look at developing a pathway which might include access to a very brief psychoeducational information like a booklet or something that we can put online to make it available through the internet. Again, borrowing things from other countries and adapting them so that they're appropriate for an Indian context is perfectly appropriate, but again, helps you reach more people so that they understand what's actually happened to them in terms of their cancer treatment impact on sexual well-being. We need to also think about research to, again, help us demonstrate that these are difficulties that people are experiencing, and also, if possible, developing interventions in relation to helping them with sexual difficulties, such as the ones, the different interventions that you've already trialled as RCTs that are advertised on some of the posters that are outside. So again, it's a call to action, I guess, to all of you to think, can you overcome your embarrassment? Do you want to learn how to actually address this topic with these patients? Because the need is out there, it's just we're not hearing it because people are frightened to actually speak up. Thank you very much for your attention today and for inviting me.
So thank you so much, ma'am, for your words of wisdom. It will be a great pleasure for us to listen you again in our future events. Next, moving towards our second plenary session on colorectal cancer. So we have our chairpersons here present here today. I would like to introduce Dr. Meena Sudan. She is working as professor and head Department of Oncology, Shri Guru Ramdas Medical College, Rotary Cancer Hospital, Mehta Road, Valla at Amritsar, since September 2008. She worked as associate professor and head in the same department of oncology at SGRD Medical College, Rotary Cancer Hospital at Amritsar from Feb 2004 till 2008. She worked as an associate professor and head of department in the radiotherapy oncology SCOMS Hospital Sidran Jammu from 1st Feb to 2003 till 11th August. In the radiation and clinical oncology, she's having over 27 years of experience as a radiation oncologist after completing her MD training from MGM Medical College, Indore, which is one of the oldest radiotherapy training centers in the country. She have exhibited excellent clinical skills with mature decision making and high quality leadership and training faculties. She has been working as independent head of one or other oncology since July 2001. She is having expertise in cancers in women, including breast and gynecological malignancies, and the treatment of solid tumors, including chemotherapy and supportive care, palliative care, including pain management of all types of cancers. So, welcome you, ma'am. So,
Next chairperson is Dr. Rita Lakhani. She is the principal, Jupiter College of Nursing, former principal of T.Y. Patel University School of Nursing, Nerul, Navi Mumbai, member of various professional organizations and vice president of Oncology Nurses Association of India, having 23 years of professional experience in various faculty positions, including critical care clinical experiences. And her major achievements are she received many awards, of which gold medal at MSc Nursing, received the Bharat Vidya Shromani Award and a certificate of education excellence for outstanding achievements and remarkable role in the field of education in December 2015 at the International Institute of Education and Management, and having certificate of outstanding contribution in the field of education during Asia Education Summit Awards 2016. She received the Best Principal Award in 2020 by Excelligent and NOI publications. She received the first prize in teachers category amongst all faculties at Maharashtra University of Health Sciences for research presentation during Avishkar Convention 2010 and 2015 also. Published about 20 papers in international and national journals and 9 book chapters, received 3 Best Paper Presentation Awards, research guide for 2 international students, and also delivered more than 40 talks at various forums. So I welcome ma'am also.
So before proceeding to our plenary session, I would like to call upon our principal, Dr. Parvez Saini, College of Nursing, to honor our ma'am, Dr. Isabella White. I like to call upon our vice principal, ma'am, Dr. Manpreet Kaur. And please come forward and receive your honor. Next, I would like to call upon Dr. Meena Sudan, ma'am. Please come on the stage. I'd call upon Dr. Rita Lakhani ma'am also to come forward and receive your honor. So thank you so much, ma'am. So without any delay, we'll start with the next session. I would like to call upon ma'am and introduce our first speaker.
Morning to one and all. It's a pleasure to be here this early morning, pleasant morning, and to address such a wonderful gathering. And perhaps share some thoughts on colorectal cancer and hear it from the expert speakers too. So we are going to develop a lot of insights from expert speakers. We know that colorectal cancer is the most common diagnosis, second deadliest problem amongst both the sexes. The first topic that we're going to deliberate on is molecular basis for colorectal cancer by Ms. Surabhi Mondal. It's a pleasure to introduce her. So, talking about Ms. Surabhi, she is the West. She has back. So, working in the College of. So, education, the West Bengal University of Health Sciences, College of Nursing, NRS Medical College and Hospital, Kolkata. Oh, she's backed her Bachelor of Nursing from there. Regarding her work experience, she's working with AIMS, New Delhi as a nursing officer till date. And she was also the infection control nurse out over there. She's worked with Tata Medical Center, Kolkata as a staff nurse for about 1 year as a clinical nurse in high dependency unit. She's also worked in Tata Medical Center, Kolkata as study nurse for about 2 years' time as a clinical nurse again in high dependency unit. She's published various articles, New Normal during COVID-19 in Dr. BRA IRCH AIMS New Delhi in ONI Journal. I welcome her to speak on this topic. The floor is ours. We've inherited about 40 minutes late, and I hope to cover it up. Maybe not all the 40 minutes. My request to all the expert speakers is let's respect time and maybe let's stick on to the time and maybe have 5 minutes more with us, Stan, so that we have more of question answer discussion. Thank you.
So, morning to everyone. So, today I'll discuss about the molecular basis of colorectal cancer. This 30 minutes I am going to discuss about the mainly the genetic parts in the colorectal cancer. So, first let's see the incidence of colorectal cancer. There is a Globocan data of 2020 which says colorectal cancer is the third most common cancer for both the sexes in all ages. And the second, it shows like from the same, both are from the Globocan data. This shows that colorectal cancer is the second most common reason of death due to cancer for both the sexes in all ages. So as I'm going to discuss about the molecular basis. So basically here I am going to discuss what are the mutation happening in the genetic level. So genetic mutations are basically divided into two types, which are like inherited and acquired. So from the term inherited, we can understand that some genetic mutation is there from in the parents, and that genetic mutation is being carried to the children. Like in the second picture inherited, we can see the black marked grandmother. She is having some genetic mutation, and that is being carried to the son and daughter, that both are the black mark, the 3 and 4. And from there, that same genetic mutation is being carried to the grandchildren, like the 3, 4, and 5 that has been marked by black. This type of genetic mutation which is carried in the family from mother to daughter, like that are being called as inherited. And then there is that acquired type of genetic mutation, where there is that genetic mutation was not present in the parents, but the children has developed that genetic mutation during their lifetime. Means this type of genetic mutation are developed after the fertilization. So here in the first picture, you can see like the parents, grandparents, they didn't had any genetic mutation, they died, but the black marked, which is showing like 70 years, this is the case patient, we can see she has developed some genetic mutation which was not there present in the family before her. So this type of cases are called as sporadic cancer, or this type of mutation are acquired during their lifetime. So based on these, the colorectal types of colorectal cancer, these are basically mainly 3 types. First is the sporadic. Sporadic means just we have discussed like this acquired type of genetic mutation is there. So there is no family history, and 70% of colorectal cancers are sporadic in nature. And then comes the inherited, like we have discussed already. 1 to 6% of colorectal cancers are inherited in nature, and this can be of with polyp or without polyp. If that is with multiple polyp colorectal cancer, the common examples are FAP, like familial adenomatous polyposis, hamartomatous polyposis, and MAP. And that can be like without polyp also, which are like HNPCC, hereditary non-polyposis colorectal cancer, or Lynch syndrome. And the third one is called as familial CRC. 25% of cases are like familial CRC. What is the difference in the familial CRC and the inherited type is that in the familial CRC, there will be also a history of colorectal cancer, but the pattern is not known. Means the gene which is causing that carcinoma in the family, that is not identified. That is why it is categorized at familial CRC. So next, every researchers or clinicians worldwide, they had accepted this sequence of adenoma carcinoma sequence for the development of colorectal cancer. What this sequence says? This says like first, for the most CRCs, first there will be development of adenoma, or there will be development of some polyp. Why most, not all? Because here we have talked about that inherited type where there is hereditary non-polyposis CRC, where there are very less number of polyp. So excluding this thing, all other CRCs, most of the CRCs will have the adenoma first, and that will eventually arise carcinoma. And there will be accumulation of multiple germline or somatic mutation. Means there will be different type of mutations. According to the types of mutation, the behavior of the tumor will differ, and according to that, the treatment also will differ. We'll discuss all about this later on slides. And next, the clonal nature of tumor means if all the cancer cells are developed from single mother cell where there is a common type of genetic mutation, in that cases, that colorectal cancer will have better prognosis, rather than if the in colorectal cancer the tumor cancer cells are developed from more than one type of mother cell where there is more than one type of genetic mutation. So this type will not have that much good prognosis rather than the first one. So what does this adenoma carcinoma sequence? Here we can see typically this adenoma carcinoma sequence is like a heat phenomenon. Like there will be the first heat, and there will be the second heat, and there will be the changes in the cellular level. So first heat is always like APC gene mutation. Like we can see first there is normal epithelium of colon and rectum, and there will be first hit like APC gene mutation through WNT signaling pathway will be inactivated, and there will be formation of early adenoma, and that can stay in that stage for many decades. And again there will be the second hit. Second hit can be activation of KRAS gene, which is a proto-oncogene, or BRAF gene mutation, and there will be formation of intermediate adenoma. and that can stay in that state for 2 to 5 years. And again there will be the third hit, which is like loss of heterozygosity in 18q chromosome, which is typically called as DC gene in colorectal cancer gene, or SM84 mutation or CDC4 mutation. And there will be the late adenoma formation that can stay in that stage for 2 to 5 years. And lastly, always most of the time, most commonly the last is the mutation of T53 gene, which is located in the 17 chromosome number 17 in the short term. There will be loss of heterozygosity for this gene, or there can be mutation of TGFR beta R2 or BAX gene or IGFR2 IGF2R gene, and ultimately there will be formation of cancer. Like I said in the previous slide now. Okay. There will be accumulation of multiple germline or somatic mutation, means there will be different type of gene mutation. Like in slide we can see in the same hit there are 2 types or 3 types of genes are involved. So which gene is mutated in that particular pathway, that will define different type of pathways, and different type of adenoma or carcinoma will be developed. We'll discuss all these pathways later. So I know this is a very much dry topic and not that much related in nursing also. We don't study about these things so much. So kindly keep some patience and listen. Okay, we will understand the importance of this topic at the end of it. Okay. So first there is a normal colon cell, and first there will be the genesis. Like in the second picture you can see, first there will be genesis. How the genesis of the adenoma. So from the normal colon, there will be genesis of small adenoma, and then there will be growth, like there will be formation of large adenoma with villous component, and finally that will arise to carcinoma like large adenoma with high grade dysplasia. Once there is dysplasia, there is a chance of there is carcinoma. So there will be large adenoma formation with invasive carcinoma, which is called as metastasis. So this is the pathways. Like in the previous slide, I have already discussed like which it depends upon the which genes has been mutated. So according to that, there are 3 pathways. The most common pathways is the chromosomal instability pathway or CIN pathway. The other 2 pathways are not that much common, but there are other 2 pathways which are like mismatch repair pathway or microsatellite or MSI pathway, and the third one is the CpG island methylator phenotype CIMP pathway or the serrated pathway. Serrated pathway because typically serrated type of polyps are formed in the third pathway. So let's discuss one by one. So first is the chromosomal instability CIN or APC pathways. APC because typically APC gene is mutated in this pathway. So 80 to 85% of all CRCs and adenomas are formed in this pathway. This is the classic pathway of colorectal cancer, and colorectal cancer caused by CIN usually have a poor prognosis. And 2 important things are, first is there will be activation of proto-oncogene or KRAS gene in this pathway, and second one is at least there will be inactivation of 3 tumor suppressor genes, which are like loss of APC gene, which is in chromosome number chromosome region 5q21, or loss of P53, which is in chromosome region 17p13, or loss of heterozygosity of for the long arm of chromosome number 18, which is 18q, loss of heterozygosity. And inherited carcinoma, familial adenomatous polyposis, this follows this pathway, which is typically comprises of less than 1% of all CRCs. So first in the CIN pathway, we can see there is normal mucosa, and first hit will be the APC inactivation, and there will formation of early adenoma, and the second hit will be the KRAS mutation and formation of intermediate adenoma. Then again there is 18q SM82 for loss and formation of late adenoma, and again last hit will be always the TP mutation and loss, and there is formation of carcinoma. So once any carcinoma follows this type of sequence, this will be called as a CIN pathway. Not typically they follows this straight line, but anyhow they are just moving in these lines only. So a little bit about these genes, APC genes and KRAS genes. So what is APC gene? Adenomatous polyposis coli gene. This is located on the long arm of chromosome number 5. This is a type of tumor suppressor gene. So as it says, it's a tumor suppression gene. So anything defect causing this tumor suppressor genes eventually arise tumor, which are like adenoma and adenomatous polyps, and eventually that can grow carcinoma, typically the sporadic one. Next, the p53 gene. So p53 gene, it is located in the short arm of chromosome number 17. So the normal function in this picture, we can see the normal function of p53. So what happens in our body? There is continuous cell division in our body, and with the cell division there is DNA replication. So during the DNA replication, if there is any damage in the DNA, so there comes the role of p53 gene. What this does, this will arrest the cell cycle for that particular cell which has the damaged DNA, and that then DNA will be repaired by the cell, and once the DNA is repaired, then p53 will initiate the cell cycle. Or if the cell is unable to repair that that particular genetic damage, DNA damage, then p53 will start apoptosis for that particular cell. So eventually there will be the death of that any cell with any damaged DNA. So what happens if there is any mutation? So p53 will not function his normal whatever he was doing. So what will happen? The cell will, there is any cell DNA damage inside the cell, so p53 is not functioning, so the cell will continue to divide and will form some tumor, and eventually that can arise carcinoma. So this is the function of p53. And the RAS gene, there are many types of RAS gene like KRAS, MRAS, NRAS, and typically the KRAS gene is our importance in CRC. So KRAS gene is located in the short arm of chromosome number 12, and this is being used for fecal CRC screen. So whenever in the cells, epithelial cells in the colon and rectum are shredded in the fecal matter also. So whenever is fecal screening is being done, so that cells are being observed for KRAS mutation. And if there is mutation, it is understood that maybe the CIN pathway has been started. So normal function of the RAS gene is this encodes protein that regulates cellular signal transduction of extracellular growth signal, which we typically can call like this helps in contact inhibition. Contact inhibition means cells continue to grow, normal cells will grow, and whenever it will get in contact with the other cells surrounded by it, it will know like, okay, I don't have any space, so I should not grow anymore, so I should stop my growth. So this is the function of RAS gene. So if there is any problem with the RAS gene, so what it will do, it will not listen to the it will not stop growing with contact inhibition, so it will continue to grow and there will be formation of tumor. Like if there is any point mutation in the RAS gene, so there will be inappropriate stimulatory signal and the cell will continue to grow and there will be cell survival, and there will be suppression of apoptosis, and eventually it will arise tumor and carcinoma. So RAS mutation is found in 50% of sporadic colorectal cancer and 50% of colonic adenomas which are more than 1 centimeter, and the adenomas which are less than 1 centimeter, they eventually also develop RAS gene mutation later on the period. And the most important thing is if there is RAS gene mutation, there will be absence of response to agents targeting EGFR like cetuximab or panitumumab, because already we discussed it will not listen the it will not listen the stimulatory signal for the contact inhibition. So obviously the EGFR will not agents targeting EGFR will not function for if there is any KRAS mutation. And next is the second pathway, which is mismatch repair pathway, the mutator phenotype or microsatellite instability pathway. Mismatch repair pathway because the mismatch repair genes are being dysfunction is there. There is mutation in the mismatch repair gene, and if there is any mismatch in the DNA replication, that is not being repaired. So this is called as mismatch repair pathway. And microsatellite instability pathway because in the genetic level, in the DNA level, there is microsatellite like structure formation, so that is called as microsatellite instability pathway. So this comprises of 15% of total CRCs, and there is dysfunction in the mismatch repair genes, MMR genes, particularly MSH2, MLH1, PMS1, PMS2, MSH6, MLH3. And this is the hallmark of hereditary non-polyposis colorectal cancer or the Lynch syndrome, and more than 95% of HNPCC will follow this pathway. So how this works, as I said, if there is any mismatch in the DNA, that is being repaired by this mismatch repair genes. If there is any mutation in this mismatch repair gene, so that repair will not be taken care of. So that damaged DNA part will be repeated during replication. That damaged DNA part will be repeated more and more times, and that will look like microsatellite like structure under the microscope. So what happens in the mismatch repair pathway? Like there is normal epithelium, and there will be loss of APC gene and failure of MMR genes to repair those mismatch, and there will be formation of adenoma. And secondly, there will be mutation in the TGF beta R2 or BAX genes, and there will be formation of carcinoma. So this is the last pathway, which is like CpG island methylated phenotype, CAMP pathway, or the serrated pathway, because I already said the serrated type of polyps. Serrated means how this looks like under microscope, looks like sawtooth like structures, like in this picture, the number C picture, it looks like this. So how this happens? There is vast hypermethylation of promoter CpG island site. So promoter site, we all know the replication starts from the promoter site. There are promoter genes. Hypermethylation means if we see DNA in the microscopic level, so DNA is wrapped around the histone body, like in this picture where it is written like nucleosome. You can see the DNA is wrapped around the histone body. So whatever genes which are trapped inside, means which are touching the histone body, that are not available for transcription. So if there is any hypermethylation, means more and more DNA will be wrapped around this histone body. So more and more genes are not available for transcription. So these genes will not be expressed. So if there are genes which are acts as a tumor suppressor gene, so that genes will not function. So ultimately that will form tumor, and that can eventually grow to carcinoma. Particularly, serrated polyps are being formed, especially sessile serrated adenomas. Sessile serrated adenomas means the number B picture, it shows a sessile polyp which will have a broad base. Pedunculated, we know pedunculated will have a short base. Okay, there will be BRAF gene mutation, and there will be normal epithelium, BRAF gene mutation or DNA methylation. There will be serrated adenoma, and again there will be some mutation, and there will be formation of carcinoma. So a bit about BRAF gene. This follows the CIMP pathway, and less than 10% of sporadic CRCs are with BRAF gene mutation, and this will be resistant to anti-EGFR therapy. So here we can see like in the CIN pathway, there will be loss of heterozygosity, and in the MSI pathway, there will be mutation in the MMR gene, and CIMP pathway, there will be hypermethylation. Prevalence we already discussed, and frequent tumors which are associated with CIN pathway is left-sided, and CIMP is right-sided, and genes which are involved we are already discussed. Here we can see how the clinicians are doing the diagnosis. Like if there is any polyp or adenoma, they are sending it for biopsy, and in the biopsy they are specifically writing for testing for MSI or KRAS. If it is MSI high, then it will be like mismatch repair pathway. And in the serrated pathway also, this can be MSI high. In that case, they are for testing for BRAF mutation also. BRAF mutation will be negative for MSI pathway, rather it will be positive for CIMP pathway. And again we can see like chromosomal instability, this is present in the chromosomal instability pathway, other it will be absent, and KRAS mutation typically presents in the chromosomal instability pathway. And again in this picture we can see there is a overlapping between the MSI pathway and CIMP pathway, where there is involvement of MLH1 gene. Particularly MLH1 gene will be mutated in the mismatch repair pathway and methylated in the CIMP pathway. Next, these are the syndromes, and these are the genes which are commonly associated, which are mutated in this disease. So this is a very most common polyposis syndrome, which is called as a familial adenomatous polyposis. Risk of CRC, if any there is any history of familial adenomatous polyposis, the patient will have, if the patient has any polyp at the age of 25 years, then there is a 100% chance that he will develop carcinoma at the age of 40 years. And the patients will have 100 to 1000 numbers of polyps in their colon, and each of these polyp has the ability to grow carcinoma. So there is 100% chance that these patients will develop carcinoma. And for prophylactically, I think they are doing polypectomy, but that is many polyps are there, so they can do colectomy or something like that. Patient has to live with colostomy, and they have to come to for regular follow-up, and the high risk patients are to be identified from the family. This is the autosomal dominant type, and diagnosis is done by direct sequencing of the APC genes. And HNPCC, Lynch syndrome, there will be the mutation in the MMR gene, particularly for these 4 genes. And this is the most common hereditary colon cancer. This is autosomal dominant type. What does autosomal dominant means? If the father is having any mutated gene, that gene is being transmitted to the children. So there is 50% chance of the children to get HNPCC. So there is also same two-head hypothesis, like there will be first is in the germline, and second it will be maybe developed during the lifetime of the patient. And BRAF gene is not mutated, particularly, and KRAS and P53 mutation can be there for HNPCC. So next, most important thing is screening. Screening are not common for all the cancers. There is guideline, NCCN guideline. This is I have typically taken from NCCN. This is available in the internet. So this guidelines is being updated every time, so you can go through these guidelines according to this average risk, increased risk, and high risk. The guidelines will differ according to that. Typically, if there is average risk, means most of us will have the average risk, means we don't have any history of colon cancer in the family, and also we don't have any high risk condition, then the screening should be started at the age of 45 years, and it should be continued to the age of 75 years. And for the screening, if the colonoscopy is done, then that can be repeated for every 10 years if the results are normal, and so it goes so on. Okay, if someone has polyp, then what should be the guideline? If there someone having any inflammatory bowel disease, then what should be the guidelines? These are all available in NCCN guideline, and that is being updated all the time. So what is the importance in nursing? Nursing, this helps if we know what is the molecular basis of colorectal cancer, so we'll get to understand how the treatment differs for every patient. And most of the patient, if we know that history is very much important thing, so we can identify the high risk patients, because most of the time we are staying with the patients. Most of the time for 24 hours, doctor will come and give the treatment for the patient. Maybe something has slipped from their history, so we can identify these things. Actually, this second point, this is being whenever I was preparing this topic, I went, there is a genetic clinic in IRCH, they're running it for every Saturday. So I met the consultant, and he accepted, like, yes, most of the time the high risk patients are identified by the nurses. So also it helps creating awareness regarding screening and genetic counseling among the patients and relatives also. So this is some bibliography, and here comes the end. So many hospitals may be having the genetic clinic. In our setup, there is genetic clinic, and they are identifying the high risk patient, and particularly they are doing MPLA, multi-panel gene testing. They are doing. Other than that, if it is specified, particularly in medical oncology, they are doing for the patient KRAS mutation and all those MSI high or low. They are checking all those things. These things are costly. Even MPLA, I think, cost 14,000 in outside, but now at times in AIMS there is some study research, so they are doing MPLA testing for breast cancer and cervical cancer. This for free of cost for female patients. So this was this. I know this is a very dry topic, so thank you so much.
Background. Because at this tender age, to talk upon molecular basis, something very difficult I had to use. God bless. Audible? Is it better now? Yeah. So here He said colorectal cancer results from the progressive accumulation of multiple genetic and epigenetic alterations that are occurring within the cells. He also explained to us about the three pathways. My God, it was so difficult. CIN, MSI, CIMP. It was too difficult for me to decipher sitting out over there at this stage. So very excellent. She's also very clearly said there's a growing body of scientific evidence which suggests that colorectal cancer is a heterogeneous disease and has got a genetic bending. He's very nicely towards the end told us that it is our responsibility. It is we who are able to get many patients screened and get screened so that they're able to get diagnosed earlier. So thank you so much. Okay, having known about how to diagnose it, I think now our next session is on what are the various therapeutic measures. And we have novel therapies and latest research in colorectal cancer, which will be dealt by Dr. Prabjot Kaur Saini. She's a professor and principal at SKSS College of Nursing, Sarabi, Ludhiana. She's a gold medalist at MSc Nursing and basic BSc Nursing. She's armed with PhD in nursing under Baba Farid University of Health Sciences, Faridkot. She was awarded with Young Scientist Award in 2015 and 2017. That's credible. She's got about 34 full text papers which are published in national and international journals. She's got numerous scientific papers which are presented various national and international journals. She was awarded the best paper presenter for 11 scientific papers. Excellent. She's been guest speaker. She's a research coordinator. She's a member of NAC. She is chairperson of educational committee at TI Punjab. She's a member of the editorial board and reviewer in 2 international journals. She's presented various radio talks. She's a certified trainer for online, virtual, interactive, and student engagement virtual classes. And she is expert in these areas that have been listed over here for you all to view. So the floor is yours. I welcome you, ma'am.
A very good afternoon to everyone. So I'll try to make the session a more interactive. Okay, just to review about the last lecture that ma'am has taken. I know we are not dealing much with molecular science and molecular things, but basic difference between a tumor and a normal cell is, what is the basic difference between a tumor and a normal cell? I hope everybody knows about that, because we are talking about cancer and tumor is what we are talking about. See, the basic difference between tumor and normal cell is the mitosis or the cell division. The frequency that the tumor cell divides is not the same as that of normal cell, isn't it? So that is the reason why we give chemotherapy. Chemotherapy is acting on the multiple dividing cells, isn't it? But there are many other normal cells also which are multiple dividing, which are frequently dividing, like stratified squamous epithelial cells. इसीलिए तो वो oral ulcer हो जाते हैं ना? That is the reason why we get so many of the hairs fall down, because that is also rapidly dividing cells. Please listen carefully. I want you to make it understand whatever I'm going to teach you. Because rapidly divide cells होते हैं, तो इसीलिए that is the reason why chemotherapy also affects our normal body cells, and it is lot of side effects are there. In colorectal cancer that I am going to discuss, in this actually chemotherapy, radiotherapy and surgery के अलावा, the scientists have taken up the targeted therapy. अब targeted therapy क्या है? Chemotherapy was also acting on normal cells, so side effects were very much high. टारगेटेड थेरेपी में क्या किया उन्होंने, सेल्स और उन्होंने रिसेप्टर्स और उन्होंने कुछ एंजाइम्स लेके लैब में प्रिपेयर किए, एंड व्हाट दे डिड, दे इंड्यूस्ड और इन्फ्यूज्ड इन द बॉडी, एंड नाउ दे आर गोइंग टू एक्ट ओनली ऑन द ट्यूमर सेल्स, दे आर नॉट गोइंग टू एक्ट ऑन द नॉर्मल सेल्स. तो ये अच्छा है ना, ठीक है. But this is not given alone. Targeted therapy is always a adjuvant therapy which is given along with the other basic treatment of cancers. So just wanted to make you aware that there are a lot of targeted therapies, immunotherapy, biological therapy that have been introduced by scientists, which we are not well aware. And I'm thankful to the to SGRD to give me an opportunity to go through this topic. And now I'm going to teach you this topic. Okay. So novel therapies and latest research in colorectal cancer. I will try to skip off everything which has been already, you know, that chemotherapy, radiotherapy, all these things, you know. So how common is CRC is colorectal cancer? So I've made a short form of this. Who is at high risk? किसको कैसे हमने treat करना है? What are the novel therapies and what are the clinical trials? See, remember that clinical trials are always going on. तभी हम new चीज apply करते हैं. Isn't it? So the standard treatment is all the old treatments. New treatment is something that are done or they become the standard treatment after a lot of clinical trials. Okay. So in this half an hour, we are going to study about introduction, colorectal cancer, case scenarios, epidemiology. I'll try to skip this off because it has already been covered up, and focusing on the novel therapies. Okay. So the background is that colon cancer is a disease of the colon, and colon is large intestine. Talking only about large intestine, and we are not talking about small or any other GI tract. Health history affects the risk of developing colon cancer, and signs are varied. Tests, there are various tests to diagnose as well as screen them. See, there's a difference between diagnosing and screening, though it is intermixed. Diagnose का मतलब वो normal patient आता है कि मुझे stool आ रहा है. I'm coming here to diagnose myself कि what is happening. Then the person comes to know that he is being screened for the colorectal cancer. समझ आया the difference? The person is coming for routine test, and later on he comes to know there are polyps, there could be cancerous. Okay. So the screening and the diagnosis is being done, and there are many factors which can be given, novel therapies that can be given to treat colorectal cancer. So you know already, colorectal cancer is the second most lethal cancer and third most prevalent malignant tumor. And worldwide, बहुत सारे cases that has already been discussed. Most cases are found in United States, Canada, America, Australia, New Zealand, Denmark, Sweden. Why so? Why not India? Anybody? A very common sense question. Because no, the reason is we are not doing much researches. Even if we are doing it, we are not publishing. That is the reason we do not have a pool of data which is showing India here. India is in billions. और अगर India में अगर इनमें 8% आती है, तो that 8% might be 1% for us, but that itself is a large population. We need to do researches, and the most important is we need to publish them. Okay. An Indian scenario says that age, अब इनके पास कोई study नहीं है. I didn't find any study which could give us the epidemiological survey of how many colorectal cancers are there. And remember that if it is in the family, you have to be getting screened yourself. If it is first blood, if it is second blood, you need to tell the people, and also you have to get yourself screened every 10 years. Okay? And if it is first blood, then every 2 years and every 5 years. Okay. So 5-year survival of colorectal cancer in India is one of the lowest in the world, which is very bad, at less than 40%. So that means survival rate यहाँ पे बहुत कम है, अगर हो जाता है तो. Okay? Why? Because we are not putting up, we are only going for chemotherapies, we are only going for surgery. Surgical treatment or therapy is the main treatment. Why? कहीं पे भी मिल गया, we need to resect it. If it is a polyp, we have to resect it. If it is a tumor growing up in somewhere, we have to resect that colon. अगर बहुत बड़ा है, एक side है, तो ascending colon को पूरा निकाल देना. So partial colectomy has to be done. If it is complete, the whole colectomy has to be done. We have to remove that. And along with that, और क्या चीज remove करते हैं जब हम कैंसर के ट्यूमर को remove करते हैं? The nearby tumors, nodes. Lymph nodes, it has to be removed क्योंकि pathway क्या है? Lymph system, lymphatic system. Okay, so I'm just adding up all those things just to make it more interactive. Lot of demography is there. It is The mean age affected CRC is 47.2. So कह लो कि 40 to 60 years is the basic age group where the colorectal cancer is diagnosed. It may happen 10 years back. और अगर family में history है तो the age limit goes down to 30 years also. So remember that hereditary and familial tendencies are there for this cancer. Okay, so left-sided tumors are there and right-sided tumors are there, and it all depends upon then what happens is ki there are different types of signs and symptoms that occurs. Okay, the median duration of symptom was 4 months and ranges from 10 years to 10 days to 12 years. Okay, 5-year survival rate क्यों बता रहे हैं? Because if it is early stage you are detecting it, 91% survival rate है 5 years का. Early stage है, that means stage 2 and then can be detected 88%. Regional disease है stage 3 तक पहुंच गया 70% and metastatic disease है then less than 12%. So identifying, screening is very much important. Pathophysiology I'll not go through. It is same as that of how it starts from at a place, it grows, and when it grows then it metastasizes to the nearby organs, then to the distant organs. Okay, so that is as same as that of any other organ. And what are the risk factors here? For colon cancer, increasing age, male, family history, personal history, environmental factors and lifestyle. How many of you are exercising every day? Raise your hands. Because we do not believe in exercising. We do not believe in prevention is better than cure, isn't it? Do exercise. It will prevent you from lots and lots of modifiable and non-modifiable disease. And this becomes a non-modifiable because, you know, the cancer, you can prolong the life, but the cancer, the tumor can be eliminated. अच्छा एक और चीज़ मैंने बतानी थी. What we talk that surgery is done. फिर हमें और क्यों देनी पड़ती है therapy, chemotherapy and radiotherapy? Why? Because there can be micro tumors which can settle down somewhere and you never know that when it starts growing again. And then you can't be waiting for 10 years more to find out whether you have got cancer, isn't it? So इसलिए हमें surgical treatment के बाद we have to give chemotherapy also. Somewhere it is required. अगर rectal है तो radiotherapy also. And now additional therapy, novel therapies are targeted therapy. Okay? So lifestyle, physical inactivity, obesity, diet less in fibers is a high risk. Alcohol, smoking, use of tobacco and IBD. IBD is inflammatory bowel disease. What are the two diseases coming under this? Ulcerative colitis and Crohn's disease. Ulcerative colitis is a typical disease of the colon. Okay, and if ulcerative colitis occurs, remember that the person has to screen every now and then. Follow up should be there to detect whether he is having colorectal cancer or not. Diabetes mellitus type 2 as well as genetic or hereditary colon CA syndromes are there, where familial adenomatous polyposis, which is FAP, and the last speaker has already mentioned about HNPCC or Lynch syndrome. These are familial or hereditary polyps which can cause cancer in an increasing rate. So if anybody is having in his family, the person needs to get it checked again and again. Signs and symptoms are varied, and I tell you, nobody comes, it is asymptomatic for a long period of time. And when you come to know is when it is bleeding through the stool and it is already very late. So bleeding, sudden change in bowel habits, vague cramping, weakness, tiredness, ये तो हमें वैसे ही होती है every time, isn't it? अभी चले जाओ कि कॉन्फ्रेंस के बाद मुझे टायर्डनेस हो रही है, but that is not a symptom. So these are the symptoms which are every day happening. So we do not come to know, and it is not a good sign. Anatomical sites, the sites of where the tumor can grow are ascending colon में 22% हो सकता है, transverse colon 11%, descending colon 6%, sigmoid colon 55%. And four major tissue levels are there ना, पूरे GI tract में 4 कौन से होते हैं? Mucosa, speak up, submucosa, muscularis and serosa, which is the outermost layer, isn't it? So it starts from mucosa and then it starts growing, and then the stages, 1 stage से 2 stage हो जाती है. When it includes the muscularis, it becomes 3 stage. When it goes to the nearby organs, it becomes 4th stage and metastasis occurs. Okay. So right-sided lesions matlab right side of the colon, left-sided lesion matlab left side of the colon. Okay. So if it is right side, remember that bleeding and usually diarrhea are the sign and symptoms of the right-sided lesions. And left-sided lesions are detected later and could present with bowel obstruction only. Because why bowel obstruction? Because the tumor will grow so much that there will be a thin pencil-like stools will be there. Okay, you might have even read it in ulcerative colitis also. Pencil or very thin ribbon-like. So morphology, 50% of the rectosigmoid areas are affected, and right-sided tumors are more commonly affected. And this is again the percentage of a particular area where how many chances of tumors can occur. I've already told you the difference between diagnosis and screening. The most important is sign and symptoms. Entire bowel evacuation has to be done, physical examination, colonoscopy, double contrast barium enema, CT colonography, which is done by CT scan, and flexible sigmoidoscopy, digital rectal examination, जिसको हम DRE भी बोलते हैं, ultrasonography, which tells us about how much is the tumor penetrated, and fecal occult blood test. पता है ना? So just to see fecal test, fecal blood, that how much is there. So we need to do two types of tests are there, GUIAC FOBT and immunochemical FOBT. GUIAC mein, there is a special card where you can just test it and send it to the laboratory by dipping it into the stool. And immunochemical test is also, there is a liquid is being injected in the stool and then it is passed on in the machine where a line comes and then it is tested as positive. CEA is carcinoembryonic antigen. This is a tumor marker and that can also be 0 to 3 nanogram per ml is a normal value. If it increases, it can be high risk. Then biopsy and DNA stool tests are done. Screening is same as diagnosis. Remember that how we will find out that CRC is there? By colonoscopy. Colonoscopy is the gold standard or gold screening method. Okay, and CEA levels also. Screening guidelines have been already discussed by the last speaker. And staging and grading, there are various methods to stage and grade. Duke's classification is most common one, where you stage them accordingly, where stage A is there, B is B1, B2, C1, C2, D, and stage D, which is the fourth one, or distant metastatic. I've just mentioned it here that if it is wall or the mucus, then remove the tumor and surrounded lymph nodes, extend to the wall, not spread to the lymph nodes. Agar B category hai, B stage, then surgery and chemotherapy is only required. The cancer has spread to the regional lymph nodes, then surgery and chemo again. Agar rectal hai, to usme we have to give radiotherapy also. And spread to the nearby areas, then chemo plus surgery, as well as additional surgery has to be given, has to be done to remove the metastasis of whatever organ is also involved. TNM staging you already know. The sites of metastasis are liver, via blood, lung, brain and bone, lymph nodes, abdominal wall, nerves and vessels. Let us come to the novel therapies. Okay, remember that जब tumor बनता है तो from where it takes the oxygen and nutrients? From where it is taking? Yes, very good. It is creating its own blood vessels, which we call as angiogenesis, isn't it? अब जो हमने targeted therapy में हमने जो prepare किए थे enzymes बाहर laboratory में, they are going to act on killing those or reducing those angiogenesis. और जब उसको oxygen ही नहीं मिलेगी तो what will happen? It will actually kill the tumor cells only. Is it clear? So this is what we are talking about, angiogenesis inhibitors. Targeted में immunotherapy आ जाती है, and we'll just talk about this. The causes of colorectal cancer, 1/3 are familial, hereditary, and so there are always enhanced risk of causing it. So this we have already seen in the last. Stage 0 में local excision करना पड़ता है along with polypectomy. Stage 1 resection and anastomosis. Stage 2 also resection किस चीज़ की? Surgery to remove the or resect the colon or the tumor or wherever it is present. Stage 2 में थोड़ा बड़ा area हो जाता है तो we have to remove the colon only. Stage 3 resection and anastomosis के साथ साथ we have to go for targeted therapy or clinical trials. Stage 4 also clinical trials, all the therapies have to be included in this. Okay, along with radiotherapy, chemotherapy. Okay, and we'll discuss about this. So the treatment goal of adjuvant and the primary therapy is, where surgery is the gold standard, is maximizing the shrinkage of the tumor, okay, suppressing the tumor spread and growth, and achieve complete removal of the tumor. So that is what we are aiming for. So surgery is a gold standard, and radiotherapy and chemotherapy are all the adjuvant therapies that are given along with the surgeries. Okay. So treatment options have been here. This we already know: surgery, medical में chemotherapy, targeted therapy, and immunotherapy, and there is radiation therapy. Always remember, when you are getting these therapies, if the patient is getting these therapies, you have to ask him for follow-up and screening again and again, because relapses are there. Okay. So some standard are there and clinical trials. मैंने बताया कि standard treatment जो मैंने आपको पहले दिखाया, surgery, chemo and radio. जो clinical trials है, they are done in the laboratory, applied on the animals and the people who are willing to get for clinical trials. जब उनके ऊपर successful हो जाता है and they start implementing it on the patients, तो वो क्या बन जाते हैं? Those clinical trials becomes the standard treatment. Okay? So this is carried on again and again by a lot of scientists all over the world. So a treatment clinical trial is to improve the current treatment to obtain information on new treatment. So a new treatment is better than the standard treatment, and this is always a adjuvant and a good therapy that can increase the lifespan of the patient. Okay. So surgery, I will not go through this details because this is already, you know, colectomy करनी है, partial है, कौन सी side पे करना है, wherever the tumor is there, we are actually going to remove that area. Okay. So surgery is the gold standard for curative and palliative management also. Okay. And so see, you can see here, जहाँ पे भी tumor है, you can see the round one, we have removed it. Okay. We have removed that part of side because nearby lymph nodes को भी remove करना पड़ता है. And why we are removing it? Because we do not want to give any chance for tumor to grow again. Okay. And chemotherapy as an adjuvant therapy. See, chemotherapy, they are given in combination, double combination and triple combination also. You can see the combination here. I'll show you this slide. Active chemotherapy drugs, where 5-fluorouracil नाम सुना होगा आपने, ठीक है? Leucovorin is there, LCV. There is oxaliplatin, ठीक है? Irinotecan, so this is CPT. ये combination में हम करें तो we have given the names. Not we, I mean scientists have given the names. If 5-FU and all these oxaliplatin is added, then Folflox. And if it is irinotecan, तो then it is Folfiri. Okay. And then अगर तीनों ही add हो जाए तो Folfoxiri नाम बोल देते हैं. So this is the name that we are giving कि ये वाली treatment उसको चल रही है. Okay. So adjuvant chemotherapy is always effective because it is being given along with the surgical treatment. And always remember that the adjuvant therapy is usually started in stage 3. Stage 2 may it is not effective. So the researchers have seen that it is not effective at stage 2. So 40% effective ही होता है. In stage 3 it is 60%. Okay. Then there is radiotherapy, and I hope you know that external is there, then there is internal. Remember that external therapy is usually given as a palliative. Internal is given in the lesser stages. Okay. Then comes targeted therapy. Okay, so targeted therapy over the past 10 years have been evolving, and there is a use of drugs or other substances to identify and attack specific cancer cells, and they cause less harm to the normal cells and more harm to the tumor cells. Okay, तो 3 तरह की है targeted therapy: monoclonal antibodies, angiogenesis inhibitors and protein kinase inhibitor therapy. Remember that inhibitor हमने क्यों नाम डाला है? Because actually they were feeding the tumor cells. और हमने वो prepare किए lab में, we gave them inhibitors, they became inhibitors. When we infuse them in the body, उन्होंने जो tumor cells grow कर रहे थे उसको उन्होंने control कर दिया, and the tumor cells died. Okay? I could not show you the video here because वो video मेरे से download नहीं हो पा रही थी. You can go through, you can put up these names on the YouTube and you will see a very good video where you can see how it is killing the germs, okay, killing the tumors. So monoclonal antibodies क्या करता है? They are immune system proteins made in the laboratory to treat cancer, Antibodies can attach to a specific target on the cancer cells. Cancer cells के ऊपर भी receptors होते हैं. So they attach themselves on them. Okay. When they attach, then what will happen? They will kill it because they are not going to angiogenesis नहीं होने देंगे वो. ठीक है. Those antibodies are able to kill the cancer cells, block their growth, or keep them from spreading. So monoclonal bodies are given by infusion, and they can carry drugs. They can be given along with the drugs, toxins, or radioactive material also. So there are two types of monoclonal antibodies. You can remember the short name: vascular endothelial growth factor inhibitor therapy and epidermal growth factor receptor inhibitor therapy. Inhibitor को आपने ऐड करना ही है, because जो शुरू वाला पार्ट था वो क्या है? They are actually feeding the tumors. Okay. अगर ये हम inhibitor therapy नहीं देंगे तो this is naturally produced by the body and they are actually feeding the tumors to grow. And what we are now giving is inhibitor therapy. They attach it on the tumor cells and do not let them grow, and ultimately they die. Okay. So this is where it is causing angiogenesis. Actually क्या होता है कि vascular endothelial growth factor angiogenesis करता है. Angiogenesis को stop कर देंगे अगर inhibitor देंगे तो ultimately it will make the tumor cells reduce. Okay, kill the cancer cells. Bevacizumab is an example for this therapy, in inhibitor therapy, where you can see that it is actually they are attaching it on the blood vessels of the tumor, and ultimately they will stop the angiogenesis and the cancer cell will die. This is how it is getting attached, and angiogenesis will stop, and ultimately they will not let the cancer cell grow. Here you can see it is causing regression, inhibition of the new blood vessels, and anti-permeability of surviving vasculature. Ultimately, the death of the cell. Epidermal growth factor क्या है? Epidermal क्या होता है? They are the cells. Okay, they are the so this inhibitor therapy, they are proteins on the surface of the certain cells. तो ये क्या करेंगे? This is just a type of flow chart only. Epidermal growth factor actually attaches to the endothelial growth factor on the cells, surface of the cell of the tumor, and causes the cell to grow and divide. When we are giving inhibitor therapy, तो वो क्या कर रहा है? It is actually stopping the growth, and ultimately the cell will stop dividing and die. Okay. So, so these are the inhibitors, and the examples are already given here. These are a lot of clinical trials are already going on. So I just mentioned one of them. Then there is angiogenesis inhibitors. I think I don't need to explain that. नाम से ही समझ आ रहा होगा. Angiogenesis inhibitors means it will stop the growth of the blood vessels, new blood vessels, which are helping it to grow. Okay. This angiogenesis, you can see that the small tumor cell is there, and the tumor secretion of angiogenic factors, they stimulate the angiogenesis, but now we are stopping it by giving the angiogenesis inhibitors. There is another one which is protein kinase inhibitor therapy. This blocks the protein needed for the cancer cells to divide. तो अल्टीमेटली क्या है, जो चीजें उसको डिवाइड होने के लिए चाहिए हम उसको दे ही नहीं पा रहे, isn't it? So actually it is acting as a contraceptive for the tumor cells, isn't it? I gave a new name to it. So all these targeted therapies are contraceptives to this tumor cells. Okay. So BRAF inhibitor एक नाम mention किया था last speaker ने, and that blocks the activity of the proteins and makes it mutant. Okay. So these are few of the studies. I have just showed them. I can't read everything, but these are studies actually going on, clinical trials going on, which have proved that these therapies are effective. Okay. And then there is a immunotherapy. And immunotherapy क्या होती है? What is immune? Our own T cells. T cells are killer cells. अगर हम उन killer cells को ट्यूमर के अगेंस्ट काम करवाने लग जाएंगे, what will happen? It will actually start acting, our own body immune system will be helping on killing the tumor cells. And this is called as biological therapy or biotherapy. Lot of cancers, other cancers are using this immunotherapy. Okay, they are using the patient's immune system to fight the cancer. They take the immune cells, prepare them, boost them up, then insert them back into the body. Okay, and this is called as biotherapy. This block the proteins called checkpoints, and they are making which are made by the T cells and some cancer cell, ultimately stopping its growth. Okay, this is immunotherapy, another study which is being carried out. This is a published study, and there are many other studies being carried out on immunotherapy. This is another checkpoint inhibitor therapy, immune checkpoint inhibitor therapy, which is a protein on the surface of the T cells that helps keep the body's immune response in check. Now, this protein will be acting on the B7 on a cancer cell. अब ये भी समझ लो cancer cell के ऊपर भी receptors होते हैं. They are same as that of normal cells, but ये है कि they are just different because they are multiplying rapidly. So B7 is one of the receptor on the cancer cell, and it attaches on it and ultimately killing the cell. A very beautiful video is there. Do watch it. If possible, I will send the link to the organizing committee, and they can send it to you through WhatsApp. Okay. And so these therapies are actually very effective. Now, another one is PD-L1. There are number of therapies. All these are under clinical trials. Few are already being in use. And these clinical trials, one of them is PD-1. Okay. And this PD-1 is a protein on the surface of T cells that helps keep the body's immune response in check. And this protein is also found on some of the cancer cells. So which also kills the cancer cells. Okay, so this is also, so the main mechanism is same. Ultimately, what they are using, either they are using T cells or they are using the specialized proteins to kill the cells. So few of them are there. Now I would like to come to a very interesting therapy. Still it is going on, and I'm very happy to say that it is already being carried out in DMC hospital, which is microbiota manipulation. Can anyone tell what it is? Microbiota manipulation. The people who are I would like to just tell, the people who are suffering from Crohn's disease or ulcerative colitis, fecal implant is being done. Have you heard of that? They take the feces of a normal or a healthy person, maybe from their own family. They prepare it in a lab, and then they implant it in the body of the through colon. In the colon only they place it, and they actually improve the fecal status of the person. And it has shown, lot of studies have been done. I will just show you few studies. Gut microbiota modulation, a novel strategy for prevention and treatment of colorectal cancer. So you can imagine how effective it could be that a good feces and a bad feces in a cancer patient, their fecal matter and microorganism itself are causing mutations and leading to cancers. And what we are doing, we are taking the healthy fecal matter of a healthy person and then transplanting it into a normal person and into a cancer patient, and ultimately it is also improving the health status of the patient. And I can tell you, I have seen this procedure. I was in DMC in 2 years back, and then there they are doing it and implanting it also, and the doctors itself says that the patient are feeling improved from ulcerative colitis. Cancer mein abhi trial chalne hai there, but I'm sure that various big hospitals and AIIMS also might be having these transplant therapies or microbiota modulations or manipulation. So very new thing, I think, or you already knew it. So go through it, okay? So last summary, I'm sure I'm within time. Despite advances in therapy, metastatic CRC remains lethal, but we can improve that by good screening, by finding out who are the high-risk people, as well as screening them and diagnosing them well on time, and giving them adjuvant therapies, which includes surgery as a gold standard, chemotherapy, radiotherapy, as well as targeted therapy. So I'm sure that you might have got a good amount of information. I tried to make it very simplified because it is in the same way that the molecular explanations were there. So I understood, and so that I could make you understand. Thank you so much. Thank you, one and all.
Thanks, Dr. Prabjot. I think normally when people speak, they speak parallel. You know, there's one line there, there's one line here. But when Dr. Prabjot spoke, she managed to get a V, connected it. And she realized that there was a need that she stands here and says, hey, hello, I'm speaking. And I'm here to give you all something. I'm here to give you all a lot of sense because I have prepared well. And I want to share that with you all because when you look into the books, you might spend hours together to contemplate and develop insights the way she had developed. So I tip my hat to you. Lovely. Yeah. I thought I would have to tell them to give you a round of applause, but they managed to do it themselves. So that's the feedback that you have got. So I just loved. She started off very clearly telling us what is cancer. She didn't miss that point. So she wanted to know how much her audience knows. She moved ahead to tell us what are the risk factors. She connected and she told us in the risk factors, we Indians are not there because we don't do researches. And we are a little low, including myself, a little low on recording. So we don't like to record. And then we miss everything. And then we say, oh, I got something there, I got something there. But we don't have a record to prove ourselves. And this is what all of us would have experienced when we want to stand by ourselves, stand on our feet. We are not able to do it because we don't have record. So that was something very impressive. She moved ahead to tell us what is the various gamut that's available to us in management. And she said there is a progressive improvement and that improvement is very transitional. It's very classic. There are certain things that are proved. There are certain things which she said are under invention and which will come up. It will unfold to us. I just loved what she told about immunotherapy and targeted therapy. We all are studying about immunotherapy and targeted therapy, but she put it such simple words, like how we teach a KG student. There is something abnormal and you develop something against that abnormal and remove it up. I like what she said about angiogenesis, and it immediately connected me to a small study that I'm doing on Ayurveda. So Ayurveda tells us, I'm just adding on to what she has, the allied therapy. So Ayurveda says you want angiogenesis. A cancer cell wants angiogenesis. A cancer cell wants to grow. So it requires nutrition. Don't give it nutrition. Don't give it nutrition. It will start. So they are telling us a lot about starvation therapy. You starve a long period of time. I liked when she said, how many of us exercise? And she must have had, I didn't turn back and see, but she would have had a few hands that would have come up very reluctantly that we do exercises. And believe me, the kind of change that I find in the population today, when I go for a walk in the morning, I find a lot of people are running and I find a lot of people are active doing exercises, which was not there 10 years down the line when my husband and me would go for a walk in the morning. We had a religious walk on Saturday, Sunday, which is growing. So a message for all of us that we feel we are tired, we are fatigued, it's all in our head. Try to put that across to you all very, very subtly. Get that off, get a little more active, start enjoying your life. You will find it very fulfilling. Going a little more ahead, I feel she told us about that fecal therapy, which is not new. It came when I was a student at KEM Hospital, and there was a doctor when he was teaching about colorectal cancer. He said, fecal therapy is there. It's done in small, small areas, but people are saying she to it. And there, the fecal therapies come in a full bound way. And what is this fecal therapy? They are giving us back our gut health, which means you and me are spoiling our own gut and we don't bother. We are abusing our gut. So can we put away all that junk food? Can we start eating the meals that has been cooked with a lot of love by our mother? And the food that we eat, the Mediterranean food is considered the best all over the world. Can we get back to those roots and enjoy the meals? We will have less problems. So even Ayurveda says that gut health is very important. They're saying keep it alkaline, have a lot of probiotics, have a lot of small sized meals, go in for starvation. See that you're eating small portions and not filling yourself. Let's start all that. Lifestyle changes is put away from a lot of problems. And perhaps then this newly open chapter will not think of having another conference. All these cancer abates. Fine. So I introduce with all due respects, ma'am, this chapter is opened and they have taken an international conference. Can you imagine to have national conference also? People say, nahi, 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 Baba. They have taken the challenge of international conference is something very, very great. So let's move on. Let's move on to our third speaker. How to build a new stoma and nursing care of a stoma patient, which is again very important for us because we know surgical intervention is very important. And in surgical intervention, you will have a stoma that's going to come up, and how are we going to manage? So I welcome my third speaker, Dr. Monica Sharma. She's Associate Professor at the Department of Medical Surgical Nursing, in charge Nursing College, AIMS, Bhatinda. I'm sorry for that. Okay, so she's affiliated with AIMS Bhatinda. Regarding her awards and honors, let's have a glimpse at what she has put in. She's received the Award of Appreciation for Exemplary Work and Behavior during posting in PGIMER Chandigarh by the then Cabinet Minister, Government of Punjab. She has various research paper presentations to her credit at national and international level. She has won 5 research awards at various national and international levels, and she has also done scientific paper presentation. She has interpreted and presented data in major research project titled Drug Abuse and Young Offenders in Punjab, Psycholegal Problem by Indian Council of Social Science Research, ICSR, New Delhi. She's a faculty instructor for basic life support. She's expert member of Board of Nursing Studies at College of Nursing. She's the expert member in Faculty of Nursing Sciences at BFUHS Faridkot. She's expert member of Research Development Committee at RDC Faculty in Nursing Sciences, same Faridkot. She has various areas of interest, and that's there on the display for you all to read. I welcome Dr. Monica Sharma. The floor is yours.
Thank you, ma'am. Thank you for such a warm welcome. And first of all, I would like to thank Principal ma'am and ONAI organizers, Vice Principal ma'am, to give me opportunity to deliver my lecture over here. And the topic which has been given to me is how to build a new stoma and nursing care of stoma. So before proceeding, I just want to share one of my very good teacher who had stoma, and she lived with stoma for 15 years. She was Mrs. Baljeet Kaur. She's no more. She was diagnosed with colon cancer in 2003. And she and her husband, she took care of herself in such a nice way. She has undergone 7 surgeries, in which twice colostomy was done, and in last ileostomy was done. And she had 4 openings on her stomach.
And she has managed all the openings, all the stomas so nicely. And she was the one who was taking care of her stoma herself. And in 2020, she died. And because of her care, because of care of her husband, they were able to manage. And Dr. Prabjot, he has means ma'am se mile hain ma'am, or she was such a enthusiastic lady. So I just want to tell you that what is the importance of colostomy and the stoma care. We can increase the lives, we can improve the lifestyle of the person, we can improve the quality of life of the person if we take very good care of these stomas. So what is stoma? So a stoma or ostomy, these two words means the same thing. These are used interchangeably. It is a surgically created opening on the abdomen which allows stool or urine to exit the body. There are three main types of stoma, that is colostomy, ileostomy, and urostomy. So when we are talking about intestinal stomas, then it is colostomy and ileostomy. And when we are talking about genitourinary tract stomas, then it is urostomy. So as I've told you, colostomy and ileostomy is a part of intestinal stoma, and cicostomy is also in rare cases. In urinary stomas, when a urinary stoma is created, the urine does not go to the bladder. The urine is rerouted through an opening on the abdomen created by a surgeon. And in this also, we have various types of stomas, that is vesicostomy, ureterostomy, and ileal conduit. So vesicostomy, it is the opening in the bladder, and it is created to connect the bladder to an opening on the lower abdomen. So directly from the bladder, this opening is given on the abdomen. And ureterostomy, as the name indicates, ureters, they are diverted towards the abdominal cavity, and urine is passing from the ureter directly outside the body. And ileal conduit, it is a type of pouch which is created with the help of the ileum, which is a part of small intestine, and there the urine is being collected, and after that it is expelled out. So these are the various types of stomas. So now here we are talking more about colon cancers and intestinal cancers. So intestinal stomas, which is, it can be temporary and it can be permanent. So as I've told you, ileostomies are there and colostomies are there. So talking about colostomy. A colostomy is an artificial opening made in the large bowel to divert feces and flatus to the exterior, where it can be collected in an external appliance. Depending on the purpose for which the diversion has been necessary, a colostomy may be temporary or permanent. So it depends, as I've told you, that means how patient undergoes various surgery when the person is having colon cancer or ileum cancer. So what happens, sometimes we need to do the permanent colostomies or the permanent stomas, and sometimes we need to do temporary, because once the anastomosis and all the surgical portion, it will be healed, then again we have to route the same path. So temporary stomas are also there and permanent stomas are also there. So there are various types of colostomies like loop colostomy, end colostomy, and double barrel colostomy. So we need to understand that what is the difference between these types of colostomies. So loop colostomy, this type of colostomy is usually used in emergency and is temporary and large stoma. A loop of bowel is pulled out onto the abdomen and held in place with an external device. So what happens in this? In this, we are taking the colon out, and we are not actually dividing the colon in two parts. What we are doing, we are taking it like a loop, and above portion is, we are dissecting it, and it will come like this. I'll show you the diagram like this. So this is the way how we form the loop. And if it is a temporary colostomy, then again it will help us to re-anastomosis it, and it again the passage will be converted into the normal passage. So the bowel is then sutured to the abdomen, and two openings are created in one stoma, one for stool and the other for the mucus. So one is for the stool, which is coming means from the mouth side, the canal is coming, that is for the stool, and other part is for the mucus. Next is end colostomy. A stoma is created from one end of the bowel. The other portion of the bowel is either removed or sewn or shut. And that procedure is called as Hartmann's procedure. So again, I want to show you the diagram. So this is the end colostomy in which we have taken the gut. Sigmoid colon we have taken out, and it is the end colostomy. Means we are not formulating any loop, but we have a end colostomy, means we have totally resected the colon, and end colostomy is being done and it is taken out onto the abdomen. And end colostomy is also called as Hartmann's procedure. When there is a large cancer in the colon, at that time we need to do the permanent colostomy. So this type of colostomy can be done in these patients. Next is double barrel colostomy. The bowel is severed and both ends are brought out on the abdomen. Only the proximal stoma is functioning. So here is the diagram for this. So this is the double barrel stoma. So we can see bowel is surgically served and two ends are brought onto the abdomen. And two separate stomas are there. So you can see two separate stomas are there, and proximal end. What is the function of that? It is the functional stoma from where the stool is coming out. And distal end is the non-functioning from where the mucus fistula is coming out. Right? So double barrel stoma is there, but we have dissected it and two openings has been formed on the abdomen. So it is used in temporary diversion cases where resection is required due to perforation or the necrosis. So sometimes a part of colon we need to remove. In those cases, we can have this type of stoma. So these are the three types of colostomy: loop colostomy, end colostomy, and double barrel colostomy. Next is the ileostomy. So as the name indicates, ileostomy, here what we are doing, we are taking the ileum out and suturing it onto the abdomen. So it is an artificial opening made between the ileum and skin of the abdominal wall to divert intestinal contents to the exterior without a sphincter to control the timing of its emptying. And effluent is usually liquid. So when we are talking about colostomy, effluent is more of solid form, but in this case it is more in liquid form. Can anybody tell me why it is happening? In ileostomy, why the stool is more liquid, and in colostomy, why the stool is more solid? Because in large intestine, water absorption is there. Fine. So when water absorption is there, so then we will have different types of colostomy. So wet colostomy will be there, dry colostomy will be there. If we will be doing colostomy on the transverse colon, then solidification will be more. If it will be on the ascending side, then solidification will be less. If it will be in descending side, then it will be more dry type of colostomy. So depending upon the level where we are doing the colostomy, or in the ileostomy, totally liquid stool will be there. So it will be depending upon the area where we are doing the stoma. So there are various types of ileostomy as well. Like loop ileostomy is there. It was similar as we have done in the colostomy. So loop is there. So in this also we are taking the loop out and we are not cutting the lower portion of the loop, but we are cutting the upper portion, and two barrels are being formed. And end ileostomy, in which we are cutting the loop, we are cutting the ileum, and it is totally dissected from the next part of the ileum. Then cecostomy, and it happens when there is trauma to the cecum or closed loop syndrome is there. So in desperately ill patients with advanced obstruction, we need to go for that. And the most common site for this is right iliac fossa. So these are the various types of stomas, intestinal stomas, which we do for the patients, for the cancer patient. They can be temporary, they can be permanent. If it is temporary, for a while, until the surgical site has not been healed, तब तक हम उसको use करेंगे. After that, we will again anastomose it, and again the normal pathway will be used. So how to differentiate a colostomy from the ileostomy? So as I've told you, site will be different. In colostomy, right upper abdomen and left iliac fossa, these are the most common sites. But in ileostomy, because it is on the right side, so right iliac fossa is used. Discharge from the colostomy, formed feces or feculent fluid will be there, but ileostomy, it is fluidy. Color of discharge, colostomy, brownish or blackish, and in ileostomy, brownish, greenish, yellowish, because of the presence of enzymes and bile in it, because they are not being absorbed till now. So because of that, it will be more of yellowish and greenish color. Odor of discharge, because more and less full stool is being formed in the colostomy, so very offensive. Excessive gases will be present. But in case of ileostomy, it will be less offensive. Stoma will be large, constructed, flush, or slightly elevated from the skin. So when we are creating the stoma, the formation of stoma will be different in case of colostomy, and it will be different in case of the ileostomy. That I will tell you why. In ileostomy, it will be small, constructed as a nipple-like projection above the skin. Reactions of this surrounding skin, so in colostomy, it will be usually normal. Usually normal because it is a solid material and it will directly come into the bag and it will not give erosions to the skin. But in ileostomy, because it is fluidy, so what happens? Erythematous and edema will be there and enzymatic digestion will be there, which will erode the skin around the stoma. Now, what is the principle of stoma formation? As how to, my topic is how to form the new stoma. So what is the principle behind this stoma formation? First is discussion. Discuss the possibility of a stoma with patients undergoing elective or emergency colorectal surgery. So first of all, we need to discuss with the family, with the patient, and between the healthcare professionals that what is the need of this stoma, whether it is very much required, and if it is very much required, then which type of stoma should be done, whether it should be temporary, whether it should be permanent, whether it should be ileostomy, or whether it should be colostomy. Then assessment by stoma therapist should be done. Assess the patient pre-operatively, lying down, sitting and standing. So we need to locate the site that where we need to do the stoma. Mark the best site for the stoma. Area should be easy to see and access. Avoid bony prominences like iliac crest and rib cage. Scars, skin creases, anticipated surgical wounds and belt line. So we need to assess all those things while going for the stoma, that how it should be created and it should not be uncomfortable for the person. Then coming to stoma creation, that is the third principle. Create an opening about the width of 2 fingers in anterior abdominal wall. So all the stomas, they are being created in the anterior part of the abdomen. Deliver well-vascularized, tension-free segment of bowel through the rectus abdominis. Close any other wound if it is surrounding. Open bowel and secure to skin with evenly spaced absorbable sutures. So now, when we are creating this stoma and we are using the ileum, means we are doing ileostomy, then what we need to focus? Ileostomy effluent is liquid, frequently at alkaline pH. Contains activated digestive enzymes, discharge almost continuously, excoriates and digests the skin. So keeping in these things in mind, we need to create the stoma. So for creating stoma for ileum, elevate the ileostomy opening 2 to 3 centimeters from the skin to ensure the effluent passes directly into a stoma bag with minimal contact with the skin. So हमारा क्या principle है, क्या हमारा focus है कि ileum को हम इतना बाहर लेके आए कि जो उसमें से fluid बाहर आ रहा है, stool, liquid stool बाहर आ रहा है, it should not touch the area around the stoma. So ileum is everted on itself to form a spout, and I'll show you like this. So the length of the ileum which is taken out and it is folded back onto the abdomen, that is large. Then the colostomy, that is 2 centimeters, and spout is being formed. So when fluid will come or the stool will come, it will directly pour into the bag. Then stoma creation for colostomy. So colostomy effluent is, it is more or less feces, discharge intermittently, not directly corrosive to the skin, and usually falls directly into the stoma bag. Because when it is a liquid, when we are talking about ileostomy, so frequency क्या है उसकी? It is dribbling all the time. But in this case, when the stool will be formed, it will be intermittent. So this is the way how we form the stoma in case of the colostomy. So formed feces is there and it will directly go into the stoma bag and mucosa is level with the skin. So the जो spout हम इसमें बना रहे हैं, that is not like ileostomy, but it is smaller than the ileostomy. So from here also we can see these are the various sites of the ileostomy and the colostomy type. So in ileostomy it is on the right side, and colostomy it can be ascending colostomy, it can be transverse colostomy, it can be descending or sigmoid colostomy. And as I was telling you, ascending colostomies, these are wet colostomies because here the stool is still liquid. Then transverse colostomy and descending colostomies, these are the dry colostomies. So according to the location also, we need to see that how we need to formulate this stoma. Now, what makes a stoma difficult? When we are planning to make the stoma, that what are the things which makes us, which are the hindrances in our path? First is poor planning, टेक्निकल एरर्स एंड डिफिकल्ट पोस्ट ऑपरेटिव मेंटेनेंस. सबसे पहले हमने प्लान ही ठीक नहीं किया, हमने जो साइट चूज की दैट वाज नॉट करेक्ट. टेक्निकल एरर्स ड्यूरिंग द क्रिएशन ऑफ स्टोमा वी हैव नॉट टेकन केयर, एंड later on when stoma was created, it was on the well site, it was very good, operation was done, but post operatively we have not maintained. So we can see that if it is more towards the suture line, then it is an imperfect location. But stoma is perfect. So we need to see stoma should also be perfect, location should also be perfect. So here difficult stoma is there. So we need to see we need to recognize the individual also, that which type of stoma can be created in this particular individual. So preoperative consideration, location, location and location. So does this person really need this stoma? That we need to understand. Quality of life issues कैसे रहने वाले हैं? Elective versus emergent. We need to do it, or electively we can plan it, or in emergency we need to do it. Education, we need to educate our patients and the family members to cope up with that condition. And will this be reversed? मतलब हम उसको, that will be permanent or that will be temporary, how we are going to manage it if it is a permanent, and how we are going to educate our clients or our patients that it is going to be permanent. So proper sight. So how to properly sight a stoma? First, examine abdomen with patient clothed. Examine exposed abdomen with patient supine, standing, sitting and bending over. Identify skin creases, folds, skin problems, scars, bony prominences. Draw imaginary line where incision will be. Choose 0.5 centimeter away from the incision with 5 to 7 centimeter of flat surface. Identify and mark edge of rectus muscle. So all these things we need to identify to see what is the site. So mark the site with the X. Initially, जब हमें operate करने जाना है, we need to mark that area that where we are going to do the stoma. Choose an area visible to patient but below the level of the belt line. So examine, mark with the patient supine, standing, sitting and bending over. So in all the position we should see that person should be comfortable, and mark and cover with the tegaderm, and then we need to send the patient to the OT. So this is the most common ostomy triangle, means most common ostomy should be done in this triangle. If it is not feasible, then we can change the position because of any incision or because of any previous surgery, but this is the most common site. Then special consideration, if obesity is there, ventral hernia, multiple stomas, prior stomas and lifestyle. So these all considerations we need to take into consideration, like person should not be having difficult stoma because of the previous history. So criteria taken into consideration when positioning a stoma: first, away from any bony prominence, away from the umbilicus, away from any previous surgical incision, visible when the patient stands and comfortable for the patient. So again, it is written that it should be comfortable for patient in all the positions. So better to create an ugly stoma in a good location than a pretty stoma in an ugly location. Fine. So remember, pre-operative planning, operative technique, post-operative education are of vital importance. Make every stoma as though it were going to be permanent. Because when we are creating the stoma, we don't know that it is, means, let's suppose we have planned for the temporary stoma, but later on, after the surgery, after when we were about to anastomose it back, again the reoccurrence of cancer is there. So it means we have to continue with that stoma. So every stoma should be created in a way then it can be a permanent stoma. So ostomies should have an ostomy bag in place. So once the stoma has been created, ostomy care should be done. Depending on the location of ostomy, may produce liquid or solid fecal matter. Digestive enzymes may corrode skin around the stoma. Ostomy site should be pink or red, and most pouches can be emptied without the removal. So when we are going to do the ostomy care, we need to see ostomy, location, temporary, permanent, all these aspects we need. For that, we have ostomy bags, which we use for the stomas. So stoma appliances are there. Protective skin barriers we are using to, means those bags should be intact on the skin. It remains on the skin between bag changes and needs to be changed every few days. And pouches, closed-ended pouches may be there, and drainageable pouches should be there. So ostomy care is one of the most important aspects. Once you have created the stoma, it is at very good location, it is very well created, but if you are not maintaining or you are not giving good care to the ostomy, then again complications can arise. So attachment of stoma appliance, gently clean the stoma and peristomal skin. Dry the peristomal skin and apply filling paste on it. Cut the central hole of the skin barrier to match the diameter of the stoma. So we need to match the diameter of the stoma bag with the colostomy. It should be slightly bigger than the stoma so that it should enter over the stoma and it should get fixed up. Remove the sticker of the skin barrier. Fix the skin barrier to the peristomal skin. So this is the way. Fix the pouch to the skin barrier and clip the other end of the pouch. Finally, apply plaster around the skin barrier. So it should be well fixed. It should not be leaking or any this type of incidents occur. Then again person has to clean the area and again he has to fix the bag. So attachment of the stoma appliance you can see. And last, prepare for drainage and always document the procedure. And whenever there is leakage inside the bag, inside the skin and the bag, then again we have to remove it. Otherwise, it will be excoriation of. Sometimes we need to go for the colostomy irrigation also if there is some impaction or there is some other complication. So normally it is done in patients with permanent colostomies only, who need bowel preparation for special investigations like colonoscopies or some other procedure, usually done after 1 year of stoma creation, because till that time it is not properly matured. Take about 45 minutes, but in certain stomas it is contraindicated. So we should not go for the irrigation like ileostomy, ascending colon stoma and transverse colon stoma. So in this also, what we need to have 1.5 to 2 liter of lukewarm water, reservoir bag should be there, a tube with a controller and a funnel shaped introducer which prevents damage to the stoma. 2 clips to close the bag and bag to discard the feces. So this helps in the irrigation. This is the way how patient can irrigate the stoma for any procedure or if it is an impaction of the. So if not maintained, if ostomy care is not given very well, then there may be various complications. So early complication like ischemia and retraction can occur. Late complications can occur like stenosis, prolapse, parastomal herniation, obstruction of small bowel, hemorrhage, diversion colitis, dermatitis, and psychological issues can arise. So there are various studies which has shown there are various complications. Aortic and non-functional stoma. That one is the good stoma. This bad stoma can occur due to impaired blood flow. Bleeding can occur because of the excessive cleaning of the stoma. So we need to बहुत ज़्यादा भी उसको जोर से या manipulate करके we need not to clean it. retraction can occur. Retraction means stoma can go inside. But हो सकता है. Herniation versus prolapse. So herniation means whole of the stoma, it is coming protruding out. And prolapse is when the part of the ileum or the colon, it is coming out, then it is a prolapse. This is prolapse stoma. Not be so long. It is retracted stoma. It is sunken in stoma. It is erythematosus skin. Around the excoriation is there. So excoriation of the skin we need to prevent. So for excoriation, what we need to do? We need to do proper cleaning and proper ointment should be used so that excoriation can be. Like educate the patient about appliance change. Consider a two-piece appliance to allow healing. Stoma adhesive powder or paste. Not use antiseptic for cleaning peristomal skin and change the base plate as soon as it leaks. And a methyl cellulose skin vapor is helpful in this. Advises as physical exercises. If even person is with stoma, physical exercises should be done. So person need to ask from the doctor that which exercises that person can perform. Nutrition and advices. Regularly, person should be eating, but some things like beans or some nuts, they are, if they are, doctor is not advising certain things, person should not take those things according to the position of the stoma. Intimacy and relationship. So for that also, person should take advice from the doctor that how the person can have the normal and healthy sex. Summary, maybe colostomy or ileostomy, may be temporary or permanent. Temporary or dysfunctioning stomas are usually fashioned as loop stomas, and ileostomy is spouted stoma. Colostomy is a flush stoma. Ileostomy is effluent is usually liquid, whereas colostomy effluent is usually solid. Ileostomy patients are more likely to develop fluid and electrolyte problems. So considering all these things, we need to give care to our patients who are with colostomies and intestinal stomas. That's all related to the topic. Thank you so much.
So I think now everybody is exhausted with such a elaborate this thing discussion on the topic of CA colon. So Dr. Rita has made things very easy for me by summarizing first two speakers. So coming to the third speaker, Dr. Monica Sharma has beautifully discussed the different types of stomas, whether it is end colostomy or it is then loop colostomy or it is an ileostomy. So our patients, we do come across colon patients, and whenever the surgeon advises for colostomy, patients are usually reluctant of getting stomas on their body. So our duty as physicians and nursing staff is to convince the patient regarding the importance of stomas. So, and the best thing is to educate them. And I think everybody will be more wiser in this after listening to this beautiful lecture given by Dr. Monica. So how to to discuss the types of stomas and how to take care of the stomas. So you all must be now more this thing wiser by her lecture. So I thank all the three speakers for a beautiful discussion about cancer colon. I would also congratulate our nursing department for organizing such a beautiful conference. So once again, congratulations.
So it's the time for honoring now. I would like to invite our chairpersons, Dr. Meena Sudan ma'am and Dr. Rita Lakhani ma'am, please come over the stage and honor our speakers. I invite our first speaker. Yes, Dr. Saurabhi Mondal, please come over here and receive your honor. Okay, sorry, Miss Saurabhi. I request Dr. Parvez Saini, Principal, College of Nursing, please join, ma'am. I request our second speaker, Dr. Pradzol Saini, ma'am. I request Dr. Manpreet Kaur, Vice Principal, College of Nursing. She also come and join the stage. Dr. Monica, ma'am, please come forward and receive your honor. Navneet, aa jao. So kindly have your seats. So thank you, Principal ma'am, Vice Principal ma'am, our chairpersons and all the speakers. So they have sparing their valuable time and shares a vast knowledge with us. Next, we are moving towards our third session on teenagers cancer. So for that, I will introduce our next anchors, Navneet and Miss Sonia. So I'm handing over the mic to these.
Thank you, ma'am. Thank you, everyone.
Ma'am. Good afternoon, everyone. Now we are moving towards our third plenary session that is about teenage cancer.
So I will introduce our chairpersons, Dr. Meena Sudan, HOD SGRD Rotary Cancer Hospital, Valla, Shri Amritsar, and next Dr. Nimesh Kumar Dave, Principal, Government College of Nursing, Ajmer. So I would like to request Sir Nimesh Kumar, please come on the stage and share your views. Please, big round of applause.
लाइट कैसे चेंज होगी? It's a great opportunity for me to introduce the person who has set the milestone. Especially, we are here for the topics related with the oncological nursing. And as I am talking, that the person who has set the milestone, the opportunity, I am going to introduce her. Ma'am Anita D'Souza, the professor cum principal, MSc Nursing in 1999 she has done. She has done postgraduate diploma in the educational management certificate course and pursuing now the PhD in nursing. Oncological nursing, when we talk about the oncological nursing, only one general I see. Whenever you are going for the searching, that any journal is being published in India, only the one nursing journal you can see on the Google. That is in India, Oncological Nursing Association of India, that is publishing. So this is the, I think, when the one more topic that is related with the teenage. You are all are going through the teenage. So the topic will be interested for you also. What she has not done, when we are talking about the ma'am Anita D'Souza, she has done lot of things in the nursing field. She has contributed in the research sector also, conducted so many researches, and the position she held in nursing, the Secretary, Oncological Nursing Association of India. She is executive member in Indian Association of Supportive Care in Cancer. So now I am going to invite the ma'am on the floor for the topic. Thank you, ma'am.
Good afternoon, all. I know I'm talking at a time which is just the pre-lunch, but I guess those who are here in the auditorium are not feeling really very hungry. So let's shortly look at, what is the experience of nurses when when they care for teenage cancers. Okay? This is a typical, the teenager that you will look at. Sometimes they're very bubbly, very enthusiastic, very overactive, and suddenly you will find their mood being changed. Okay? So that is a typical picture that we have in our minds about the teenagers. So now actually we no longer call them as teenagers, but this particular group is actually grouped under as adolescents and young adults. So which is the age group from 10 to 39. But what we are looking at is a teenager. And what I'm going to basically talk about is a pediatric population, or the population that ranges from 10 to 20. Because even at that time, the children as young as 10 years old will start exhibiting characteristics that are similar to the teenagers that we were talking about earlier. So when you look at the pediatric age group, that is a younger age group, the cancers are basically of embryonic origin. And when we look at the adults, that is the young adults or the adults for that matter, the cancers are mainly of the epithelial origin. And these teenagers or the adolescents are the ones who are the bridge between the childhood and the adults. And therefore, they have the tumors which are of the mixed type. Some of them will have epithelial, some of them will have embryonic. And because of this nature of their cancer, there is an heterogeneous response to cancer therapy. So if you look at the age group between 10 to 20, and if you look at the psychosocial development of these children, we see from the age 10 to 14, there is a shift in attachment. That is, these children who were very attached to the parents earlier now start getting, start developing attachment towards their peers. So they, slowly they start detaching themselves from the parents and start getting attaching to the peers. Those who have children will surely, identify this statement of mine. Then from 15 to 17 years of age, they start having their own self-image. They say that I am like this, okay? And now they no longer tend to listen to others and follow the instructions. There is a sense of achievement and power that they develop. There is an experimentation. They want to experiment. And very importantly, they start having logical thinking, and there is an increased ability to think abstractly. Okay, so this is something, they start questioning, they start asking, and they start forming their own opinions. And from the age 18 to 20 years, which is a later age in the adolescent period, there is an awareness of oneself and others. And here they appreciate the meaningful relationships. And at this stage, they want to have relationship even with the people of the opposite sex. So if you look at this particular age group, actually it's a time of unfinishedness. They have neither, children nor adults. They're somewhere in between. And there is a lot of confusion with regard to their role. If you look at the body, the physical characteristics of this particular age group, the body also starts changing drastically. There is an entry of these children into the puberty. There are many physical as well as emotional changes. And this is mainly because of the hormonal changes that are occurring in these individuals. And the change happens right from physical appearance, personality, as well as the behavior. Now, when these adolescents or these young children or teenagers are faced with cancer, it is not very easy for them to take, because at one time, they were all very fine children, and now they have entered into the journey of cancer. Many of them, you will find that they were absolutely fine. Okay? And they were having certain symptoms which could be regarded as normal or something, maybe viral infection or maybe just a pain which related to their normal growth. And suddenly when they do investigations, and they realize that it is nothing of that sort, and it could be a malignancy. So it actually comes as a shock. And that's the reason the way they behave when the cancer is being diagnosed is something which is very difficult, because this response of theirs to the diagnosis of cancer is also very mixed. So the journey of cancer basically begins like this. There are symptoms. The investigations are done because the symptoms are not very typical of the usual diseases. Then there is a diagnosis. Then there is treatment. There are the side effects related to the treatment. There are repeated admissions because of the side effects of the treatment. And ultimately, the patient or the child or the adolescent either survives the cancer, or the child goes on to the end of life care. And during this entire journey, the child and the parents with them, they face a lot of uncertainty, and there is always a facing of reality of death throughout this journey. Now, these children have suddenly entered into the kingdom of sick. The children were absolutely normal. They were with their peers, they were enjoying their school, college life, and suddenly they have entered into the kingdom of sick. And now, here they start feeling distance from the normal life into the trajectory of cancer. The family, which was actually, which was normally functioning, now this family life turns where the diagnosis, prognosis, and treatment becomes in the forefront. There is a lot of social, emotional, and developmental difficulty for these children as well. There is, the family will have, initially there was the illness in the foreground, and there is wellness in the foreground. And the children and the family is actually shuttling in between. And what is the role of a nurse is basically helping them to balance both the things with instilling hope and humor. Now, what are the stages in the experiences of cancer trajectory for these teenagers? First thing is the exploratory stage, where there is recognition of symptoms and there is diagnosis, which is extremely difficult for both the child as well as the parents. Then there is a stage of crisis, where the treatment is initiated. And as we know, the childhood cancers or teenage cancers, we say most of them are curable cancers, and that's the reason why we treat them very aggressively. So here the treatment is initiated, and naturally the child is going to face the effects that are related to the treatment, and therefore the child or the parent, the teenager starts experiencing anxiety, depression, altered body image because of the treatment, and also certain treatment related effects such as alopecia or the skin changes. Children may have to undergo amputation or some kind of a surgery, and there is also concern about the changing relationships. Then later comes the phase of either adaptation or maladaptation. There are some children who adapt that to the treatment, and they carry on with the treatment. But there are some of them who are not able to adapt, and they start showing the symptoms that may not be very normal, and therefore the children may have to be referred to the psychologist. And lastly, there is a resolution or disorganization phase where the child or the teenager faces the long-term sequelae as a result of treatment and the disease. So when the child comes, what is the response, or how do we see these children behaving as? One thing is they are withdrawn. Okay, the withdrawal is basically as a result of their inability to comprehend what is happening. So here, what has happened was that the child, was able to logically think, and now here what happens is that the child doesn't want to ask the parents, the child doesn't want to ask the healthcare workers also. So what happens? The child actually doesn't have adequate knowledge, and they're unable to comprehend as to why this thing has suddenly happened to me when I was absolutely normal. So that is the time they actually go through this symptom of withdrawal. There is a lot of stress that is experienced by these children. The stress may be as a result of comparison with the peers, because they see their peers or their friends are now going to the college, they're going to school, they go to play, they meet each other, but this child is not able to do all those things because of various reasons. So that puts them at stress. Second thing is there is a risk of appearing different, because we see that many of the children, they develop either leukemias or they will have bone and soft tissue tumors. So they may have to undergo amputation. Because they are treated aggressively with chemotherapy, there might be weight loss, there might be hair loss. As a result of treatment, the patients might gain weight. There might be skin changes as a result of therapy. They also may be stressed because now it causes burden on the parents, because the parents have to probably leave their job or take leave, be with the child, and spend a lot of money on the treatment. They also may be stressed because of the reaction of peers. Now what happens is that the child has got his friends who are of the same age, who also do not have adequate knowledge. So what happens, the peers of these children tend to react in a way that they distance themselves from the child who is not well, because of the fear of contracting cancer. They don't understand that this is a non-communicable disease. So that also will cause stress on the child. And of course, the finances is another thing. The child also experiences a sense of threat. Okay, why the sense of threat is there? Because earlier the child was trying to become independent of the parents, and now here the child has to depend on the parents, because the parents are the ones who are going to take the child for the treatment, spend the money, be with the child, take care of all the adverse events. So there is the sense of dependency is something which puts them to feel threatened. The autonomy is also threatened, because here now because the child was shifting towards the peers and was trying to become autonomous with regard to taking their own decisions. Now this same child has to depend on the parents with regard to the initiation of treatment, what treatment has to be undertaken, and things like that. Next thing is that the decision making, because now here the child is no longer a decision maker, it's the parents who are a decision maker. Though we say from the age of 14 we need to take the consent of the child into consideration, but as far as law is concerned, it's only after the 18 years of age. So legally it is the parents who are making decisions, and that puts the child at a feeling where he starts feeling threatened. There is a lot of sense of unfairness and anger because of uncertainty of the events, because they don't know whether they're able to come out of the disease process, or they will what would be the sequelae of the treatment, or they're going to lose the battle with cancer. Of course, the dependence on parents, and also there is a lot of anger because of the repeated visits to the healthcare setups. Because what happens is that these children are treated, when they're treated with chemotherapy, they develop side effects related to the chemotherapy. And these children may have to visit the healthcare facility apart from taking treatment to deal with these problems related to the therapy. And that can also make them very angry. We see many children having a problem with the adherence of treatment. They don't adhere to the treatment. There is a non-compliance with the supportive treatment. Supportive treatment could be like, in the form of diet. It could be in the form of exercises. It could be in the form of not doing something and doing something. The children do not adhere to the treatment, and that is why they come with a lot of problems. We know one child, who had undergone surgery for bone cancer, and he had 17 surgeries after that because the implant used to break, or he used to not follow the whatever advices he's been given with regard to the activities. Okay, and that is what is another issue that we face with the children. Risk-taking behavior. I told you, we tell them don't do certain things, they will not listen. They will continue doing things that we have told them not to do. Lack of communication. I know one of the children, who was some like 18 years old, colorectal cancer patient. We told him that you need to eat well because he was receiving 5-fluorouracil. Not eating well, the child was absolutely, he was like totally emaciated, and we had to admit him and put him on the oral, the IV fluids. Okay. Then lack of communication. They don't communicate neither with the parents nor with the healthcare workers. So what happens is that we do not know what they know and what they don't know, and we are unable to guide them accordingly. And because of which, again, that leads to non-compliance or leads to the complication. They also do not adhere to the clinical trials. We have clinical trials where we sometimes, the children are an eligible group, or it is involving the adolescents. And when we put them into the clinical trials, they may not adhere to the trial instructions, and that can put us at a difficult situation as well. Next thing is fatigue. The fatigue is a phenomenon which is very, very less commonly studied by the physician and the healthcare workers. We all think fatigue is experienced only by the adults when they are receiving cancer-related therapy, but it is not true. The children also experience a lot of fatigue. They actually feel absolutely knocked down after they have received even 1 or 2 cycles of the therapy. And the fatigue can also be because of the treatment and the emotional overwhelming, because they're so emotionally overwhelmed with the entire experience of diagnosis and the treatment, and that puts them at a problem or developing the issue of fatigue. Body image disturbance, that's another issue. This body image disturbance is a disturbance that children usually experience when they go back to their routine life. What happens, as I told you, that most of the children or the childhood malignancies or teenager malignancies are curable. So what happens is that once they have been cured, or once they have been, we know that the disease is under control, they're disease free now, they can go back to their college or the school and they can continue with their academic activity. Now, if during that time they go back to the school or a college, when the other children look at them because of certain physical restrictions, like if the child has undergone amputation, the child might have some kind of difficulty in walking or doing certain activities. Everybody will look at them. And this puts the child at a very vulnerable position. Hair loss. So the children lose hair when they are on treatment, and once the treatment is over, they start getting the hair back. But the kind of hair that they get may not be the same as they had earlier. That again disturbs the body image. Skin changes. Some of the children might have the skin changes in the form of having hyperpigmented skin. Though gradually it starts reducing and the skin, but it is never the same as it was at the time of before the treatment. So that is again disturbs the body image. There might be weight gain in the children because of the hormonal issues. Then the effects on the growth because of the metabolic syndrome. Like the children can develop metabolic syndrome, maybe some kind of thyroid issues. So this can also, and also that there can be some effect on the growth of these children. Some of the children might have stunt. All these issues will actually cause a body image disturbance, and the results or the effects because of the body image disturbance are likely to stay for a very, very long time, even after the treatment is completed by the teenager. There is fear. There is fear in the form of changes in future, because the teenager probably would have had many dreams or many aspirations as to what he or she would do. Now the child thinks that he will not be able to do these things. So there is a fear of changes in future, that he may have to change his decisions. Returning to school, because the child doesn't know what is going to be the reaction or the acceptance of the child by his or her peers. Loss of childhood, because what happens is that a treatment like ALL, it might even go on for years. A treatment of bone cancer might again go on for years. So the returning to the child, the loss of childhood, the child thinks that I have lost my childhood now, and that is also puts fear into the mind of the changes in body, the fear of potential death. Though we say that the child is now a survivor, but yet there is always a fear of death which is lurking in the mind of the child as well as the family. The fear that the body will never return to its original appearance, and the fear that they may not be recognized by others as normal individuals. There is depression in these children. Okay, the depression is because of insight, the understanding of what is at risk, what is lost, and what may never be. And that's the reason why the children are they feel very depressed. And let me tell you that many of the children will never verbalize that they feel like this. They will just show the signs, and we as healthcare workers, we need to understand it, and we need to treat them, because even if we tell them that you need to go to the counselor or a psychologist, they will never accept those suggestions. So we need to handle them very, very carefully when they're going through this stage of depression. There is a lot of feeling of vulnerability. Let me tell you that the children feel extremely vulnerable, and this vulnerability feeling results in the poor communication. They think that if I express my feelings, then I will be, I will become very vulnerable, and somebody else will take advantage of those feelings. So that because of those feelings, they will not communicate with the parents or the family or the healthcare workers. They feel vulnerable to the illness even though they are healthy now, because these are like, they understand few things about cancer, and they also know that probably there might be a relapse. So they feel that even though they are healthy now, but yet they are vulnerable to other illnesses as well, like, maybe opportunistic infections or things like that. There is a fear that the cancer may come back anytime in future. And there is a fear of secondary cancers, because we know that people, when they receive chemotherapy, radiation therapy, there is a fear or there is a possibility of having a secondary cancer later in their lifetime. Now, some of the children also adopt. Okay, many children adopt. Because why? Because now they have understood, like someone said yesterday, like, it's a second life. When they understand that they have cancer and they have recovered from cancer, it's a phase where they think that it's a second life, and they want to take full advantage of that second life. And that's the time when the adaptation actually sets in. So there is an increased confidence and psychosocial maturation in this children. The children start appreciating life. Every small thing, every small joy in life is being appreciated by these children. They maybe, like, some of them, the hair is lost, they want to use wigs. But in our hospital, we see, because we are a hospital which is a totally cancer hospital, they see many others who have alopecia. So they may not want to use wig. Many of them actually don't use wigs, and they are okay with not having any hair at all. They rely a lot on the positive feedback from the friends and the family. They have a desire to feel normal. So they start taking part into even activities which are recommended, like children who have had implants after the bone cancer surgery, though not very heavy activities, but they start taking part into, certain sports which are not very, which will not be very damaging for their implants. Then they are very resentful to sympathy and pity. Let me tell you that the children do not want any sympathy and pity, because they feel that the moment you show them sympathy and pity, they feel that they are being, treated as something below you. They do not want it. Actually, we've had a certain last maybe 2 or 3 months back, we've had experiences of teenager cancer patients, and all of them said that they do not want sympathy. Okay? So we need to be careful before we actually show them sympathy and pity. There is an anger because of delay in diagnosis. As we know, when the cancer is struck, there are a lot of battery of investigations that the child has to undergo. And during this time, the child can get really upset, and there might be anger because they cannot put up with so much of time. There may be anger with parents because, as I said, that some of the cancers are embryonic, some of them might be hereditary. So they think that the parents are the ones who are responsible for this cancer diagnosis and the life thereafter. anger because of the dependence on others, and the restrictions that are placed because of the disease and the treatment. There is a feeling of uncertainty. Okay, this uncertainty may be probable, temporary, and perceptual. There is an ambiguity regarding the state of the illness and the symptom. There might be complexity of the systems of care and treatment. We know cancer treatment, the systems are very complex, and the treatment is also very complex, because we want to make sure that we are giving the right treatment to the patient, and for which reason the patient may have to undergo complex diagnostic procedures as well as the treatment possibilities. There may be lack of information about the diagnosis and the seriousness of illness, and unpredictability regarding the disease process and the prognosis. The children feel lonely and disconnected. As I told, many of the children's peers, their friends, they don't want to come near the child, and they start discussing about among them. So what happens? This child feels very lonely and very disconnected from the other world. There is an ongoing battle with the emotions, because they are not able to understand their own feelings. They are drained. They are fatigued by their continuous feelings and the thoughts that go on in their mind, and fighting one's own feelings. There are children who want to fight against the negative feelings that they experience because of the disease, and in the process of fighting those negative feelings, they start feeling very emotionally drained. The self-concept is also at stake. Okay, they start, because of all these changes, amputation or hair changes, skin changes. Sometimes some of the children also might develop the cognitive difficulties. Okay? And this all problems, which are likely to remain even after the treatment is over, start, having, the child starts having the doubt about their own self-concept. Now, when a child who has survived this entire process or the process of cancer still do also experience the problems. One thing is, there can be a post-traumatic stress. The post-traumatic stress can be to an extent that even for other small small health issues, they do not want to go to the doctors, because they've had too much of hospital visits and doctors' treatments, diagnosis. But they don't want to go back for any problem to the doctor. So that could be something like a post-traumatic stress disorder. Even though the treatment is over, the children continue to experience fatigue for many, many years, even after the treatment is over. There can be certain physical signs of cancer and treatment. As I told you, maybe amputations or implants, or they've had those central lines put in, the signs of central line which were put in, okay, the scars might still be there. There might be cognitive difficulties in some of the cancer children, and there might be difficulty in transitioning into adulthood. And apart from that, these children also, once they start understanding, they also start having questions in their mind with regard to fertility, the family, childbearing, etc., etc. So in conclusion, I want to say is that adolescent cancer patients face many psychosocial challenges. The manner in which healthcare professionals manage them may influence the overall outcome of the patient. Any questions?
Thank you for the one interesting topic. When everyone was feeling hungry and taking the third or fourth lecture, it's very difficult for the audience which is going in the teenage. So distraction is the very big factor, and still the ma'am manage the things very honestly and very interestingly. Thank you very much, ma'am. The factors he talked about, that these are totally related with my age group also, because I am having the children of this age group as well as you also. So there are so many things which are going normally. Whatever she talked about, that factors which are contributing the cancer related treatment, the same thing are going normally also in this age group. And how to manage them. The one more thing she emphasized, that the secondary prevention has a big role, and the nurses deal with that, and it can be prevented, or it can be reduced by the early diagnosis. And the most of the cancer which are found in the this age group, they are totally cured. So these things can go through in the mass in the gathering, in the viewer, in the general public, that the hope is also there. So thank you very much, ma'am, for the interesting topic. And the second, so you are to stay for more time also here. Okay. The speaker whom I am going to introduce, I know him very well since 20 years back. And when I want to talk about the psychiatric personality, who has a specialization in the psychiatric field, most of you think that the person who is having or who is adapting who is electing the psychiatric field, they are also having some type of psychiatric something. But the person whom I am going to introduce, he is really belong to that field, and how to behave in the mass age group, how to behave with the person, how to behave with the patient, how to with the peer age group. That all the things can be seen this person, and how to influence other type of person. So Mr. Sushil Maheshwari, please, floor open for you.
Thank you, everyone. Thank you, boss. Very good afternoon to all of you. All the faculty members, delegates, organizers, principal madam. First of all, I would like to thank organizers and ONAI for giving me opportunity to interact with you, as well as inviting me on this tour. The topic which is given to me is, of course, the topic of psycho-oncology. The topic of psycho-oncology. बैठ जाओ, मजे करेंगे आधा घंटा. आ जाओ. I am a teacher of psychiatric nursing, and I always believe in mental health. When I was going through the literature while preparing this presentation, I came to know that stress causes cancer. Stress causes cancer. Indirectly, not indirectly, directly. There are so many types of cancers which are due to stress and behavior issues. So, being a mental health professional, I always believe in mental health. And if the person is mentally healthy, definitely everything is going to be all right. So, as you all know, adolescent is the age of energy and courage. It's the age of whatever you want to do, give it thing to the adolescent or adult person, they will do. कोई गल नहीं जी हो जूगा. पंजाबी च कहंदे ये काम कर दोगे कोई गल नहीं जी हो जूगा. Okay? So it's a time, it's a period of energy and enthusiasm, courage, risk-taking behavior. And we consider this age as a 12 to 19, 18 years of age. But unfortunately, if some person who is in particular age group suffers from cancer, which is a life-threatening disease, it's a very challenging time because the person has to deal with the two issues simultaneously. There are several physical and psychological changes occurs during this time. The first and the second things are associated with the disease itself. So it's a very difficult time. And it also affects the person's psychological, functional and social areas of life. Although already discussed by yesterday Madam Manpreet that the statistics and epidemics of cancer. But still, I would like to quote one data that approximately 4 lakhs children and adolescents diagnosed with cancer every year. And if we see the types of cancer which happens in this particular age group, the CA breast is the most common cancer, followed by lymphoma, melanoma, and other types of cancer. So this is what the common types of cancers which happens in this age. Now coming on the psychosocial issues. Severity and the types of psychosocial issues related to cancer depends on 3 factors. The first is the type of diagnosis and the prognosis of the disease, as well as staging. At what stage the cancer is. Is it in the first stage or the 4th stage, whether it's the benign, malignant, advanced stage, like that. The second factor is available social support system and the environment with the particular person. And the third factor is individual strength. Uski khud ki kitni ताकत है. How person is mature and psychologically fit to deal with the crisis which just now he came to know. So these are the 3 factors which influence the severity of the psychological distress. देखिए जो physical distress है because of the disease, वो तो आना ही आना है. Okay, suppose CA breast है या CA testes है या lymphoma है, और भी कोई भी कैंसर है, जो डिजीज के कारण होने वाले फिजिकल प्रॉब्लम्स है वो तो जो होनी है वो होनी ही है. साइकोलॉजिकल इश्यूज टोटली डिपेंड्स ऑन द थिंकिंग ऑफ द पर्सन, हाउ द पर्सन इज थिंकिंग, हाउ द पर्सन इज टेकिंग द इश्यू. ओके, डेफिनेटली in the beginning everyone will take it negative because it's a crisis situation. So these are the 3 factors. Other than these factors, different psychological issues happens at different phase of the cancer. If we see the different time frame or the phases of cancer, I am dividing on the basis of time duration, that is at the time of disclosure of diagnosis, at the time of treatment and follow-up. So the different issues arise at the different phase of the cancer. So in the beginning or the disclosure of diagnosis, the first issue will shock. कौन सा shock? Psychological shock. Okay. Then disbelief, which is denial, uncertainty, mixed anxiety, depression, insomnia, irritability. At the time of treatment, again anxiety, depression, insomnia and all. So these are another way of explaining. Now I am coming directly on the what are the common psychiatric and psychological issues which happens with the cancer patient. This is a big list. So I am taking few of them. The first is issues of uncertainty. सबसे पहला आता है. इससे भी पहले आएगा denial. What is denial? मुझे कैंसर नहीं है. Recently, the last 1 year, one of my very close family member is diagnosed with particular cancer. So the first thing which came into my mind, go for the second reporting. Go for the second reporting. क्यों ऐसा कहा? Denial. ये नहीं हो सकता. Yes or no? Denial. 1 रिपोर्टिंग, 2 रिपोर्टिंग, 3 रिपोर्टिंग. जब थोड़ा सा टाइम मिल जाता है 1 वीक का, थोड़ी सी एक्सेप्टेंस आने लगती है. ओके, वो 1 वीक बहुत क्रूशियल है उस पेशेंट के लिए, उसकी फैमिली मेंबर्स के लिए. तो द फर्स्ट थिंग इज डिनायल. ये हो नहीं सकता. रिपोर्ट गलत है, लैब गलत है, दूसरे डॉक्टर के पास जाएंगे, गेट सेकेंड अनदर रिपोर्ट, बायोप्सी कहीं और से करवाते हैं. दीज आर वेरियस. एवरीवन इज द सेम फीलिंग. आई होप कि ये होता है सबके साथ. लेकिन अल्टीमेटली जब सेकंड रिपोर्ट भी हो जाती है, थर्ड रिपोर्ट भी हो जाती है, तो डिनायल धीरे धीरे कम होता है. द पर्सन गोज इनटू द एंगर. वो डाबडा याद है ना, DABDA, दैट इज द बेस्ट. ए फॉर एंगर, गुस्सा आता है. बार्गेनिंग आती है कि मुझे ही क्यों हुआ, मुझे ही कैंसर क्यों हुआ, मैंने ऐसा क्या किया, मैं तो बिल्कुल बाहर का खाना नहीं खाती, मेरी तो हेल्दी लाइफ स्टाइल है। वो लोग तो इतना अल्कोहल पीते हैं, मैंने तो कभी अल्कोहल ही नहीं पिया, मुझे सीए स्टमक क्यों हो गया? बार्गेनिंग, राइट? फिर डिप्रेशन, फाइनली acceptance. So these are the stages through which a person goes. Okay? तो उसके बाद आती है अनसर्टेनिटी। क्या इसका इलाज है? क्या मैं ठीक हो जाऊंगा? कि क्या साइड इफेक्ट्स है? ट्रीटमेंट कितने दिन चलेगा? व्हाट आर द साइड इफेक्ट्स ऑफ द ट्रीटमेंट? क्या कॉस्ट होगी? मेरी फैमिली का क्या होगा? मेरा फाइनेंशियल कौन सपोर्ट करेगा? Will I come back to the school? Will I come back to the college? Will I come back to the job? So there are so many issues related to uncertainty कि क्या होगा। और इतनी थॉट रेस होती है माइंड में ना, इधर से थॉट आया ये वो, और फाइनली ना एकदम से होपलेसनेस आ जाती है। होपलेसनेस, कुछ नहीं है, दुनिया खत्म है। Isn't it? I hope you may have witness any of these type of crisis situation जिसमें ये feel होता है कि now it is worthless, everything is like nothing is exist in this world, totally hopeless feelings. So the first is issue of uncertainty. इसके बाद second question आता है, second issue जो है वो है fear of death. कैंसर मतलब व्हाट इज कैंसर? कैंसर का मतलब आम लोगों की भाषा में डेथ। आज डायग्नोस हुआ, नेक्स्ट क्वेश्चन मेरे पास अब कितने दिन है? व्हाट इज द नेक्स्ट क्वेश्चन? हाउ मेनी डेज आई हैव नाउ? इजंट इट? मेरे पास अब कितने दिन है? इज इट कैंसर? एम आई डाइंग? क्या मैं मर रहा हूं? हाउ लॉन्ग आई हैव आई गॉट? मेरे पास अब कितने दिन है? हाउ विल आई डाई? हाउ विल आई डाई? कैसे होगा मेरा? कितना पेन में रहूंगा मैं? ओके, विल आई डाई इन द हॉस्पिटल? विल डाई इन द हाउस और समवेयर? व्हाट हैपन्स आफ्टर आई डाई? मेरे साथ क्या होगा? ओके, व्हाट हैपन्स विद माई फैमिली? देखिए कितने बड़े क्वेश्चंस है ये, बहुत बड़े क्वेश्चंस। हाउ माई फैमिली विल कॉप अप विद ऑल दिस? वो कैसे इससे कॉप अप करेगी? तो दीज आर वेरियस इश्यूज, क्योंकि प्रोग्नोसिस आजकल सब गूगल सर्च कर लेते हैं तो एवरीवन कम टू नो कि कितना उसके पास टाइम है। इवन जो ऑन्कोलॉजिस्ट है वो भी पेशेंट्स को, उनके फैमिली मेम्बर्स को बता देते कि नाउ दिस पर्सन हैज दिस मच टाइम, इजंट इट? तो जब इतना टाइम हो जाता तो ये सेम क्वेश्चंस पेशेंट के साथ भी है, उसका जो केयर गिवर है, फैमिली मेम्बर्स है, उसके साथ भी, राइट? तो द सेकेंड इज फियर ऑफ डेथ। अब आते हम इन दो इश्यूज तो, चलो ये तो कभी ठीक होते ही नहीं है। कौन से? अनसर्टेनिटी एंड फियर ऑफ डेथ। फियर ऑफ डेथ तो अभी नॉर्मल पर्सन को भी है, हाँ या ना? सबको है वो तो, कि कल क्या होगा। दिस इज व्हाट अनसर्टेनिटी एंड फियर ऑफ डेथ, राइट? So these are the two issues which are not going to be resolved. But these issues are much, much more in a person with cancer, because he has a cause to think about all this. We are not having any cause, but still we are thinking कि क्या होगा, right? Then the third issue is feeling of alteration in body image. Now the person is on treatment or the planning of treatment. प्लानिंग आते ही सपोज सीए ब्रेस्ट है, सर्जरी होनी है, रेडिकल मस्टेक्टमी या पार्शियल और मॉडिफाइड, वट एवर द सर्जरी टाइप इज, रिमूवल ऑफ वन ब्रेस्ट, देयर इज ह्यूज डिसफिगरमेंट, पूरी बॉडी इमेज चेंज बिकॉज ऑफ। For a female, beauty is the most, figure and beauty is the most important part, because that is the identity of a woman. And if something happens with the identity, that is the biggest crisis. That is the biggest crisis in the person's life. If something happens with the beauty or the figure of the person specific to female. And if it happens with the female in case of breast cancer, removal of breast, it's really a crisis situation. बहुत मुश्किल और tough time. Anyway, we have now so many advancement on this, in which at the social level the person will try to manage with the use of prosthesis and all. But personally, there is huge crisis with regard to the self-image, right? So then hair loss, treatment है, patient is on treatment. Chemotherapy शुरू की सबसे पहले oncology ने, oncologist ने. कीमोथेरेपी की सेकेंड डोज के साथ ही क्या हुआ? क्या हुआ? हेयर लॉस टोटली, एकदम से. जिसके बहुत सुंदर और लंबे से बाल थे, उसके एकदम से ही सारे बाल गिर गए. बहुत शॉकिंग. ओके, देन वेट लॉस, वेट गेन, ये चलते रहते हैं. सर्जरी स्कार्स बिकॉज ऑफ द ऑपरेशन, डिपेंड्स ऑन द टाइप ऑफ कैंसर. इफ इट इज सर्जरी के कारण इश्यूज हो गया. देन रैशेस बिकॉज ऑफ एनी मेडिकेशंस, लॉस ऑफ लिम्ब or any organ, presence of ostomy on the part of body, or because of the treatment, because of the disease itself, because of the regular visiting to hospital, the patient will totally tired, will have so much fatigue which will reflect on the face of the patient. So these all are the feeling which are associated with body image, and this is the very, very important issue जो कि उसको अंदर तक हिला देता है. नेक्स्ट इज सोशल आइसोलेशन. सोशल आइसोलेशन स्टार्ट्स फ्रॉम द डायग्नोसिस, डिस्क्लोजर ऑफ डायग्नोसिस. जैसे ही पता लग जाता है वैसे ही सबसे पहले फैमिली अपने आप को क्या करती है? अलग कर लेती. बताना पसंद नहीं करती. करती है पसंद नहीं. क्यों? Because still we are very much uneducated and illiterate with regards to the disease. Psychiatric problems और कोई ऐसी problems जो कि फैमिली को भी अफेक्ट कर सकती फ्यूचर में, उस डिजीज को we are not supposed to tell, we do not wish to tell to the other people, because सोसाइटी में इन चीज को अच्छे से एक्सेप्ट नहीं किया जाता. So at the time, as soon as the family and the client came to know the diagnosis, they isolate themselves with the others. Okay? Then isolation starts with the physiological changes because of the disease. Disease के कारण suppose medicines पे है, hair loss हो गया, right? Hair loss हो गया तो बाहर नहीं निकल सकते. Okay? मेस्टेक्टमी हो गई, बाहर निकलना, राइट? तो बहुत सारे ऐसे फिजियोलॉजिकल चेंजेस होते हैं जिसके कारण सोशल आइसोलेशन सेल्फ इम्पोज्ड हो जाता है. देन रिस्क ऑफ इन्फेक्शन. द पेशेंट इज ऑन कीमोथेरेपी एंड देयर इज साइड इफेक्ट कि वहाँ पे जो है सेल काउंट्स कम होगा, द क्लाइंट इज ऑन द रिस्क ऑफ इन्फेक्शंस, राइट? So the therapist will tell you, try to stay at home and not meet with the others, otherwise you might have risk of infection because of your low immunity. Then cognitive belief, उसकी खुद की सोच ऐसी हो जाती है. Cognitive belief means patient खुद ही ऐसे सोचने लग जाता है कि मुझे क्यों मिलना है किसी से, लोग मुझसे पूछेंगे कि क्या हुआ, कैसे हुआ, और किसको है, कितने दिन चलेगा, राइट? पेशेंट अपने आप को अंदर से मजबूत कर रहा है, लेकिन फिर भी लोग उसको पूछेंगे, रिलेटिव्स पूछेंगे, बार बार पूछेंगे, फोन करके पूछेंगे कैसे हो, कितनी थेरेपी हो गई, बाल है या यस और नो, बहुत सारे इश्यूज है तो वो लिमिट कर लेता है. देन एंजाइटी, बहुत ज़्यादा चिंता. मेरे पास थोड़ा सा टाइम कम है, आई एम लिटिल बिट फास्ट. तो एंजाइटी बहुत ज़्यादा होती है. डिप्रेशन एंड कैंसर. नॉर्मल डिप्रेशन इज, suppose study says that the normal prevalence of depression in around 9 to 10%, but in case of the cancer patient the depression goes double. It's around 18 to 19% in patient with malignancy. So the depression is very high. And in they just see the prevalence in oropharyngeal cancer, the study says it is 22 to 57% the depression is. Suicidal ideation, मरना ही है. 10 दिन बाद, 1 साल बाद, 5 साल बाद, ऐसे क्या जीना. रोज ही पेन होता है, रोज ही दर्द होता है, रोज ही हॉस्पिटल जाना, कीमोथेरेपी के लिए जाना, 5-5 दिन कीमोथेरेपी चल रही है, नोजिया है, वॉमिटिंग है, साइड इफेक्ट्स है. इससे बेटर है क्या, फैमिली भी जाना ही है ना, एक दिन सब नहीं जाना है. मैंने भी जाना है, आपने भी जाना है. यस और नो. और कैंसर पेशेंट को तो ये बता दिया डॉक्टर ने क्या, 5 साल बाद जाना है. यस और नो. तो फिर सुसाइडल आइडिएशन, इससे तो अच्छा है आज ही खत्म हो जाए. तो इट्स ए बिग इश्यू. ओके. देन डेलीरियम, भूल जाना. cognitive impairment because of the disease. Substance misuse to relieve the pain, to relieve the psychological pain, कि मैं इन चीज़ों को भूल जाऊँ, इससे अच्छा है और नशा कर लूँ, कोई सब्सटेंस ले लूँ, एल्कोहल ले लूँ, ओपियोइड ले लूँ. If we see few of the barriers in management of these, सबसे पहले ये तो बहुत सारे barriers हैं. I have a big list. I have only discussed few of them. The barrier को problems कहाँ आती हैं barriers को? What are the barriers which are present to manage the psychological issues? The first is lack of attitude. Lack of attitude to identify these barriers in these issues. The second is lack of resources and the trained professionals. We don't have much counselors and psychologists. Then lack of trained healthcare providers, lack of availability of specific treatment, social stigmas, and inaccurate assessment of cases. So these are some of the barriers which makes it difficult to manage those issues. Now I am just going few of the like simple suggestions, psychiatry point of view. जो oncologist ने बताने, जो onco nurse ने बताने, वो तो already exist करते हैं, वो तो आप पूरे 3 दिन में आप देख ही रहे हो. These are few of the suggestions. The first is get help from the Department of Psycho-Oncology. अब ये Psycho-Oncology क्या है? It's a super specialty branch which has a group of mental health professionals with which they deals with the physical, psychological, social and behavioral aspect of the cancers to improve the overall quality of life. And it's an emerging area, but it's still not much available in India. Only available in few of the private sectors, good hospitals, not in government sector hospitals, because not much trained professionals are available and most of the people are not aware about it. Then second is psycho-oncology के पास जाने के बाद आपको they will take care of your psychiatric part. What is psychiatric part? They will identify your early psychiatric symptoms. What is thinking, what is emotions, and what is your behavior. So they will do your overall assessment and will try to find out any comorbid psychiatric illness other than cancer. It may be depression, it may be suicidal thoughts, it may be any other disease. So they will take care of that part. So the important thing is go to the psychiatrist and get your assessment. Then medicines, take medicines. These are the medicines which the client has to take other than the oncomedicines, right? Get counseling services, very important. Talk with your friends, talk with professional counselor. Make a group, or there are several already existing groups which are functioning in can support like. So join that group. They give psychological support. डेवलप हेल्दी कॉपिंग स्किल्स टू फेस डे टू डे वियर एंड टीयर। तो जब मैलिग्नेंसी हो जाती है तो सारे दिन एक जैसे नहीं चलते, अभी तो हमारे सारे दिन एक जैसे चल रहे हैं, यस और नो? बट व्हेन द पर्सन इज इन ट्रीटमेंट, कभी नोशिया हो गया, हेयर फॉल हो गया, सो दीज आर वेरियस, बीच बीच में बहुत अप्स एंड डाउन्स आते हैं, तो उसको मैनेज करने के लिए यू हैव टू बी मेंटली प्रिपेयर योरसेल्फ कि हाउ यू विल डील विद ऑल दोज। सो डेवलप हेल्दी कॉपिंग स्किल्स, helping patients to cope with hair loss, so use of wig is the best option. So buy wig before hair falls, पहले से ही बाल छोटे करा लीजिए, सिर पे टर्बन यूज कर सकते हैं या कोई कपड़ा बांधा जा सकता है। So there are so many now techniques are available, but the person should have aware. Also, the person should be ready to adopt those ways of managing these issues. Then another issue is fertility fear and preservation. Okay, कई बार कैंसर सपोज सी ओवरी है, सी टेस्टिस है, तो वहाँ पे फर्टिलिटी और सेक्सुअलिटी का भी इश्यू आ जाता है। सो नाउ वी हैव अगेन इन दिस एरिया वी हैव डेवलप्ड लाइक स्पर्म बैंक, so there now this issue can also be managed. Keep yourself happy, laugh as much as you can, and don't shy. Right? Remember your happy moments of life. हमेशा एक दिन मैंने भी बोला था कि our all the days are not like the same. We have like good memories. अब आप यहाँ 3 दिन अमृतसर आए हो ना, मैं यहाँ क्यों आया हूँ 3 दिन? क्यों आया हूँ? क्यों आया हूँ? मेमोरीज कलेक्ट करने के लिए, अपने फ्रेंड से मिलने के लिए। इसलिए आया हूँ, फ्रेंड से मिलने के लिए, आप लोगों से मिलने के लिए। 3 दिन मजे करेंगे। आप भी इसलिए आए हो? यस और नो? यस, ये ऐसी स्पिरिट होनी चाहिए कि हर कॉन्फ्रेंस में जाना है। क्यों? मजे करने के लिए। यस, ये रखा करो, मेन ऑब्जेक्टिव ऑफ एवरी कॉन्फ्रेंस शुड बी मजा, नॉट सजा। सेशन तो है सजा, मेरे से बात करोगे तो मिलेगा मजा। राइट? तो ट्राई टू गो ईच एंड एवरी प्लेस, दोस्तों से मिलो, दोस्त बनाओ, अपने हैप्पी मोमेंट्स को याद करो, बर्थडे याद करो, कोई भी सेलिब्रेशंस है, छोटे छोटे फन करो, एक्टिविटीज करो, उससे फ्रेश अप रहेगा पेशेंट। फॉरगेट योर सैड टाइम एंड नेगेटिव थॉट्स, उस पर ध्यान ना दे। डोंट बी परफेक्ट, आप कभी भी परफेक्ट, मैं इस प्रेजेंटेशन में ना 15 दिन लगा दूं ना, इसमें इस मेरे प्रेजेंटेशन में, इफ आई स्पेंड 15 डेज, या मैडम प्रभजोत ने लिया या उन्होंने लिया या किसी और ने भी लिया, अगर 15 डेज भी लगा देंगे ना तो वो परफेक्ट। एम आई राइट मैडम? एम आई राइट? इजंट इट? सो नो वन इज परफेक्ट। तो डोंट बी परफेक्ट, एंड परफेक्ट होने की कभी कोशिश भी मत करो। जैसे आपने परफेक्ट होने की कोशिश की, आपने ओवर स्ट्रेस ले लिया, पेशेंट के साथ भी ऐसा ही है। कभी भी ओवर स्ट्रेस पेशेंट को नहीं करो, जैसा है वैसा ही बहुत बढ़िया है। यू ऑल आर द ब्यूटीफुल सोल ऑफ द अर्थ। भगवान ने हर एक पेशेंट को, हर एक क्लाइंट को बहुत ही खूबसूरत और बहुत ही मेहनत से बनाया है, बहुत ही मेहनत से। तो डोंट कंपेयर योरसेल्फ, वट एवर यू आर द बेस्ट क्रिएचर। अपने आप को बोलो आई एम द बेस्ट। यस और नो? बोलो आई एम द बेस्ट। यस, नेवर कंपेयर विद अदर्स। जैसे ही आपने अपने आप को कंपेयर किया, यू आर इन्वाइटिंग स्ट्रेस। लोगों के है ना, वो व्हाट्सएप स्टेटस मत देखा करो, वो बहुत बड़ा स्ट्रेसर है। मैडम प्रभजोत कुछ करती है, स्टेटस डाल देती है, तो मुझे स्ट्रेस हो जाता है। यस और नो? कि मैडम ने कुछ कर दिया, अब मुझे भी कुछ करना पड़ेगा। यस और नो? दिस, वी ऑल आर ह्यूमन बीइंग, ये सबके साथ होता है। वी ऑल आर ह्यूमन बीइंग, इट्स अ नेचुरल फिनोमिना कि एक जैसे ही हम किसी और की प्रोग्रेस या कैसे, मैं आई एम जस्ट नॉट टेकिंग, मैडम पर्सनल मत लेना, वी आर गुड फ्रेंड्स, वो नहीं लेंगे। तो इट्स नेचुरल, सबके साथ होता है कि यार उसने इतनी सुंदर ड्रेस डाली है, मैं भी कहीं जाके फोटो खींच। जैसा ना होता है ना, उसने बाल खोले, तो अभी मैं देख रहा था बाहर ना, सुंदर सी लड़कियां बाल खोल के फोटो खिंचा एक दूसरे की। यस और नो? तो ऐसे ही करो, पर दूसरों का स्टेटस मत देखो, बिकॉज व्हेन यू सी द स्टेटस ऑफ अदर यू आर कंपेयरिंग योरसेल्फ एंड इट क्रिएट्स स्ट्रेस. डेफिनेटली स्ट्रेस आता है. एग्री? हाँ. Remember, not there are so many things, but the things are not in your hands. जो अर्थ पे दुनिया में बहुत सारी चीजें हो रही है ना, वो चीजें आपके हाथ में नहीं है. हमें ऐसा लगता है कि हम धरती को चला रहे हैं. क्या लगता है कि हमारे बिना तो कॉन्फ्रेंस होगी नहीं जी, हम नहीं जाएंगे तो, या हमारे बिना तो शादी नहीं होगी जी, हम नहीं जाएंगे तो. ऐसा होता है? सब चीजें होती रहेगी, दुनिया चलती रहेगी, आते हैं लोग चले जाते हैं, बट एवरीथिंग हैपन्स एज पर द प्लान. सो इट्स अ गॉड प्लान. किसी को कैंसर होना है या नहीं होना है, इट्स नॉट इन योर हैंड. इट्स नॉट इन योर हैंड, द हैंड ऑफ गॉड. राइट? तो उस पर ध्यान न देके ओनली फोकस ऑन योर गुड कर्म. आपके कर्म अच्छे होने चाहिए. आप लोगों को खुशी दो, लोगों को खुश रखो, तनाव मुक्त रखो, जितनी हेल्प कर सकते हो उतनी करो. That's all. That's our job. Leave rest of the things to the God. Make friends. ज़्यादा से ज़्यादा दोस्त बनाइए. अच्छे से नींद लो. बढ़िया कॉन्फ्रेंस का खाना खाओ. शाम को डीजे पार्टी में डांस करना है. ओके? राइट? उस पार्टी में सबने आना है, तैयार होके आना है. ओके? और उसके बाद अच्छे से सोना है, कल फिर आना है. डू योगा डेली. राइट? दिस इज व्हाट समरी. थैंक यू सो मच. मैंने थोड़ा ज़्यादा टाइम ले लिया, इन्होंने मुझे बीच में बांध दिया था. मैंने बोला मुझे बता देना, मैं रुकता नहीं हूँ, एक बार बुला लेते हैं तो फिर ठीक है ना, क्योंकि साइकेट्री वालों का काम क्या है? बोलना. यस और नो? थैंक यू सो मच.
तो मेरी बात को सर ने बिल्कुल प्रूव कर दिया. He changed the aim of the conference totally opposite. We talk about whenever we are going to in any conference, we think that it will be fulfill our aim, that knowledge and all these things, research, and but changed everything. अगर इनको अलाउ किया जाता तो शायद हो सकता था इस टॉपिक पे ये 3 से 4 घंटे का सेशन ले सकते थे. तो मज़ा आ गया. किसी कॉन्फ्रेंस के टॉपिक्स का एंड किस तरह से होना चाहिए इन्होंने फुलफिल किया. थैंक यू वेरी मच सेशन के लिए.
Now it's time for discussion and question answer. So you can clear your doubts with our chairpersons. Anybody? Nobody have question? Say yes or no. Okay.
Now I would like to call our respected principal ma'am, vice principal ma'am, and Dr. Meena Sudan to come up on stage and honor our chairperson, Dr. Nimesh Kumar.
Please big round of applause. Now I would like to call Dr. Sushil K. Maheshwari. Please come on the stage and receive your honor. Please big round of applause. I request Miss Anita D'Souza. Ma'am, please come on the stage and receive your honor. Dr. Sushil K. Maheshwari, Professor, Baba Farid University Health Sciences, Faridkot. I request I request Dr. Meena Sudan, please receive a honor. Please, big round of applause. Thank you, ma'am. Thank you, Principal ma'am and Vice Principal ma'am. Destiny may ride with us today, but there is no reason for it to interfere with lunch.
Now, it's time for lunch break. We request to all of you to kindly assemble here before 2:30 p.m. Thank you.
wasting our time.
Welcome back, everyone. It's time for interactive session with patient relatives related to their cancer experience.
So I would like to call Mr. Pritpal Singh. Please come on the stage and share your views. Please, Mr. Singh, please come on the stage. Big round of applause.
ਹੈਲੋ ਐਵਰੀਵਨ, ਮੈਂ ਪ੍ਰਿਤਪਾਲ ਸਿੰਘ ਅੰਮ੍ਰਿਤਸਰ ਤੋਂ। ਮੇਰੀ ਵਾਈਫ ਇੱਥੇ ਜੀਤ ਕੌਰ ਆਂਦਾ ਹਸਪੀਟਲ ਬਾਹਰ ਅਸੀਂ ਬਹੁਤ ਟਰਾਈ ਕੀਤੀ, ਮੱਲ੍ਹ ਵਾਲਿਆਂ ਕੋਲ ਜਾਂ ਦੂਸਰਿਆਂ ਕੋਲ ਅਸੀਂ ਹਸਪੀਟਲ ਵਗੈਰਾ 'ਚ ਟਰਾਈ ਕੀਤੀ ਅਤੇ ਸਾਨੂੰ ਕੋਈ ਫਰਕ ਨਹੀਂ ਪਿਆ। ਫਿਰ ਅਸੀਂ ਕਿਸੇ ਨੇ ਸਾਨੂੰ ਰਿਕਮੈਂਡ ਕੀਤਾ ਤੁਸੀਂ ਇੱਥੇ ਚੱਲ ਜਾਓ ਅਤੇ ਇੱਥੇ ਤੁਹਾਡਾ ਇਲਾਜ ਬਿਲਕੁਲ ਸਹੀ ਹੋਏਗਾ। ਬਾਕੀ ਅਸੀਂ ਟੈਸਟ ਵਗੈਰਾ ਵੀ ਬਾਹਰੋਂ ਕਰਾਉਂਦੇ ਰਹੇ ਹਾਂ, ਕੋਈ ਫਰਕ ਨਹੀਂ ਪਿਆ। ਫਿਰ ਰਿਕਮੈਂਡ ਕੀਤਾ ਰਾਮਦਾਸ ਹਸਪੀਟਲ ਅਤੇ ਫਿਰ ਅਸੀਂ ਇੱਥੇ ਆਏ ਅਤੇ ਟੈਸਟ ਵਗੈਰਾ ਸਾਰੇ ਕਰਾਏ ਅਤੇ ਤਕਰੀਬਨ 1.5 ਮਹੀਨਾ ਅਸੀਂ ਇੱਥੇ ਦਾਖਲ ਰਹੇ ਅਤੇ ਫਿਰ ਕੀਮੋ ਵਗੈਰਾ ਇੱਥੇ ਲੱਗਦੀ ਹੈ ਅਤੇ ਫਿਰ ਅਸੀਂ ਕੀਮੋ ਇੱਥੇ ਆ ਜਾਂਦੇ ਸੀ ਅਤੇ ਬਿਲਕੁਲ ਮੇਰੇ ਵਾਈਫ ਤੁਰ ਵੀ ਨਹੀਂ ਸੀ ਸਕਦੇ, ਸਿਰਫ ਬੈੱਡ 'ਤੇ ਰਹਿੰਦੇ ਸੀ ਅਤੇ ਅਸੀਂ ਸਟਰੈਚਰ 'ਤੇ ਹੀ ਆਉਂਦੇ ਸੀ। ਤਕਰੀਬਨ ਕਾਫੀ ਵਾਰੀ ਸਟਰੈਚਰ 'ਤੇ ਆਉਂਦੇ ਰਹੇ ਅਤੇ ਜਦੋਂ ਫਿਰ ਇੱਥੋਂ ਅਸੀਂ ਮੇਰਾ ਇਲਾਜ ਸਟਾਰਟ ਹੋਇਆ ਇੱਥੋਂ ਅਤੇ ਫਿਰ ਉਹ ਕੁਰਸੀ 'ਤੇ ਬਹਿ ਕੇ ਆਉਣ ਲੱਗ ਪਏ ਅਤੇ ਕਾਫੀ ਇਹਨਾਂ ਨੂੰ ਫਰਕ ਪੈ ਗਿਆ ਅਤੇ ਹੁਣ ਇਹ ਉੱਠ ਕੇ ਆਪੇ ਹੀ ਬਹਿ ਜਾਂਦੇ ਨੇ, ਆਪੇ ਹੀ ਲੇਟ ਜਾਂਦੇ ਨੇ। ਕਾਫੀ ਇਹਨਾਂ ਨੂੰ ਅੱਗੇ ਨੂੰ ਫਰਕ ਪੈ ਗਿਆ ਅਤੇ ਤਕਰੀਬਨ ਅਸੀਂ ਕੀਮੋ ਲਵਾਉਣ ਇੱਥੇ ਆਉਂਦੇ ਹਾਂ ਅਤੇ ਬਾਕੀ ਇੱਥੇ ਇਲਾਜ ਬਹੁਤ ਵਧੀਆ, ਜਿਹੜਾ ਘਰ ਵਾਲਾ ਮਾਹੌਲ ਚੱਲਦਾ ਸਾਰਾ, ਨਰਸ ਵਗੈਰਾ ਸਾਰੇ ਡਾਕਟਰ ਵਗੈਰਾ ਉਹ ਬਿਲਕੁਲ ਸਹੀ ਸਾਨੂੰ ਗਾਈਡ ਕਰਦੇ ਨੇ ਅਤੇ ਬਿਲਕੁਲ ਸਾਨੂੰ ਉਸ ਹਿਸਾਬ ਨਾਲ ਪੰਜਾਬੀ 'ਚ ਸਭ ਕੁਝ ਦੱਸਦੇ ਨੇ ਜੋ ਸਾਨੂੰ ਸਮਝ ਲੱਗ ਜਾਂਦੀ ਅਤੇ ਮੈਡਮ ਬਿਲਕੁਲ ਸਹੀ ਤਰ੍ਹਾਂ ਸਮਝਾਉਂਦੇ ਨੇ ਸਾਨੂੰ। ਬਾਕੀ ਇੱਥੇ ਕੋਈ 1-2 ਪ੍ਰੋਬਲਮ ਇੱਥੇ ਹੈਗੀਆਂ ਜਿਹੜੀਆਂ, ਅਤੇ ਪੈਟ ਸਕੈਨ ਇੱਥੇ ਨਹੀਂ ਹੈਗਾ। ਪੈਟ ਸਕੈਨ ਸਾਨੂੰ ਬਾਹਰ ਜਾਣਾ ਪੈਂਦਾ ਅਤੇ ਕੋਸ਼ਿਸ਼ ਇਹ ਕਰਨੀ ਚਾਹੀਦੀ ਵੀ ਪੈਟ ਸਕੈਨ ਇੱਥੇ ਹੀ ਹੋਏ, ਸਾਰਾ ਇਲਾਜ ਇੱਥੇ ਹੀ ਹੋਏ, ਕਿਉਂਕਿ ਟੈਸਟ ਇੱਥੇ ਹੀ ਨੇ ਸਾਰੇ ਤਕਰੀਬਨ। ਬਾਹਰੋਂ ਅਸੀਂ ਟੈਸਟ ਕਰਾਉਂਦੇ ਸੀ, ਕਦੀ ਕਿਤੇ ਚਲ ਜਾਂਦੇ, ਕਦੇ ਮਾਲ ਰੋਡ 'ਤੇ ਚਲੇ, ਅਤੇ ਉਹ ਸਾਡਾ ਇਹ ਨਹੀਂ ਹੋਇਆ ਕੰਮ ਸਹੀ। ਅਤੇ ਇੱਥੇ ਜਿਹੜਾ ਪੈਟ ਸਕੈਨ ਹੈ ਇੱਥੇ ਚਾਹੀਦਾ ਜ਼ਰੂਰੀ। ਇੱਕ ਜਿਹੜੀ ਪੇਸ਼ੈਂਟ ਵਾਸਤੇ ਜਿਹੜੇ ਕੈਂਸਰ ਪੇਸ਼ੈਂਟ ਵਾਸਤੇ ਚੇਅਰ ਰੱਖੀ ਹੈ, ਲੋਹੇ ਦਾ ਸਟੂਲ ਵਗੈਰਾ ਰੱਖਿਆ, ਉਹ ਲੋਹੇ ਦਾ ਹੈਗਾ। ਉਹ ਜਿਹੜਾ ਉੱਥੇ ਜਿੱਥੇ ਬੈਠ ਸਕੇ ਬੰਦਾ, ਢੋ ਵਗੈਰਾ ਹੋਵੇ ਉੱਤੇ, ਉਹ ਉਹਨਾਂ ਨੂੰ ਰੱਖਣਾ ਚਾਹੀਦਾ। ਬੰਦਾ ਜਿਹੜਾ ਅਟੈਂਡੈਂਟ ਹੈਗਾ ਉਹਦੇ ਵਾਸਤੇ ਬੜਾ ਮੁਸ਼ਕਲ ਹੋ ਜਾਂਦਾ। ਅਤੇ ਬਾਕੀ ਇਹਦਾ ਰਵੱਈਆ ਬਿਲਕੁਲ ਠੀਕ, ਇਹਨਾਂ ਦਾ ਬਿਲਕੁਲ ਸਹੀ ਹੈ। ਅਤੇ ਰਾਤੀ ਦੇ 3 ਵਜੇ ਵੀ ਸਹੀ ਇਹਨਾਂ ਨੂੰ ਆਵਾਜ਼ ਦਿੰਦੇ ਅਤੇ 3 ਵਜੇ ਉੱਠ ਕੇ ਹੀ ਉਸ ਵੇਲੇ ਅਟੈਂਡ ਕਰ ਦਿੰਦੇ, ਲਵਾਉਣਾ ਜਾਂ ਉਹ ਬਿਲਕੁਲ ਅਟੈਂਡ ਕਰਦੇ ਰਹੇ ਅਤੇ ਬਿਲਕੁਲ ਸਾਡਾ ਇੱਥੇ ਸਹੀ ਐਕਸਪੀਰੀਅੰਸ ਰਿਹਾ ਅਤੇ ਹੁਣ ਕਾਫੀ ਉਹਨਾਂ ਨੂੰ ਫਰਕ ਹੈਗਾ। ਹੁਣ ਉਹ ਉੱਠ ਕੇ ਬਹਿ ਜਾਂਦੇ ਨੇ ਅਤੇ ਤੁਰ ਵੀ ਲੈਂਦੇ ਨੇ ਹੌਲੀ ਹੌਲੀ, ਵਾਕਰ ਦੇ ਨਾਲ ਤੁਰ। ਅਤੇ ਬਿਲਕੁਲ ਅਸੀਂ ਆਸ ਛੱਡੀ ਸੀ ਕਿ ਇੱਥੇ ਅਸੀਂ ਆਸ ਛੱਡਤੀ ਸੀ, ਇੱਥੇ ਆ ਕੇ ਸਾਡਾ ਬਿਲਕੁਲ ਸਹੀ ਹੋ ਗਿਆ ਤਕਰੀਬਨ। ਥੈਂਕ ਯੂ ਵੈਰੀ।
Thank you so much, sir, for sharing your experience with us. Next, I would call next patient relatives, that is Mrs. Ritu. Please come on stage.
ਮੇਰੇ ਹਸਬੈਂਡ 2 ਸਾਲਾਂ ਤੋਂ ਕੈਂਸਰ ਦੇ ਪੇਸ਼ੈਂਟ ਸੀ। 14 ਮਈ ਤੋਂ ਸਾਡਾ ਇੱਥੇ ਗੁਰੂ ਰਾਮਦਾਸ ਹਸਪੀਟਲ ਇਲਾਜ ਚੱਲਿਆ। ਹੁਣ ਕਾਫੀ ਬਹੁਤ ਜ਼ਿਆਦਾ ਫਰਕ ਨੇ। AP ਸਿੰਘ ਸਰ ਸਾਡੀ ਬਹੁਤ ਹੈਲਪ ਕਰਦੇ ਨੇ, ਨੀਰੂ ਮੈਮ ਸਾਡੀ ਬਹੁਤ ਹੈਲਪ ਕਰਦੇ ਨੇ, ਸਾਡਾ ਸਟਾਫ ਬਹੁਤ ਜ਼ਿਆਦਾ ਵਧੀਆ ਹੈ। ਇੱਥੋਂ ਦੇ ਸੇਵਾਦਾਰ ਵੀ ਬਹੁਤ ਜ਼ਿਆਦਾ ਹੈਲਪ ਕਰਦੇ ਨੇ, ਨਰਸਿੰਗ ਵੀ ਬਹੁਤ ਜ਼ਿਆਦਾ ਹੈਲਪ ਕਰਦੀਆਂ ਨੇ। ਸਾਨੂੰ ਬਹੁਤ ਜ਼ਿਆਦਾ ਫਰਕ ਹੈਗਾ ਮੇਰੇ ਹਸਬੈਂਡ ਨੂੰ। ਪਹਿਲਾਂ ਬੋਲ ਵੀ ਨਹੀਂ ਸਕਦੇ, ਹੁਣ ਜ਼ਿਆਦਾ ਬੋਲਦੇ ਵੀ ਹੈ, ਤੁਰ ਫਿਰ ਵੀ ਲੈਂਦੇ ਆ। ਹੁਣ ਕੀਮੋ ਚੱਲਣ ਡੀਆਂ।
Thank you, Ritu ji, for sharing your experience. Next, I would like to call Veena Arora for sharing her experience. Please, ma'am, come on the stage.
ਸਤਿ ਸ਼੍ਰੀ ਅਕਾਲ ਜੀ। ਮੇਰੇ ਹਸਬੈਂਡ ਬ੍ਰੈਡ ਕੈਂਸਰ ਦੇ ਮਰੀਜ਼ ਹੈ। ਉਹ ਇੱਥੇ ਪਹਿਲੇ ਉਹ ਇਲਾਜ ਕਰਾਉਣਾ ਨਹੀਂ ਚਾਹੁੰਦੇ ਸੀ। ਫਿਰ ਕਿਸੇ ਨੇ ਗੁਰੂ ਰਾਮਦਾਸ ਹਸਪੀਟਲ ਸਾਨੂੰ ਕਿਹਾ ਕਿ ਤੁਸੀਂ ਇੱਥੇ ਜਾ ਕੇ ਇਲਾਜ ਕਰਾਓ। ਅਸੀਂ ਪਹਿਲੇ ਤਾਂ ਦਿੱਲੀ ਤੱਕ ਹੋ ਕੇ ਆਏ ਹਾਂ, ਅਤੇ ਇੱਥੇ ਆਣ ਕੇ ਸਾਨੂੰ ਡਾਕਟਰ AP ਸਿੰਘ ਨੇ ਸਾਡਾ ਇਲਾਜ ਕਰਵਾਇਆ। ਉਹਨਾਂ ਨੇ ਸਭ ਕੁਛ ਠੀਕ ਤਰ੍ਹਾਂ ਦਾ ਕੀਤਾ ਅਤੇ ਮੇਰੇ ਹਸਬੈਂਡ ਹੁਣ ਕੀਮੋ ਚੱਲ ਰਹੀਆਂ, ਕਾਫੀ ਫਰਕ ਹੈ। ਅਤੇ ਨਰਸ ਹੈ ਮੇਰਾ ਬਹੁਤ ਸਾਡਾ ਖਿਆਲ ਰੱਖਦੀਆਂ, ਜੋ ਕਰਮਚਾਰੀ ਹੈ ਉਹ ਵੀ ਠੀਕ ਤਰ੍ਹਾਂ ਦਾ ਖਿਆਲ ਰੱਖਦੇ ਹੈ। ਥੈਂਕ ਯੂ।
Thank you, ma'am. Now I request my respected teacher, Miss Rupinder Kaur and Kiran ma'am, please come on the stage. And please, I request Miss Kamalpreet Kaur ma'am, please come on the stage and give honor to the I request Mr. Pritpal Singh, please come on the stage and receive your honor. Please big round of applause for ma'am. Thank you, ma'am. Next, I would like to call Ritu and Veena Arora. Please come on the stage and receive your honor. Please big round of applause for them. Next, Mrs. Veena Arora. Thank you, ma'am. Thank you, everyone. Now, it's time for open discussion based on patient care experiences. I would request our moderator, Miss Kamalpreet Kaur, Assistant Professor, Adesh University, Bathinda. Please, ma'am, come on the stage. Please, big round of applause. She has presented papers and posters on cancer care in national and international conferences and got first position in SOMI Unicorn E-Conference for paper presentation. She has sound experience in organizing CNE webinar on Oncology Nursing conference and has spent many days at state and national level of conference. She has good members of publication in field of Oncology Nursing. Ma'am Kamalpreet, please ma'am come on the stage.
Thank you so much, ma'am. Good evening, one and all. So first of all, it's a great pleasure to stand here and to attend such a wonderful platform with all of you. This session is all about the open discussion on patient experiences, patient care experiences with our 4 finest speakers. So in this whole session, they will discuss about the experiences or the challenges from which the cancer patients go throughout their cancer treatment as well as their cancer care. So without taking much of your time, I would like to request our first well-deserved speaker of this session, Ms. Pawandeep Kaur. So Ms. Pavandeep Kaur, currently she is working as a senior nursing officer at Guru Gobind Singh Medical College and Hospital. Ma'am has worked as a staff nurse in Sigma Heart Institute and Research Center at Ludhiana. Currently, she is working as a staff nurse or nursing officer at the Guru Gobind Singh Medical College Hospital since 2010. And she has sound experience of 22 years in the oncology field. And ma'am is also a lifetime member of ONI. Ma'am, the stage is all yours.
Good evening. My name is Pavandeep Kaur and my topic is patient-centered communication and decision making. Patient-centered care is based on a partnership between the patient and their family and the healthcare provider, like staff nurses, technicians, psychologists, dietitians, all are involved in this field. It is focused on the patient value, preferences, and needs. Effective patient communication and shared decision making are key component of a patient-centered care. Doctors share information to the patient, then both are taking a decision on their disease, chemotherapy, like radiation or any other procedure done. Shared decision making honors both the healthcare providers' expert knowledge and the patient rights to be fully informed of all care options and the potential harm and benefits. That's all healthcare workers or patients ਨੂੰ ਉਹਦਾ ਰਾਈਟ ਹੈ ਕਿ ਉਹ ਆਪਣੇ ਹਾਰਮਸ ਤੇ ਉਹਦੇ ਬੈਨੀਫਿਟਸ ਪਤਾ ਹੋਣੇ ਚਾਹੀਦੇ ਨੇ ਉਹ ਕੀ ਉਹਦੇ ਤੇ ਪ੍ਰੋਸੀਜਰ ਕਰ ਰਹੇ ਨੇ ਉਹਨੂੰ ਕੀਮੋਥੈਰੇਪੀ ਮਿਲ ਰਹੀ ਹੈ ਤਾਂ ਉਹ ਆਪਣੇ ਦੱਸ ਸਕਦਾ ਹੈਗਾ ਕਿ ਮੈਂ ਇਸ ਦੇ ਬੈਨੀਫਿਟਸ ਜਾਂ ਇਸ ਦੇ ਮਤਲਬ ਮੇਰੇ ਲਈ ਕੀ ਇਹਦੀਆਂ ਲਾਭ ਨੇ ਤੇ ਕੀ ਇਹਦੀਆਂ ਹਾਨੀਆਂ ਨੇ ਸੋ ਇਸ ਕਰਕੇ ਪੇਸ਼ੈਂਟ ਨੂੰ ਫੁੱਲੀ ਇਨਫੋਰਮ ਹੋਣਾ ਚਾਹੀਦਾ ਐਵਰੀਥਿੰਗ ਆਲ ਪ੍ਰੋਸੀਜਰ This process provides patient with the support. अगर patient ਨੂੰ ਇਹ ਸਾਰਾ ਕੁਝ ਪਤਾ ਹੈ ਤਾਂ ਉਹ ਆਪਣੀ full support ਕਰੇਗਾ ਜੋ ਵੀ ਆਪਾਂ ਉਹਦਾ ਇਲਾਜ ਕਰਾਂਗੇ ਤਾਂ ਉਹਦਾ ਇਲਾਜ ਬਹੁਤ ਵਧੀਆ ਹੋਵੇਗਾ ਤੋਂ ਇਲਾਵਾ primary function it involves focusing on patient needs value and wishes ਅਸੀਂ ਇਹ ਸਾਰਾ ਕੁਝ patient ਦੀਆਂ ਨੀਡਸ ਨੂੰ ਧਿਆਨ ਵਿੱਚ ਰੱਖਦੇ ਹੋਏ ਕਰ ਸਕਦੇ ਹੈਗੇ ਆ ਕਿ ਉਹਨੂੰ ਪ੍ਰਾਇੋਰਟੀ ਬੇਸਿਸ ਤੇ ਕੀ ਨੀਡਸ ਨੇ ਤੇ ਉਹਦੀਆਂ ਵੈਲਿਊ ਤੇ ਵਿਸ਼ੇਸ ਇੱਕ ਪੇਸ਼ੈਂਟ ਜਿਸ ਤਰ੍ਹਾਂ ਦਾ ਵੀ ਉਹਦੀਆਂ ਵਿਸ਼ੇਸ ਨੇ ਜਾਂ ਵੈਲਿਊਜ਼ ਨੇ ਇਹ ਪੇਸ਼ੈਂਟ ਅਗਰ ਨਾਨ ਵੈਜ ਨਹੀਂ ਲੈ ਰਿਹਾ ਤਾਂ ਅਸੀਂ ਉਹਨੂੰ ਫੋਰਸ ਨਹੀਂ ਕਰ ਸਕਦੇ ਕਿ ਤੁਸੀਂ ਐਗ ਹੀ ਲਓ ਅਸੀਂ ਉਸ ਦੀ ਥਾਂ ਤੇ ਕੋਈ ਉਹਨੂੰ ਸਬਸਟੀਚਿਊਟ ਦੇ ਸਕਦੇ ਹਾਂ ਜਿੱਦਾਂ ਉਹ ਪਨੀਰ ਲੈ ਸਕਦਾ ਉਹਨੂੰ ਪ੍ਰੋਟੀਨ ਦੀ ਰਿਕੁਆਇਰਮੈਂਟ ਹੈਗੀ ਹੈ ਤਾਂ ਇਸ ਤਰ੍ਹਾਂ ਅਸੀਂ ਪੇਸ਼ੈਂਟ ਨਾਲ ਬਹੁਤ ਵਧੀਆ ਢੰਗ ਨਾਲ ਸਾਰੀਆਂ ਗੱਲਾਂ ਕਰਨੀਆਂ ਹੈਗੀਆਂ ਹੈਲਪਸ ਟੂ ਇੰਪਰੂਵ ਪੇਸ਼ੈਂਟ ਟਰਸਟ ਐਂਡ ਸੈਟਿਸਫੈਕਸ਼ਨ ਮੋਰ ਇਫੈਕਟਿਵ ਪ੍ਰੈਕਟਿਸ ਵਿਦ ਐਪਰੋਪ੍ਰੀਏਟ ਟਰੀਟਮੈਂਟ ਜੇ ਅਸੀਂ ਪੇਸ਼ੈਂਟ ਦਾ ਟਰਸਟ ਗੇਨ ਕਰ ਲੈਂਦੇ ਹਾਂ ਤਾਂ ਉਹਦੀ ਜਿਹੜੀ ਹੈ ਮਤਲਬ ਟਰੀਟਮੈਂਟ ਵਿੱਚ ਸਾਨੂੰ ਬਹੁਤ ਹੈਲਪ ਮਿਲਦੀ ਹੈ ਤੇ ਉਹ ਆਪਣੇ ਟਰੀਟਮੈਂਟ ਲਈ ਖੁਦ ਵੀ ਥੋੜਾ ਆਪਣੇ ਆਪ ਨੂੰ ਚੰਗਾ ਫੀਲ ਕਰਦਾ ਹੈਗਾ ਕਮਿਊਨੀਕੇਸ਼ਨ ਇਨਫਲੂਐਂਸ ਹਾਊ ਕੰਫਰਟੇਬਲ ਪੇਸ਼ੈਂਟ ਫੀਲ ਆਪਣੀ ਕਮਿਊਨੀਕੇਸ਼ਨ ਹੀ ਉਸਨੂੰ ਮਤਲਬ ਕਿ ਕੰਫਰਟੇਬਲ ਫੀਲ ਕਰ ਸਕਦਾ ਉਹ ਕਮਿਊਨੀਕੇਸ਼ਨ ਬਹੁਤ ਇੰਪੋਰਟੈਂਟ ਰੋਲ ਅਦਾ ਕਰਦੀ ਹੈ ਜਦੋਂ ਵੀ ਆਪਾਂ ਕੋਈ ਵੀ ਕਿਸੇ ਨਾਲ ਵੀ ਡੀਲ ਕਰਦੇ ਹਾਂ ਖਾਸ ਕਰ ਪੇਸ਼ੈਂਟ ਨਾਲ ਜੇ ਆਪਾਂ ਸਹੀ ਢੰਗ ਨਾਲ ਗੱਲ ਕਰਦੇ ਹਾਂ ਤਾਂ ਪੇਸ਼ੈਂਟ ਬਹੁਤ ਜ਼ਿਆਦਾ ਮਤਲਬ ਆਪਾਂ ਨੂੰ ਸੁਣਦਾ ਹੈ ਤੇ ਆਪਣੇ ਤੇ ਫੇਥ ਵੀ ਉਹ ਬਹੁਤ ਜ਼ਿਆਦਾ ਕਰਦਾ ਹੈਗਾ ਹੈਲਪ ਇਨ ਡਿਸੀਜ਼ਨ ਮੇਕਿੰਗ ਤੇ ਉਹ ਆਪਣਾ ਇੱਕ ਡਿਸੀਜ਼ਨ ਲੈ ਸਕਦਾ ਹੈ ਕਿ ਮੈਂ ਇਹ ਇਲਾਜ ਕਰਵਾਉਣਾ ਜਾਂ ਨਹੀਂ ਕਰਵਾਉਣਾ ਜਾਂ ਮੈਂ ਇੱਦਾਂ ਅੱਗੇ ਜਾਣਾ ਹੈਗਾ ਕੀਮੋਥੈਰੇਪੀ ਲਈ ਇਨੇਬਲ ਪੇਸ਼ੈਂਟ ਸੈਲਫ ਮੈਨੇਜਮੈਂਟ ਤੇ ਜੇ ਅਸੀਂ ਉਹਦੇ ਨਾਲ ਸਹੀ ਗੱਲ ਕਰ ਰਹੇ ਹਾਂ ਸਹੀ ਡਿਸੀਜ਼ਨ ਲੈਣ 'ਚ ਮਦਦ ਕਰ ਰਹੇ ਹਾਂ ਤਾਂ ਉਹ ਆਪਣਾ ਸੈਲਫ ਮੈਨੇਜਮੈਂਟ ਵੀ ਕਰ ਲੈਂਦਾ ਹੈਗਾ ਨੈਕਸਟ ਹੈ ਪੇਸ਼ੈਂਟ ਸੈਂਟਰ ਕੇਅਰ ਪੇਸ਼ੈਂਟ ਦੀ ਜਿਹੜੀ ਸੈਂਟਰ ਕੇਅਰ ਹੈਗੀ ਆ ਉਹ ਇਨਫੋਰਮਡ ਐਕਟੀਵੇਟ ਪਾਰਟੀਸਪੇਟ ਪੇਸ਼ੈਂਟ ਐਂਡ ਫੈਮਿਲੀ ਉਹਦੇ ਵਿੱਚ ਉਹਦੀ ਫੈਮਿਲੀ ਪੂਰੀ ਇਨਵੋਲਵ ਹੁੰਦੀ ਹੈ ਪੂਰੀ ਫੈਮਿਲੀ ਐਕਟੀਵਿਟੀ ਲਈ ਪਾਰਟੀਸਪੇਟ ਕਰੇ ਦੈਨ ਅਸੈਸੀਬਲ ਵੈਲ ਆਰਗੇਨਾਈਜ਼ਡ ਰਿਸਪੈਕਟਿਵ ਹੈਲਥ ਕੇਅਰ ਸਿਸਟਮ ਤੇ ਉਹਨੂੰ ਇੱਕ ਚੰਗਾ ਸਿਸਟਮ ਮਿਲੇ ਇਹ ਨਹੀਂ ਕਿ ਉਹ ਇੱਥੇ ਆਪਣੇ ਟੈਸਟ ਕਰਵਾ ਰਿਹਾ ਹੈਗਾ ਦੂਸਰੀ ਜਗ੍ਹਾ ਤੇ ਜਾ ਕੇ ਆਪਣਾ ਕੁਝ ਹੋਰ ਲੈ ਰਿਹਾ ਤਾਂ ਪੇਸ਼ੈਂਟ ਨੂੰ ਇੱਦਾਂ ਨਹੀਂ ਉਹਨੂੰ ਪੂਰਾ ਵੈਲ ਆਰਗੇਨਾਈਜ਼ਡ ਸਾਰਾ ਐਸਟੈਬਲਿਸ਼ਮੈਂਟ ਆਰਗੇਨਾਈਜੇਸ਼ਨ ਹੋਣੀ ਚਾਹੀਦੀ ਹੈ ਕਿ ਉਹਨੂੰ ਮਤਲਬ ਇੱਕ ਫੈਸਿਲਿਟੀ ਤੋਂ ਬਾਅਦ ਦੂਸਰੀ ਦਾ ਪਤਾ ਹੋਣਾ ਚਾਹੀਦਾ ਕਿ ਮੈਨੂੰ ਇੱਥੇ ਮਿਲ ਰਹੀ ਹੈ ਥਰਡ ਹੈ ਪੇਸ਼ੈਂਟ ਸੈਂਟਰ ਕਲੀਨੀਸ਼ੀਅਨ ਵਿਦ ਗੁੱਡ ਕਮਿਊਨੀਕੇਸ਼ਨ ਸਕਿੱਲ। ਜਿੰਨੇ ਵੀ ਕਲੀਨੀਸ਼ੀਅਨ ਆ ਜਿਹੜੇ ਉਹਦੇ ਨਾਲ ਡੀਲ ਕਰ ਰਹੇ ਨੇ, ਜਿੱਦਾਂ ਨਰਸਸ ਨੇ, ਹੋਰ ਵੀ ਹੈਲਥ ਵਰਕਰਸ ਨੇ, ਤਾਂ ਉਹਦੇ ਨਾਲ ਉਹਦਾ ਮਤਲਬ ਕਮਿਊਨੀਕੇਸ਼ਨ ਗੁੱਡ ਹੋਣੀ ਚਾਹੀਦੀ ਹੈ। ਜੇ ਉਹਦਾ ਮਤਲਬ ਬੋਲ ਚਾਲ ਦਾ ਰਵੱਈਆ ਜਾਂ ਉਹਦੇ ਗੱਲ ਸਮਝਣ ਦਾ ਸਾਰਿਆਂ 'ਚ ਹੋਏਗਾ, ਤਾਂ ਉਹ ਉਹਦਾ ਵਧੀਆ ਇੰਪਰੂਵਮੈਂਟ ਹੋਏਗੀ ਉਹਦੀ ਮਤਲਬ ਹੈਲਥ ਦੇ ਵਿੱਚ। ਨੈਕਸਟ ਹੈ ਕਿ ਇੱਕ ਸਰਵੇ ਕੀਤਾ ਗਿਆ ਸੀਗਾ 1/68 ਅਡਲਟਸ ਤੇ ਹੂ ਹੈਡ ਸੀਨ ਐਟ ਲੀਸਟ ਵਨ ਹੈਲਥ ਕੇਅਰ ਕਲੀਨਿਸ਼ੀਅਨ। ਉਹਨਾਂ ਨੇ ਇਸ ਗੱਲ ਦਾ ਕਿਹਾ ਕਿ ਆਈ ਵਾਂਟ ਮਾਈ ਹੈਲਥ ਕੇਅਰ ਕਲੀਨਿਸ਼ੀਅਨ। ਉਹ ਮੈਨੂੰ ਸੁਣਦੇ ਹੀ ਨਹੀਂ। ਫਸਟ ਗੱਲ ਇਹ ਸੀ ਕਿ 92% ਲੋਕ ਇਹ ਕਹਿ ਰਹੇ ਸੀ ਕਿ ਸਾਡੀ ਉਹ ਗੱਲ ਹੀ ਨਹੀਂ ਧਿਆਨ ਨਾਲ ਸੁਣਦੇ ਹੈਗੇ। ਤਾਂ ਫਿਰ ਉਹਨਾਂ ਦਾ ਜਿਹੜਾ ਹੈਗਾ ਉਹਨਾਂ ਨੂੰ ਫੁੱਲ ਟਰੂਥ ਨਹੀਂ ਪਤਾ ਹੁੰਦੀ ਕਿ ਸਾਨੂੰ ਕਿਹੜੀ ਡਿਜ਼ੀਜ਼ ਹੈ ਤੇ ਕੀ ਸਾਡਾ ਅੱਗੇ ਕੀ ਹੋਣਾ ਹੈਗਾ, ਕਿੱਦਾਂ ਸਾਡਾ ਅੱਗੇ ਹੋਣਾ ਹੈਗਾ, ਮਤਲਬ ਟਰੀਟਮੈਂਟ ਕੀ ਹੋਣਾ ਹੈ, ਉਹਦੇ ਸਾਡੇ ਸਾਈਡ ਇਫੈਕਟਸ ਕੀ ਹੋਣੇ ਹੈਗੇ ਹੈ ਨਾ। ਤਾਂ ਇਸ ਕਰਕੇ ਜਿਹੜਾ ਵੀ ਮਤਲਬ ਉਹਦੀ ਪੂਰੀ ਗੱਲ ਸੁਣਨੀ ਚਾਹੀਦੀ ਹੈ ਪੇਸ਼ੈਂਟ ਦੀ, ਤੇ ਉਹਨੂੰ ਸਾਰੀਆਂ ਗੱਲਾਂ ਮਤਲਬ ਟਰੂਥ ਦੱਸਣਾ ਚਾਹੀਦਾ ਕਿ ਇਹ ਤੈਨੂੰ ਡਿਜ਼ੀਜ਼ ਹੈ ਤੇ ਇਹਦਾ ਇਸ ਤਰ੍ਹਾਂ ਟਰੀਟਮੈਂਟ ਹੋਏਗਾ ਔਰ ਇੰਨਾ ਟਾਈਮ ਲੱਗ ਜਾਏਗਾ ਔਰ ਇਹ ਤੈਨੂੰ ਵਿੱਚ ਡਿਫਿਕਲਟੀਜ਼ ਆਉਣਗੀਆਂ ਜਾਂ ਇੱਦਾਂ। ਫਿਰ ਉਹ ਬਹੁਤ ਕੋਆਪਰੇਟ ਕਰਦੇ ਆ ਪੇਸ਼ੈਂਟ ਤੇ, ਔਰ ਉਹ ਆਪਣੇ ਲਈ ਖੁਦ ਵੀ ਕਾਫੀ ਐਫਰਟਸ ਕਰਦੇ ਹੈਗੇ ਆ। ਬਹੁਤ ਸਾਰੇ ਲੋਕਾਂ ਨੇ ਇਹ ਦੱਸਿਆ ਕਿ ਮੈਨੂੰ ਇਸ ਗੱਲ ਦਾ ਵੀ ਪਤਾ ਹੋਣਾ ਚਾਹੀਦਾ ਕਿ ਮੇਰੀ ਕੁਆਲਿਟੀ ਆਫ ਲਾਈਫ ਕਿਹੋ ਜਿਹੀ ਹੋਏਗੀ ਜੇ ਮੈਂ ਇਲਾਜ ਕਰਵਾ ਲਾਂਗਾ ਜਾਂ ਮੇਰੀ ਬ੍ਰੈਸਟ ਰਿਮੂਵ ਹੋ ਜਾਏਗੀ ਤਾਂ ਮੇਰੀ ਅਗਲੀ ਲਾਈਫ ਕਿੱਦਾਂ ਦੀ ਹੋਏਗੀ। ਤਾਂ ਇਹ ਸਾਰੀਆਂ ਗੱਲਾਂ ਉਹਨਾਂ ਨੂੰ ਨਹੀਂ ਸੀ ਪਤਾ, ਤੇ ਉਹ ਚਾਹੁੰਦੇ ਸੀ ਕਿ ਇਹ ਸਾਰੀਆਂ ਗੱਲਾਂ ਡਾਕਟਰ ਸਾਡੇ ਨਾਲ ਕਰੇ। ਈਵਨ ਕਿ ਉਹ ਚਾਹੁੰਦੇ ਆ ਕਿ ਸਾਡੇ ਜਿਹੜਾ ਖਰਚਾ ਹੋਣਾ ਹੈਗਾ, ਮਤਲਬ ਕਿ ਜੋ ਸਾਡਾ ਪੂਰਾ ਟਰੀਟਮੈਂਟ ਦਾ ਖਰਚਾ ਹੈ ਜਾਂ ਅਸੀਂ ਇਹ ਟਰੀਟਮੈਂਟ ਲੈਣਾ, ਇਹ ਟਰੀਟਮੈਂਟ ਨਹੀਂ ਲੈਣਾ, ਤੇ ਇਹਦੇ ਬਾਰੇ ਉਹਨਾਂ ਨੂੰ ਪਤਾ ਹੋਣਾ ਚਾਹੀਦਾ ਹੈਗਾ। ਕਮਿਊਨੀਕੇਸ਼ਨ ਸਕਿੱਲਸ, ਪੇਸ਼ੈਂਟ ਸੈਂਟਰ ਕਮਿਊਨੀਕੇਸ਼ਨ ਬੇਸਿਕ ਸਕਿੱਲਸ ਹੈ। ਸਭ ਤੋਂ ਪਹਿਲਾਂ ਤਾਂ ਇਹ ਆਉਂਦਾ ਕਿ ਕਮਿਊਨੀਕੇਸ਼ਨ ਸਕਿੱਲ ਹੈ ਜਿਹੜੀ ਉਹ ਓਪਨ ਐਂਡਡ ਕੁਐਸਚਨਸ ਹੋਣੇ ਚਾਹੀਦੇ ਆ। ਆਪਾਂ ਪੇਸ਼ੈਂਟ ਨੂੰ ਇੱਦਾਂ ਨਹੀਂ ਕਿ ਮਤਲਬ ਉਹਨਾਂ ਨੂੰ ਪਹਿਲਾਂ ਜੇ ਕੀਮੋ ਦਿੱਤੀ ਹੈ ਤਾਂ ਸੈਕਿੰਡ ਟਾਈਮ ਆਪਾਂ ਉਹਨਾਂ ਨੂੰ ਪੁੱਛਣਾ ਹੈ ਕਿ ਤੁਹਾਡੀ ਕੀਮੋ ਦਾ ਕਿੱਦਾਂ ਦਾ ਤੁਹਾਡਾ ਰਿਹਾ, ਜਿਹੜੇ ਤੁਸੀਂ 15 ਦਿਨ 20 ਦਿਨ ਘਰ ਲਾਏ ਨੇ ਤਾਂ ਉਹ ਤੁਸੀਂ ਕਿੱਦਾਂ ਦਾ ਫੀਲ ਕੀਤਾ ਹੈਗਾ। ਤਾਂ ਉਹਨਾਂ ਜੇ ਉਹ ਆਪਾਂ ਨੂੰ ਕੁਝ ਦੱਸ ਰਹੇ ਆ ਤਾਂ ਆਪਾਂ ਉਹਨਾਂ ਨੂੰ ਇੰਟਰਪਟ ਨਹੀਂ ਕਰਨਾ, ਵਾਰ-ਵਾਰ ਕੱਟ ਆਫ ਨਹੀਂ ਕਰਨਾ, ਉਹਨਾਂ ਦੀ ਗੱਲ ਨੂੰ ਧਿਆਨ ਨਾਲ ਆਪਾਂ ਸੁਣਨਾ ਹੈਗਾ। ਉਹਨਾਂ ਨੂੰ ਮਤਲਬ ਇੱਕ ਐਕਟਿਵ ਲਿਸਨਰ ਦੇ ਤੌਰ 'ਤੇ ਆਪਾਂ ਉਹਨਾਂ ਨੂੰ ਹਰ ਗੱਲ ਸੁਣਨੀ ਹੈਗੀ ਹੈ। ਤੇ 60 ਸੈਕਿੰਡ ਨੂੰ ਆਪਾਂ ਗੋਲਡਨ ਮਿੰਟਸ ਕਹਿੰਦੇ ਆ ਕਿ ਉਹ ਬਹੁਤ ਧਿਆਨ ਨਾਲ ਉਹਨੂੰ ਸੁਣਨਾ ਹੈਗਾ। ਤਾਂ ਪੇਸ਼ੈਂਟ ਦੇ ਅੰਡਰਸਟੈਂਡ ਪੇਸ਼ੈਂਟਸ ਪਰਸਪੈਕਟਿਵਸ, ਫੀਲਿੰਗਸ, ਆਈਡੀਆਜ਼, ਕੰਸਰਨਸ, ਐਕਸਪੀਰੀਅੰਸ ਰਿਗਾਰਡਿੰਗ ਦਾ ਇੰਪੈਕਟ ਆਫ ਇਲਨੈਸ ਦੇ ਰਿਗਾਰਡਿੰਗ ਉਹਨਾਂ ਦਾ ਕੀ ਐਕਸਪੀਰੀਅੰਸ ਰਿਹਾ, ਉਹਨੂੰ ਵੀ ਬੜੇ ਧਿਆਨ ਨਾਲ ਸੁਣਨਾ ਹੈ। ਤੇ ਉਹ ਐਕਸਪੈਕਟ ਕੀ ਕਰਦਾ ਪਿਆ ਹੈਗਾ ਆਪਣੇ ਫਿਜ਼ੀਸ਼ੀਅਨਸ ਤੋਂ, ਐਕਸਪੈਕਟੇਸ਼ਨਸ ਵੀ ਉਹਦੀਆਂ ਧਿਆਨ ਨਾਲ ਸੁਣਨੀਆਂ ਹੈਗੀਆਂ। ਐਮਥੀ ਕੈਨ ਬੀ ਐਕਸਪ੍ਰੈਸਡ ਬਾਈ ਨੇਮ ਦਾ ਫੀਲਿੰਗ, communicate understanding, respect and support. Explore patients illness experience and emotions. ਇਹਦੇ ਇਲਨੈਸ ਦੇ ਦੌਰਾਨ ਉਹਦੇ ਕੀ ਐਕਸਪੀਰੀਅੰਸ ਹੈ, ਉਹਦੇ ਇਮੋਸ਼ਨਸ ਕਿੱਦਾਂ ਡਿਸਟਰਬ ਹੁੰਦੇ ਨੇ, ਇਹ ਸਾਰੀਆਂ ਗੱਲਾਂ ਉਹਨੂੰ ਆਪਾਂ ਫੀਲ ਕਰਨੀਆਂ ਹੈਗੀਆਂ ਐਜ਼ ਏ ਨਰਸ, ਐਜ਼ ਏ ਹੈਲਥ ਕੇਅਰ ਵਰਕਰ। ਬਿਫੋਰ ਐਂਡ ਆਫਟਰ ਏ ਡਾਇਗਨੋਸਿਸ, ਜਦੋਂ ਵੀ ਉਹਦਾ ਡਾਇਗਨੋਸ ਨਹੀਂ ਹੋਇਆ, ਉਹਨੂੰ ਨਹੀਂ ਪਤਾ ਹੈ ਕਿ ਮੈਨੂੰ ਕੈਂਸਰ ਹੈ, ਤਾਂ ਉਸ ਤੋਂ ਪਹਿਲਾਂ ਉਹਦੀ ਕਿਸ ਤਰ੍ਹਾਂ ਦੀ ਨੌਲੇਜ ਹੈਗੀ ਉਹਦੀ ਕੈਂਸਰ ਦੇ ਬਾਰੇ, ਉਹ ਕਿਸ ਤਰ੍ਹਾਂ ਦੀ ਉਹਦੀ ਸੋਚ ਰੱਖਦਾ ਹੈਗਾ, ਜਾਂ ਉਹਦੀਆਂ ਕੀ ਉਹਦੀ ਡੈਪਥ ਆਫ ਨੌਲੇਜ ਉਹਦੀ ਕੀ ਹੈ, ਇਨਫੋਰਮੇਸ਼ਨ ਉਹਦੇ ਬਾਰੇ ਆਪਾਂ ਜਾਣਨਾ ਹੈਗਾ। ਇਹ ਨਹੀਂ ਕਿ ਇੱਕਦਮ ਉਹਨੂੰ ਆਪਾਂ ਇੱਦਾਂ ਕਰ ਦੇਣਾ, ਉਹਦੀਆਂ ਵੀ ਪਹਿਲਾਂ ਸੁਣਨੀਆਂ ਹੈਗੀਆਂ ਪੇਸ਼ੈਂਟ ਦੀਆਂ ਗੱਲਾਂ। ਆਫਟਰ ਡਿਸਕਲੋਜ਼ਿੰਗ ਏ ਡਾਇਗਨੋਸ, ਐਕਸਪਲੋਰ ਪੇਸ਼ੈਂਟਸ ਇਮੋਸ਼ਨਲ ਰਿਸਪੌਂਸ। ਔਰ ਜਦ ਅਸੀਂ ਕਿਸੇ ਨੂੰ ਦੱਸ ਦਿੰਦੇ ਹਾਂ ਕਿ ਤੈਨੂੰ ਇਹ ਪ੍ਰੋਬਲਮ ਹੈਗੀ ਹੈ, ਤਾਂ ਉਹਦੇ ਜਿਹੜੇ ਇਮੋਸ਼ਨਲ ਮਤਲਬ ਉਹ ਬਹੁਤ ਡਿਸਟਰਬ ਹੋ ਜਾਂਦਾ, ਉਹਨੂੰ ਵੀ ਆਪਾਂ ਰਿਸਪੌਂਸ ਕਰਨਾ। ਇਹ ਨਹੀਂ ਕਿ ਆਪਾਂ ਇੱਕਦਮ ਉਹਨੂੰ ਦੱਸਤਾ ਤੇ ਉਹ ਇੱਕਦਮ ਫੇਂਟ ਹੋ ਜੇ, ਹੈ ਨਾ, ਇਸ ਤਰ੍ਹਾਂ ਦੀ ਕਿਸੇ ਚੱਲ ਜੇ। ਤਾਂ ਅੱਗੇ ਇਸ ਤੋਂ ਬਾਅਦ ਫਿਰ ਟਰੀਟਮੈਂਟ ਆਪਸ਼ਨਸ, ਸ਼ੇਅਰ ਡਿਸੀਜ਼ਨ ਮੇਕਿੰਗ, empower patients by inviting them to consider। ਉਹਨੂੰ ਮਤਲਬ ਕਿ ਉਹਦੇ ਨਾਲ ਸ਼ੇਅਰ ਕਰਨਾ ਸਾਰਾ ਡਿਸੀਜ਼ਨ, ਵੀ ਤੁਹਾਡੇ ਆਹ ਟਰੀਟਮੈਂਟ ਹੋਣਾ, ਤੁਸੀਂ ਕੀ ਕਰਵਾਉਣਾ ਚਾਹੁੰਦੇ ਹੋ, ਇਹਦੇ ਤੁਹਾਨੂੰ ਬੈਨੀਫਿਟਸ ਨੇ, ਇਹਦੇ ਤੁਹਾਡੇ ਲਈ ਕੀ ਨੁਕਸਾਨ ਨੇ, ਤੇ ਪ੍ਰੋਜ਼ ਐਂਡ ਕੌਨਸ ਟਰੀਟਮੈਂਟ ਦੇ ਪੂਰੇ ਉਹਨੂੰ ਦੱਸਣੇ ਹੈ ਕਿ ਇਹਦੇ ਤੁਹਾਨੂੰ ਫਾਇਦੇ ਇਹ ਨੇ ਤੇ ਆਉਣ ਵਾਲੀ ਲਾਈਫ ਤੁਹਾਡੇ ਇਹ ਨੁਕਸਾਨ ਹੋ ਸਕਦੇ ਨੇ ਜੇ ਤੁਸੀਂ ਨਹੀਂ ਕਰਵਾਉਂਦੇ ਤਾਂ। ਤੇ ਜੇ ਤੁਸੀਂ ਟਰੀਟਮੈਂਟ ਨਹੀਂ ਵੀ ਕਰਵਾਉਂਦੇ ਤਾਂ ਤੁਹਾਡੀ ਅਗਲੀ ਲਾਈਫ ਕਿੱਦਾਂ ਇਫੈਕਟ ਹੋਏਗੀ, ਇਹ ਵੀ ਚੀਜ਼ ਆਪਾਂ ਉਹਨੂੰ ਸਮਝਾਉਣੀ ਹੈਗੀ ਹੈ। ਔਰ ਹਮੇਸ਼ਾ ਮਤਲਬ ਉਹਨੂੰ ਕੁਛ ਦੱਸਣਾ, ਕੁਛ ਪੁੱਛਣਾ, ਥੋੜ੍ਹਾ ਉਹ ਤਾਂ ਸੁਣਨਾ, ਫਿਰ ਆਪਣੇ ਵੱਲੋਂ ਕੁਛ ਹੈ ਨਾ, ਮਤਲਬ ਸਮਾਲ ਚੰਕਸ ਆਫ ਡਾਟਾ ਉਹਦੇ ਨਾਲ ਡਿਲੀਵਰ ਕਰਨਾ। ਐ ਨਹੀਂ ਕਿ ਇੱਕ ਵਾਰੀ ਆਪਾਂ ਬਹੁਤ ਜ਼ਿਆਦਾ ਕੁਛ ਉਹਨੂੰ ਦੱਸਤਾ ਕਿ ਉਹ ਇੰਨਾ ਅਬਜ਼ਰਵ ਹੀ ਨਾ ਕਰ ਪਾਉਂਦਾ ਹੋਵੇ, ਇੱਦਾਂ ਦਾ ਹੈਗਾ। ਤੇ ਸਿਰਫ ਉਹਨੂੰ ਹੀ ਨਹੀਂ ਕਹਿਣਾ ਕਿ ਦੱਸੀ ਜਾ ਜਾਂ ਆਪਾਂ ਹੀ ਦੱਸੀ ਜਾਈਏ, ਮਤਲਬ ਤੇ ਉਹਨੂੰ ਉਹਦੀਆਂ ਵੀ ਸੁਣਨੀਆਂ, ਆਪਣੀਆਂ ਵੀ ਦੱਸਣੀਆਂ। ਇਹ ਡਾਇਮੈਂਸ਼ਨਸ ਆਫ ਪੇਸ਼ੈਂਟ ਸੈਂਟਰ ਕੇਅਰ, ਪੇਸ਼ੈਂਟਸ ਦੀਆਂ ਪ੍ਰੈਫਰੈਂਸ ਨੂੰ ਧਿਆਨ ਵਿੱਚ ਰੱਖਦੇ ਹੋਏ
ਉਹਨੂੰ ਇਮੋਸ਼ਨਲ ਸਪੋਰਟ, ਉਹਦੀ ਫਿਜ਼ੀਕਲੀ ਕੰਫਰਟ ਨੂੰ ਦੇਖਣਾ ਹੈਗਾ, ਇਨਫੋਰਮੇਸ਼ਨ ਐਂਡ ਐਜੂਕੇਸ਼ਨ ਉਹਨੂੰ ਪੂਰੀ ਦੇਣੀ ਹੈਗੀ ਹੈ। ਦੈਨ ਫੈਮਿਲੀ ਐਂਡ ਫਰੈਂਡਸ ਦੀ ਇਹਦੇ ਵਿੱਚ ਇਨਵੋਲਵਮੈਂਟ ਹੋਣੀ ਚਾਹੀਦੀ ਹੈ। ਤਾਂ ਫਿਰ ਆਪਾਂ ਦੇਖਣਾ ਕਿ ਜੋ ਅਸੀਂ ਉਹਨੂੰ ਕੇਅਰ ਦਿੱਤੀ ਹੈ ਤੇ ਉਹਦਾ ਕੀ ਹੈ, ਅਸੈਸ ਟੂ ਕੇਅਰ ਤੇ ਕੋਆਰਡੀਨੇਸ਼ਨ ਹੋਣੀ ਚਾਹੀਦੀ ਹੈ ਸਾਰੀ ਕੇਅਰਸ ਦੇ ਵਿੱਚ। ਤੇ ਦੈਨ ਕੰਟੀਨਿਊਟੀ ਐਂਡ ਟ੍ਰਾਂਸਲੇਸ਼ਨ। ਨੈਕਸਟ ਟੌਪਿਕ ਹੈ ਚੈਲੰਜ ਟੂ ਪੇਸ਼ੈਂਟ ਸੈਂਟਰਡ ਕਮਿਊਨੀਕੇਸ਼ਨ ਐਂਡ ਸ਼ੇਅਰ ਡਿਸੀਜ਼ਨ ਮੇਕਿੰਗ ਇਨ ਕੈਂਸਰ। ਜਦੋਂ ਵੀ ਅਸੀਂ ਕੋਈ ਇਹਦਾ ਲੈਣੇ ਹੈਗੇ ਆ ਤਾਂ ਉਹਦੇ ਵਿੱਚ ਸਾਨੂੰ ਕੀ ਚੈਲੰਜਸ ਆਉਂਦੇ ਨੇ। ਚੈਲੰਜਸ ਬਹੁਤ ਸਾਈਡ ਤੋਂ ਆਉਂਦੇ ਨੇ, ਪੇਸ਼ੈਂਟਸ ਨੂੰ ਵੀ ਬਹੁਤ ਚੈਲੰਜਸ ਆਉਂਦੇ ਨੇ ਤੇ ਜਿਹੜੇ ਹੈਲਥ ਕੇਅਰ ਪ੍ਰੋਫੈਸ਼ਨਲਸ ਨੇ ਉਹਨਾਂ ਨੂੰ ਵੀ ਬੜੇ ਚੈਲੰਜ ਆਉਂਦੇ ਨੇ। ਹੈਲਥ ਕੇਅਰ ਪੇਸ਼ੈਂਟਸ ਮਤਲਬ ਜਿਹੜੇ ਪੇਸ਼ੈਂਟਸ ਨੂੰ ਆਉਂਦੇ ਨੇ ਉਹਦੇ ਵਿੱਚ ਕੀ ਉਹਨੂੰ ਟ੍ਰੀਟਮੈਂਟ ਆਈਡੈਂਟੀਫਿਕੇਸ਼ਨ ਕਰਨ ਵਿੱਚ ਪ੍ਰੋਬਲਮ ਆਉਂਦੀ ਹੈ ਨਾ। ਨੈਕਸਟ ਉਹਦੇ ਇਮੋਸ਼ਨਸ ਜਿਹੜੇ ਨੇ ਬਹੁਤ ਹੀ ਇਨਸਟੇਬਿਲਿਟੀ ਹੋ ਜਾਂਦੀ ਹੈ ਜਦੋਂ ਕਿਸੇ ਨੂੰ ਇਹ ਪਤਾ ਲੱਗਦਾ ਕਿ ਮੈਨੂੰ ਇਹ ਪ੍ਰੋਬਲਮ ਹੈਗੀ ਹੈ। ਤਾਂ ਉਹਦੇ ਵਿੱਚ ਇੱਕ ਕੌਨਫੀਡੈਂਸ ਨਹੀਂ ਰਹਿੰਦਾ ਹੈਗਾ ਤੇ ਕਿਉਂਕਿ ਉਹਨੂੰ ਕਿਹੜਾ ਇਸ ਤਰ੍ਹਾਂ ਦਾ ਕੋਈ ਐਕਸਪੀਰੀਅੰਸ ਹੁੰਦਾ ਹੈਗਾ, ਉਹਨੂੰ ਇਸ ਤਰ੍ਹਾਂ ਦਾ ਕੋਈ ਐਕਸਪੀਰੀਅੰਸ ਨਹੀਂ ਹੁੰਦਾ ਕਿ ਇੱਦਾਂ ਦੀ ਕੋਈ ਡਿਜ਼ੀਜ਼ ਨਾਲ। ਔਰ ਬਹੁਤ ਸਾਰੇ ਪੇਸ਼ੈਂਟ ਇੱਦਾਂ ਦੇ ਹੁੰਦੇ ਕਿ ਜਿਹੜੇ ਕਹਿੰਦੇ ਕਿ ਅਸੀਂ ਕਦੇ ਸੂਈ ਲਗਵਾਈ ਨਹੀਂ ਹੈ, ਮਤਲਬ ਕਿ ਉਹਨਾਂ ਨੂੰ ਇੱਕ ਸੂਈ ਲਗਵਾਉਣ ਦਾ ਵੀ ਐਕਸਪੀਰੀਅੰਸ ਨਹੀਂ ਹੁੰਦਾ। ਇਹਦੇ ਵਿੱਚ ਇਹਦੇ ਲੈਕ ਆਫ ਪਾਰਟੀਸਪੇਸ਼ਨ ਡਿਊ ਟੂ ਲੈਵਲ ਆਫ ਐਜੂਕੇਸ਼ਨ, ਉਹਨਾਂ ਦਾ ਐਜੂਕੇਸ਼ਨ ਦਾ ਲੈਵਲ ਹੀ ਇੰਨਾ ਨਹੀਂ ਹੁੰਦਾ ਹੈਗਾ ਹਾਈ ਕਿ ਉਹ ਸਮਝ ਸਕਣ। ਮਤਲਬ ਕਿ ਜਿੰਨਾ ਉਹਨਾਂ ਦਾ ਐਜੂਕੇਸ਼ਨ ਦਾ ਲੈਵਲ ਹੈ, ਮਤਲਬ ਕਿ ਜਿਹੜੀ ਡਿਜ਼ੀਜ਼ ਉਹਨਾਂ ਨੂੰ ਹੋ ਗਈ ਉਹਨੂੰ ਆਪਾਂ ਡਿਟੇਲ 'ਚ ਨਹੀਂ ਦੱਸ ਸਕਦੇ ਕਿ ਇਹ ਸੈੱਲ 'ਤੇ ਇੱਦਾਂ ਹੋ ਰਿਹਾ, ਇਹ ਹੋ ਰਿਹਾ। ਮਤਲਬ ਜਿੰਨਾ ਉਹਨਾਂ ਦਾ ਲੈਵਲ ਆ ਉਸ ਐਜੂਕੇਸ਼ਨ ਦੇ ਲੈਕ ਆਫ ਉਹਨਾਂ ਨੂੰ ਘੱਟ ਹੈਗੇ, ਨੌਲੇਜ ਹੈਗੀ ਹੈ, ਤਾਂ ਵੀ ਨਹੀਂ ਉਹਨਾਂ ਨੂੰ ਪਤਾ ਹੁੰਦਾ। ਉਹ ਆਪਣਾ ਬ੍ਰੈਸਟ ਚੈੱਕਅਪ ਕਰਾਉਂਦੇ ਹੀ ਨਹੀਂ ਹੈਗੇ ਕਿਉਂਕਿ ਉਹਨਾਂ ਨੂੰ ਇਸ ਚੱਕਰ ਦਾ ਨੌਲੇਜ ਪਤਾ ਹੀ ਨਹੀਂ ਹੈਗਾ, ਨੌਲੇਜ ਹੀ ਨਹੀਂ ਹੈਗੀ, ਐਜੂਕੇਸ਼ਨ ਹੀ ਨਹੀਂ ਹੈਗੀ। ਤੇ ਜੈਂਡਰ ਦੇ ਵਿੱਚ ਬਹੁਤ ਪ੍ਰੋਬਲਮ ਆਉਂਦੀ ਹੈ। ਫੀਮੇਲਸ ਆਲਵੇਜ਼ ਆਪਣੇ ਆਪ ਨੂੰ ਮਤਲਬ ਕਿ ਨਹੀਂ ਐਕਸਪ੍ਰੈਸ ਕਰ ਪਾਉਂਦੀਆਂ ਕਿਉਂਕਿ ਜਿਹੜਾ ਮੇਲ ਹੈ, ਮੇਲ ਇੱਕਦਮ ਡਿਸੀਜ਼ਨ ਲੈ ਲੇਗਾ ਕਿ ਮੈਨੂੰ ਪ੍ਰੋਬਲਮ ਹੈ ਤੇ ਮੈਂ ਇਲਾਜ ਕਰਵਾਉਣਾ ਹੈਗਾ। ਪਰ ਜਿਹੜੀਆਂ ਫੀਮੇਲਸ ਹੈ, ਫੀਮੇਲਸ ਨੂੰ ਨਾਲ ਆਪਣੇ ਹਸਬੈਂਡ ਦੀ ਜਾਂ ਫੈਮਿਲੀ ਨੂੰ ਨਾਲ ਲੈ ਕੇ ਚੱਲਣਾ ਪੈਂਦਾ। ਇਸ ਕਰਕੇ ਜੈਂਡਰ, ਪਰਸਨੈਲਿਟੀ, ਓਰੀਐਂਟੇਸ਼ਨ ਸਭ ਕੁਛ ਇਹਦੇ ਵਿੱਚ ਮਤਲਬ ਕਿ ਉਹਨਾਂ ਨੂੰ ਚੈਲੰਜਸ ਆਉਂਦੇ ਨੇ ਪੇਸ਼ੈਂਟਸ ਨੂੰ। ਹੈਲਥ ਕੇਅਰ ਪ੍ਰੋਫੈਸ਼ਨਲਸ ਨੂੰ ਵੀ ਇਸੇ ਤਰ੍ਹਾਂ ਹੀ ਕੁਛ ਚੈਲੰਜ ਆਉਂਦੇ ਨੇ, ਜਿੱਦਾਂ ਏਜ ਦਾ, ਜੈਂਡਰ ਦਾ, ਟ੍ਰੇਨਿੰਗ ਦਾ। ਸਮਟਾਈਮ ਇੱਕ ਮੇਲ ਡਾਕਟਰ ਬੈਠਾ ਤਾਂ ਫੀਮੇਲ ਜਿਹੜੀ ਮਤਲਬ ਕਿ ਆਪਣੇ ਆਪ ਨੂੰ ਸਹੀ ਗੱਲਾਂ ਨਹੀਂ ਦੱਸ ਸਕੇਗੀ, ਜਿੱਦਾਂ ਮੀਨੋਪੌਜ਼ ਬਾਰੇ ਜਾਂ ਇੱਦਾਂ ਲਾ ਲਓ ਕਿ ਹੁਣ ਇਹ ਗੱਲ ਕਰ ਰਹੇ ਸੀ ਕਿ ਉਹਦੇ ਹਸਬੈਂਡ ਫਰਜ਼ ਕਰੋ ਡਾਈਡ ਹੈ, ਮਤਲਬ ਮਰ ਚੁੱਕੇ ਨੇ, ਹੈ ਨਾ। ਤਾਂ ਫਿਰ ਉਹ ਕੀ ਆਪਣੇ ਬੇਟੇ ਨੂੰ ਇਹ ਗੱਲਾਂ ਨਹੀਂ ਦੱਸ ਸਕਦੀ ਕਿ ਮੈਨੂੰ ਬਲੀਡਿੰਗ ਹੁੰਦੀ ਹੈ ਜਾਂ ਮੈਨੂੰ ਇੱਦਾਂ ਦੀ ਕੋਈ ਪ੍ਰੋਬਲਮ ਹੈ, ਮੇਰੇ ਬ੍ਰੈਸਟ ਵਿੱਚ ਲੰਪ ਹੈ, ਹੈ ਨਾ। ਇੱਦਾਂ ਦੀਆਂ ਬੜੀਆਂ ਪ੍ਰੋਬਲਮਸ ਆਉਂਦੀਆਂ ਨੇ। ਏਜ ਦਾ, ਜੈਂਡਰ, ਮਤਲਬ ਟ੍ਰੇਨਿੰਗ, ਇਹ ਸਾਰੀਆਂ। ਤੇ ਲੈਕ ਆਫ ਟ੍ਰੇਨਿੰਗ ਇਨ ਕਮਿਊਨੀਕੇਸ਼ਨ, ਹੈ ਨਾ। ਮਤਲਬ ਕਿ ਜਿਹੜੇ ਹੈਲਥ ਕੇਅਰ ਵਰਕਰਸ ਨੇ ਉਹਨਾਂ ਵਿੱਚ ਵੀ ਟ੍ਰੇਨਿੰਗ ਦੀ ਬਹੁਤ ਘਾਟ ਹੈ। ਬਾਕੀ ਲੋਟਸ ਆਫ ਪੇਸ਼ੈਂਟ ਹੋਣ ਕਰਕੇ ਮਤਲਬ ਹਰ ਜਗ੍ਹਾ ਇੰਨਾ ਰਸ਼ ਹੈ ਵੀ ਕਮਿਊਨੀਕੇਸ਼ਨ ਦਾ ਮਤਲਬ ਸਹੀ ਨਹੀਂ ਹੈ। ਕਮਿਊਨੀਕੇਸ਼ਨ ਗੁੱਡ ਨਾ ਹੋਣ ਕਰਕੇ ਮਤਲਬ ਬਹੁਤ ਪ੍ਰੋਬਲਮਸ ਆਉਂਦੀਆਂ ਨੇ। ਇਨਐਡੂਕੇਟ ਪ੍ਰੋਵਾਈਡ ਇਨਫੋਰਮੇਸ਼ਨ ਹੀ ਨਹੀਂ ਸਹੀ ਹੁੰਦੀ, ਮਿਸ ਜੱਜ ਹੋ ਜਾਂਦਾ ਪੇਸ਼ੈਂਟ। ਤੇ ਸਭ ਤੋਂ ਵੱਡੀ ਪ੍ਰੋਬਲਮ ਕਿ ਡਿਫਰੈਂਟ ਲਿੰਗੁਇਸਟਿਕ ਐਂਡ ਕਲਚਰਲ ਪ੍ਰੋਬਲਮ ਵੀ ਆਉਂਦੀ ਹੈਗੀ ਹੈ ਤੇ ਉਹਨਾਂ ਦੀ ਲੈਂਗੁਏਜ ਦੀ ਪ੍ਰੋਬਲਮ ਵੀ, ਜਿੱਥੇ ਹੈਲਥ ਕੇਅਰ ਪ੍ਰੋਫੈਸ਼ਨ ਕਈ ਵਾਰੀ ਸਾਊਥ ਤੋਂ ਆ ਜਾਂ ਕਿੱਦਾਂ ਹੈਗਾ ਉਹਨੂੰ ਉਹ ਨਹੀਂ ਸਮਝ ਸਕਦਾ। ਮਤਲਬ ਕਈ ਗੱਲਾਂ ਉਹ ਜਿਹੜਾ ਆਪਣਾ ਪੰਜਾਬੀ ਲੈਂਗੁਏਜ 'ਚ ਉਹ ਬੋਲ ਰਿਹਾ ਤਾਂ ਉਹਨਾਂ ਨੂੰ ਨਹੀਂ ਪਤਾ ਲੱਗਦਾ ਕਿ ਇਹ ਕਹਿ ਰਹੇ ਨੇ। ਟਾਈਮ ਦੀ ਤਾਂ ਸਭ ਤੋਂ ਜ਼ਿਆਦਾ ਹੀ ਹੈਗੀ ਕਮੀ ਸਾਰੇ ਕਿਤੇ ਹੀ। ਤਾਂ ਇੰਪਰੂਵਿੰਗ ਪੇਸ਼ੈਂਟ, ਅਸੀਂ ਕੀ ਇੰਪਰੂਵਿੰਗ ਕਰ ਸਕਦੇ ਹਾਂ? ਪੇਸ਼ੈਂਟ ਸੈਂਟਰ ਕਮਿਊਨੀਕੇਸ਼ਨ ਐਂਡ ਸ਼ੇਅਰ ਡਿਸੀਜ਼ਨ ਮੇਕਿੰਗ ਇਨ ਕੈਂਸਰ, ਮੇਕਿੰਗ ਮੋਰ ਕੰਪਰੈਂਸਿਵ ਇਨਫੋਰਮੇਸ਼ਨ ਅਵੇਲੇਬਲ। ਬਹੁਤ ਜ਼ਿਆਦਾ ਇਨਫੋਰਮੇਸ਼ਨ ਨੂੰ ਆਪਾਂ ਮਤਲਬ ਕਿ ਕੈਂਸਰ ਦੇ ਪ੍ਰਤੀ ਫੈਲਾ ਕੇ, ਜਿੱਦਾਂ ਕੈਂਸਰ ਦਾ ਪ੍ਰੋਗਨੋਸਿਸ ਕੀ ਹੈ, ਇਹਦੇ ਟ੍ਰੀਟਮੈਂਟ ਕੀ ਹੈ, ਇਹਦੇ ਬੈਨੀਫਿਟ ਕੀ ਹੈ ਨਾ, ਹਾਰਮਸ ਕੀ ਹੈ ਇਹਦੇ। ਤਾਂ ਪੈਲੀਟਿਵ ਕੇਅਰ, ਸਾਈਕੋਲੋਜੀਕਲ ਸਪੋਰਟ ਦੇ ਕੇ ਤੇ ਲਾਈਕਲੀਹੁੱਡ ਆਫ ਟ੍ਰੀਟਮੈਂਟ ਰਿਸਪੌਂਸ, ਇਹ ਸਾਰੀਆਂ ਚੀਜ਼ਾਂ ਨਾਲ ਅਸੀਂ ਜਿਹੜਾ ਹੈਗਾ ਇੰਪਰੂਵ ਕਰ ਸਕਦੇ ਹਾਂ ਇਹਦੀ ਕੇਅਰ। ਦੈਨ ਸ਼ੇਅਰ ਡਿਸੀਜ਼ਨ ਮੇਕਿੰਗ ਯੂਜ਼ਿੰਗ ਡਿਵਾਈਸਿੰਗ ਏਡਸ, ਤਾਂ ਐਕਟਿਵ ਲਿਸਨਰ ਹੋ ਕੇ ਨਾ, ਲਿਸਨਿੰਗ ਐਕਟਿਵਲੀ assess the patient, understanding the treatment of option, validating a patient participate in decision making process। ਜਿਹੜਾ ਉਹਨੇ ਡਿਸੀਜ਼ਨ ਲੈਣਾ ਹੈ ਕਿ ਉਹਨੂੰ ਕਹਿਤਾ ਕਿ ਕਿਸੇ ਨੇ ਕਿ ਤੁਹਾਨੂੰ ਕੀਮੋ ਵੀ ਲੱਗਣੀ ਹੈ, ਤੁਹਾਨੂੰ ਸੇਕੇ ਵੀ ਲੱਗਣੇ ਆ, ਤਾਂ ਇਹਦੇ ਵਿੱਚ ਇਹ ਹੈ ਕਿ ਉਹਨੂੰ ਇੱਕ ਵਾਰੀ ਉਹਦੀ ਮਤਲਬ ਕਿ ਸਰਜਰੀ ਵੀ ਹੋਣੀ ਹੈ, ਤਿੰਨੋਂ ਆਪਸ਼ਨਸ ਉਹਦੇ ਕੋਲੇ। ਤਾਂ ਆਪਾਂ ਉਹਦੀ ਹੈਲਪ ਕਰ ਸਕਦੇ ਹਾਂ ਕਿ ਪਹਿਲਾਂ ਤੁਹਾਨੂੰ ਕੀ ਇਹ ਲੱਗਦਾ ਹੈਗਾ, ਜਾਂ ਉਹਨੂੰ ਹਰ ਗੱਲ ਸਮਝਾ ਸਕਦੇ ਹਾਂ ਕਿ ਤੁਸੀਂ ਫਿਰ ਕਿੱਦਾਂ ਕਰ ਸਕਦੇ ਹੋ ਇਹਨੂੰ ਸਾਰਾ। ਤਾਂ ਪ੍ਰਾਇਓਰਟਾਈਜ਼ ਦੀ ਕਲੀਨਿਕਲ ਟ੍ਰੇਨਿੰਗ ਇਨ ਕਮਿਊਨੀਕੇਸ਼ਨ। Effective communication is associated with patient experience, faster recovery, improving pain control and better psychological functions। ਉਹਦੀ ਪੇਸ਼ੈਂਟ ਦੀ ਐਂਜ਼ਾਈਟੀ ਲੈਵਲ ਘੱਟ ਕਰਕੇ ਉਹਦੇ ਨਾਲ ਕਮਿਊਨੀਕੇਸ਼ਨ ਕਰਕੇ ਹੀ ਹੋਣਾ ਹੈ ਨਾ, ਉਹਨੂੰ ਸੈਟਿਸਫਾਈ ਕਰਕੇ ਉਹਦੀਆਂ ਆਊਟਪੁੱਟ। communicating information and preparing cancer care plans. ਕੈਂਸਰ ਕੇਅਰ ਟੀਮ ਹੈ ਜਿਹੜੀ ਉਹ ਪੂਰੀ ਕੋਲੈਬੋਰੇਟ ਹੋ ਕੇ ਕੰਮ ਕਰੇ। ਉਹਦੇ ਵਿੱਚ ਇਹ ਨਹੀਂ ਹੋਣਾ ਚਾਹੀਦਾ ਕਿ ਕੋਈ ਕਿੱਧਰ ਗੱਲ ਕਹਿ ਰਿਹਾ, ਕੋਈ ਉਹਨੂੰ ਕਹਿ ਰਿਹਾ ਕਿ ਤੂੰ ਇੰਨਾ ਪਾਣੀ ਪੀਣਾ ਤੇ ਦੂਸਰਾ ਆ ਕੇ ਕੁਝ ਹੋਰ ਕਹਿ ਦੇ, ਹਨਾ। ਮਤਲਬ ਕਿ ਇੱਕ ਪੂਰੀ ਕੋਲੈਬੋਰੇਸ਼ਨ ਹੋਣੀ ਚਾਹੀਦੀ ਹੈ ਕਿ ਕੀ ਤੁਹਾਡਾ ਹੁਣ ਹੈਗਾ, ਕਿ ਇਸ ਤੋਂ ਬਾਅਦ ਤੁਹਾਨੂੰ ਕੀ ਪ੍ਰੋਬਲਮਸ ਆ ਸਕਦੀਆਂ। ਪੂਰੀ ਟੀਮ ਦੀ ਇੱਕ ਮਿਲ ਜੁਲ ਕੇ ਕੰਮ ਕਰਨਾ ਚਾਹੀਦਾ ਹੈਗਾ। ਤੇ ਉਹ ਕੰਮ ਤਾਂ ਕਰਨਾ ਚਾਹੀਦਾ ਪੇਸ਼ੈਂਟ ਦੀਆਂ ਨੀਡਸ, ਵੈਲਿਊਜ਼ ਤੇ ਉਹਦੀਆਂ ਚੀਜ਼ਾਂ ਨੂੰ ਧਿਆਨ ਵਿੱਚ ਰੱਖਦੇ ਹੋਏ। ਮਤਲਬ ਕਿ ਤੁਸੀਂ ਪੇਸ਼ੈਂਟ ਤੁਹਾਡੀ ਫਸਟ ਪ੍ਰੈਫਰੈਂਸ ਹੈ ਤਾਂ ਪੇਸ਼ੈਂਟ ਨੂੰ ਮਤਲਬ ਨਾਲ ਪੈਲੇਟਿਵ ਕੇਅਰ, ਨੀਡ, ਉਹਦੀਆਂ ਸਾਈਕੋਲੋਜੀਕਲ ਸਪੋਰਟਸ ਵੀ ਦੇਣੀਆਂ। ਜਿੱਦਾਂ ਕਿ ਤੁਸੀਂ ਕਈ ਵਾਰੀ ਕੈਥ ਲਾਉਣੇ ਹੋ, ਕੈਥ ਲਾਉਂਦੇ ਤੁਸੀਂ ਉਹਦੇ ਨਾਲ ਬਹੁਤ ਗੱਲਾਂ ਕਰ ਸਕਦੇ ਹੋ। ਉਹ ਉੱਥੇ ਹੀ ਸੈਟਿਸਫਾਈ ਹੋ ਜਾਂਦਾ, ਉੱਥੇ ਹੀ ਤੁਹਾਡੇ ਤੇ ਫੇਥ ਕਰਨ ਲੱਗ ਜਾਂਦਾ ਕਿ ਇਹ ਸਿਸਟਮ ਮੇਰੇ ਲਈ ਬੈਟਰ ਹੈ ਜਾਂ ਇਹ ਸਟਾਫ ਮੇਰੇ ਲਈ ਬੈਟਰ ਹੈਗਾ। ਤਾਂ ਇਹ ਤੁਸੀਂ ਕਰਦੇ ਰਹਿਣਾ ਚਾਹੀਦਾ। ਐਡਵਾਂਸਿੰਗ ਨਿਊ ਪੇਮੈਂਟ ਮਾਡਲਸ, ਉਹਨੂੰ ਇਹਨਾਂ ਚੀਜ਼ਾਂ ਬਾਰੇ ਜਾਣਕਾਰੀ ਦੇਣੀ ਚਾਹੀਦੀ ਹੈ ਵੀ ਅੱਜ ਕੱਲ੍ਹ ਬਹੁਤ ਐਡਵਾਂਸ ਪੇਮੈਂਟ ਦੇ ਆ ਚੁੱਕੇ ਆ, ਕਿਉਂਕਿ ਇੰਨੇ ਪੈਸੇ ਕੱਢਣੇ ਹਰ ਬੰਦੇ ਦੇ ਵਾਸਤੇ ਦੀ ਗੱਲ ਨਹੀਂ ਹੁੰਦੀ। ਇੱਕ ਤਾਂ ਡਿਜ਼ੀਜ਼ ਨਾਲ ਉਹ ਸਫਰ ਕਰ ਰਿਹਾ ਹੁੰਦਾ, ਇੱਕ ਉਹਦੇ ਪੇਮੈਂਟ ਦਾ ਉੱਤੇ ਬਹੁਤ ਜ਼ਿਆਦਾ ਲੋਡ ਪੈ ਜਾਂਦਾ। ਤਾਂ ਜਿੱਦਾਂ ਅੱਜ ਕੱਲ੍ਹ ਆਯੁਸ਼ਮਾਨ ਵਾਲਾ ਚੱਲਿਆ ਹੋਇਆ, ਇਹਨਾਂ ਚੀਜ਼ਾਂ ਲਈ ਵੀ ਆਪਾਂ ਉਹਨੂੰ ਗਾਈਡ ਕਰ ਸਕਦੇ ਹੈਗੇ। ਤੇ ਥੈਂਕ ਯੂ ਫॉर ਦਿਸ।
Thank you so much, ma'am, for such a wonderful views and your for sharing your experience.
Now I would like to invite our judges, Mr. Gopal Singh Charan, Associate Professor, College of Nursing, SGRD, and Dr. Amandeep Kaur Bajwa, Professor, College of Nursing, SGRD, for evaluation of poster presentation. So I request to the students who are participated in the poster presentation, please be there for your evaluation. Thank you. Next will be proceeded by Miss Komalpreet Kaur ma'am.
So according to Ms. Pavandeep, all the patients, according to the survey, number or 100% of the patients say that we want कि हमें सुना जाए, and our speakers also want कि हमें सुना जाए. So please, it's a request, maintain silence. So the next speaker for the next session is Ms. Neer Kamal. Currently, ma'am is working at Sri Guru Ramdas College as a nursing supervisor and clinical instructor. So the achievements or the list of achievements is a vast for ma'am. She received Appreciation of Vocational Excellence Award for the treatment, dedicated and exemplary contribution towards service to the community and humanity. She also was honored by the Bhai Ganaiya Mission Society Amritsar. She received vocational awards and attended palliative care courses of the Foundation in Cancer Care. She also attended other various national conferences, courses, and she received the certificate of appreciation for dedicated her services during the COVID-19 pandemic. Ma'am is also a lifetime member of ONAI. So I'm requesting ma'am to please share your views.
ਸਤਿ ਸ਼੍ਰੀ ਅਕਾਲ ਸਾਰਿਆਂ ਨੂੰ। I am truly delighted to be part of this event. Thank you so much. Today my presentation is challenges patients face in cancer care. You all know about very well, there are so many challenges for patients face in cancer patient. Cancer is an illness associated with substantial physically, emotional, social, and financial ramifications for affected individuals and their family. Cancer patients face various challenges. ਤੁਸੀਂ ਸਾਰੇ ਜਾਣਦੇ ਹੋ ਕਿ ਕੈਂਸਰ ਜਿਹੜੀ ਇੱਕ ਬਿਮਾਰੀ ਆ ਇਹਨਾਂ ਇਕੱਲੇ ਪੇਸ਼ੈਂਟ ਹੀ ਨਹੀਂ, ਪੇਸ਼ੈਂਟ ਨੂੰ ਫਿਜ਼ੀਕਲੀ ਵੀ, ਇਮੋਸ਼ਨਲੀ ਵੀ ਤੇ ਸੋਸ਼ਲੀ ਵੀ ਬੜਾ ਕੁਝ ਬਰਦਾਸ਼ਤ ਕਰਨਾ ਪੈਂਦਾ ਹੈ। Cancer is a major cause of suffering and death throughout the world. According to Globocan data 2020, number of new cancer cases are 1.9 in both sexes, and the number of cancer deaths are 9.29 lakhs. In India, estimated number of people with cancer around 2.7 million in the year 2020. Every year, new cancer patient registered are 13.9 million. ਤੁਸੀਂ ਦੇਖੋ ਕਿੰਨਾ ਜ਼ਿਆਦਾ ਕੈਂਸਰ ਡੇ ਬਾਈ ਡੇ ਇਨਕਰੀਜ਼ ਹੋ ਰਹੇ ਕੈਂਸਰ ਪੇਸ਼ੈਂਟਸ। Cancer related deaths are 8.5 lakhs. Challenges faced by cancer patients result in delay in initiation and continuation of cancer treatment. There are so many challenges: lack of economical supports, lack of money for treatment, medicines, transportations, non-affording to transports, accommodations, medicines, foods, and drinks. This leads to delay or missed medical treatment. Financially, ਗਵਰਨਮੈਂਟ ਸਾਡੀ ਪੰਜਾਬ ਗਵਰਨਮੈਂਟ ਵੀ ਕਾਫੀ ਹੈਲਪ ਕਰ ਰਹੀ ਹੈ। ਜਿਸ ਤਰ੍ਹਾਂ ਮੇਰੇ ਕਲੀਗ ਨੇ ਪਹਿਲੇ ਦੱਸਿਆ, ਆਯੁਸ਼ਮਾਨ ਸਕੀਮ ਚੱਲਦੀ ਹੈ ਜਿਹੜੀ ਕਿ 5 ਲੱਖ ਰੁਪਏ ਦਾ ਪੇਸ਼ੈਂਟ ਨੂੰ ਹੈਲਪ ਕਰਦੀ ਹੈ, ਔਰ MMPC ਮੁੱਖ ਮੰਤਰੀ ਰਾਹਤ ਕੋਸ਼ ਫੰਡ ਇਹ ਵੀ 1.5 ਲੱਖ ਦਾ ਪੇਸ਼ੈਂਟ ਨੂੰ ਫਾਈਨੈਂਸ਼ਲੀ ਸਪੋਰਟ ਕਰਦੇ ਨੇ, ਐਂਡ ਪ੍ਰਾਈਮ ਮਿਨਿਸਟਰ ਹੈਲਪ ਫੰਡ ਵੀ ਦੇ ਰਹੇ ਆ, ਉਹ ਵੀ ਪੇਸ਼ੈਂਟ ਨੂੰ ਕਾਫੀ ਜ਼ਿਆਦਾ ਫਾਈਨੈਂਸ਼ਲੀ ਹੈਲਪ ਸਪੋਰਟ ਹੋ ਜਾਂਦੀ ਆ। Next, lack of social supports. Patients lack of supports, family and friends supports. Cancer is a non-communicable disease. Still, cancer patients has been kept away from families and societies. This behavior adds to mental trauma along with the disease burden. Social trauma patient ਨੂੰ ਕਾਫੀ ਫੇਸ ਕਰਨਾ ਪੈਂਦਾ ਕਿਉਂਕਿ ਕੈਂਸਰ ਨੂੰ ਅਜੇ ਵੀ ਇੰਨੀ ਅਵੇਅਰਨੈਸ ਹੋਣ ਦੇ ਬਾਵਜੂਦ ਵੀ ਕੈਂਸਰ ਨੂੰ ਛੂਤ ਦੀ ਬਿਮਾਰੀ ਸਮਝਿਆ ਜਾਂਦਾ ਹੈ। ਇੱਥੋਂ ਤੱਕ ਸਾਨੂੰ ਪੇਸ਼ੈਂਟ ਆ ਕੇ ਦੱਸਦੇ ਆ ਕਿ ਸਾਡੇ ਯੂਟੈਂਸਿਲ ਤੱਕ, ਬੈੱਡ ਤੱਕ ਸਾਡਾ ਸੈਪਰੇਟ ਕਰ ਦਿੱਤਾ ਜਾਂਦਾ ਕਿ ਇਹ ਛੂਤ ਦੀ ਬਿਮਾਰੀ ਆ, ਤੁਸੀਂ ਬੱਚਿਆਂ ਨੂੰ ਹੱਥ ਨਹੀਂ ਲਾਉਣਾ। ਪਰ ਇੱਥੇ ਮੈਂ ਕਹਿਣਾ ਚਾਹੁੰਦੀ ਹਾਂ ਕਿ ਆਪਾਂ ਨੂੰ ਜਿੱਦਾਂ ਰੂਰਲ ਏਰੀਆ 'ਚ ਖਾਸ ਕਰਕੇ ਅਵੇਅਰਨੈਸ ਕੈਂਪ ਲਾਉਣੇ ਚਾਹੀਦੇ ਆ ਤਾਂ ਕਿ ਲੋਕਾਂ ਨੂੰ ਹੋਰ ਵੀ ਜਾਗਰੂਕਤਾ ਮਿਲੇ ਕਿ ਇਹ ਜਿਹੜੀ ਕੈਂਸਰ ਦੀ ਬਿਮਾਰੀ ਆ ਇਹ ਛੂਤ ਦੀ ਬਿਮਾਰੀ ਨਹੀਂ ਆ। ਪੇਸ਼ੈਂਟ ਦੇ ਅਟੈਂਡੈਂਟ ਰਿਲੇਟਿਵ ਸਾਰੇ ਉਹਦੇ ਨਾਲ ਰਹਿ ਸਕਦੇ ਨੇ। Side effect of cancer treatment. Patient experiencing many treatment related side effects including chemotherapy side effect. As you know very well, there are so many side effects for chemotherapies. General weakness, loss of appetite, loss of hair, nausea, vomiting, constipation, diarrhea, neuropathy, cardiac problems, reduced lung capacity, bone and joint problems, muscle weakness, secondary cancers, and changes in memory of concentrations. Radiotherapy side effects: oral mucositis, urostomia, dental changes like dental caries, difficulty in swallowing, skin reactions, lymphedema, permanent hair loss, and infertility, slowed or halted bone growth in children. As you know, so to image this hair loss after treatment of chemotherapy and radiotherapy. Left upper limb lymphedema. After mastectomy, the lymphedema occurs. Pain after the treatment mainly due to painful scars due to surgery, pain in missing limb or breast phantom pain, pain in hand or feet due to injured nerves, emotional pain. ਪੇਨ ਕੈਂਸਰ ਦੇ ਪੇਸ਼ੈਂਟ ਨੂੰ ਬਹੁਤ ਜ਼ਿਆਦਾ, ਕਿਉਂਕਿ ਅਸੀਂ ਖੁਦ ਦੇਖਦੇ ਵਾਰਡ ਦੇ ਵਿੱਚ ਪੇਸ਼ੈਂਟ ਨੂੰ ਇੰਨੀ ਪੇਨ ਹੁੰਦੀ ਹੈ ਕਿ ਕਈ ਵਾਰੀ ਸਾਡੇ ਪੇਨ ਕਿਲਰ ਮੈਡੀਸਨਸ ਵੀ ਇਫੈਕਟ ਨਹੀਂ ਕਰਦੀਆਂ। ਬਾਰ-ਬਾਰ ਟਰਾਮਾਡੋਲ ਲਗਾਓ, ਉਹਦੇ ਬਾਵਜੂਦ ਪੇਸ਼ੈਂਟ 1-2 ਘੰਟਾ ਕਹੇਗਾ ਕਿ ਥੋੜਾ ਫਰਕ ਹੈ, ਪਰ ਬਾਅਦ 'ਚ ਫਿਰ ਸੇਮ ਪ੍ਰੋਬਲਮਸ ਰਹਿੰਦੀਆਂ ਵਾ ਕਿਉਂਕਿ ਇੱਥੇ ਸਾਡੇ ਅਜੇ ਤੱਕ ਮੋਰਫਿਨ ਅਵੇਲੇਬਲ ਨਹੀਂ ਆ। ਇਸ ਕਰਕੇ ਸਾਨੂੰ ਇਹ ਵੀ ਚੀਜ਼ਾਂ ਫੇਸ ਕਰਨੀਆਂ ਪੈਂਦੀਆਂ ਕਿ ਪੇਸ਼ੈਂਟ ਕਈ ਵਾਰੀ ਅਸੀਂ ਵੀ ਹੈਲਪਲੈਸ ਹੋ ਜਾਂਦੇ ਹਾਂ ਕਿ ਉਹਨਾਂ ਨੂੰ ਦਰਦ ਦੇ ਵਾਸਤੇ ਕੀ ਲਗਾਈਏ। Menopausal symptoms. Post chemotherapy women stop getting their period every month or stop getting them altogether. This leads to menopausal symptoms in young females, for example, hot flushes, fatigue, sleep problems, mood swings, body changes in sex life. Post-surgery challenges, feeling of shame, especially in patients of breast cancer and or patient with colostomy bag in situ. It deals with infertility in gynecological cancers, use of prosthesis in limb amputation surgery. ਜਿਸ ਤਰ੍ਹਾਂ ਕਿ ਹੁਣ ਬ੍ਰੈਸਟ ਕੈਂਸਰ ਜਦੋਂ ਬ੍ਰੈਸਟ ਰਿਮੂਵ ਹੋ ਜਾਂਦੀ ਆ ਤਾਂ ਕਈ ਜਿਸ ਤਰ੍ਹਾਂ ਬੰਦੇ ਜੌਬ ਕਰਦੇ ਜਾਂ ਥੋੜਾ ਸ਼ੇਮ ਫੀਲ ਕਰਦੇ ਆ ਨਾ, ਬ੍ਰੈਸਟ ਜਦੋਂ ਮਸਟੈਕਟਮੀ ਹੋ ਜਾਂਦੀ ਆ ਤਾਂ ਉਹਦੇ ਲਈ ਉਹ ਪ੍ਰੋਸੈਸਿਸ ਯੂਜ਼ ਕਰ ਸਕਦੇ ਆ। As you saw, image shows a colostomy bag in situ. Fear of recurrence, ਜਿਹੜਾ ਕਿ ਪੇਸ਼ੈਂਟ ਦੇ ਵਿੱਚ ਬਹੁਤ ਜ਼ਿਆਦਾ ਹੈ। ਇੱਕ ਸਾਡਾ ਮੀਡੀਆ ਕੁਛ ਇਸ ਤਰ੍ਹਾਂ ਪ੍ਰੋਜੈਕਟ ਕਰਦਾ ਵਾ ਕੈਂਸਰ ਨੂੰ ਕਿ ਜਿਵੇਂ ਨਾ ਹਵਾ ਹੀ ਹੁੰਦੀ ਆ। ਚਲੋ ਹੈ ਤਾਂ ਥੋੜਾ ਡਰ ਤਾਂ ਲੱਗਦਾ ਹੀ ਹਰ ਇੱਕ ਨੂੰ, ਅਸੀਂ ਵੀ ਇਨਸਾਨ ਆ, ਪਰ ਇਹ ਆ ਕਿ ਸਾਡਾ ਜਿੱਦਾਂ ਫਿਲਮਾਂ 'ਚ ਦਿਖਾਉਂਦੇ ਕੈਂਸਰ ਹੋ ਗਈ ਆ ਤਾਂ ਉਹ ਮਤਲਬ ਕਿਤੇ ਫੀਅਰ ਹੈਗਾ। ਰੀਕਰੈਂਸ ਦਾ ਵੀ ਫੀਅਰ ਹੁੰਦਾ ਵਾ। ਜੇ ਪੇਸ਼ੈਂਟ ਇਲਾਜ ਵੀ ਕਰਾ ਲੈਂਦਾ ਤਾਂ ਵੀ ਇਹੀ ਹੁੰਦਾ ਕਿ ਪਤਾ ਨਹੀਂ ਦੁਬਾਰਾ ਨਾ ਹੋ ਜੇ। ਪੇਸ਼ੈਂਟ ਦਾ ਕੁਐਸਚਨ ਇਹੀ ਹੁੰਦਾ ਸਾਨੂੰ ਕਿ ਦੁਬਾਰਾ ਤਾਂ ਨਹੀਂ ਹੋਏਗੀ, ਇਲਾਜ ਕਰਾਉਣ ਤੋਂ ਬਾਅਦ ਮੈਂ ਠੀਕ ਰਵਾਂਗੀ। Fear of recurrence, 70% of post-treatment cancer survivor reports high level of fear of cancer recurrence, which cause significant and enduring distress. This leads to depression, anxiety, and hence have a lower quality of life. ਜਿਸ ਤਰ੍ਹਾਂ ਮੇਰੇ ਕੋਲੀਗ ਨੇ ਪਹਿਲੇ ਹੀ ਪਵਨਦੀਪ ਜੀ ਨੇ ਕਿਹਾ ਹੈ ਕਿ ਪੇਸ਼ੈਂਟ ਦੇ ਨਾਲ ਕਮਿਊਨੀਕੇਸ਼ਨ ਇੰਨਾ ਵਧੀਆ ਤੁਹਾਡਾ ਹੋਵੇ ਕਿ ਪੇਸ਼ੈਂਟ ਨੂੰ ਮਤਲਬ ਘਰ ਵਰਗਾ ਮਾਹੌਲ ਹੋਣਾ ਚਾਹੀਦਾ। ਜਿਸ ਤਰ੍ਹਾਂ ਮੈਂ ਕਿਹਾ ਕਿ ਆਪਾਂ ਜਦੋਂ ਐਨਜੀਓ ਕੈਥ ਲਗਾਉਂਦੇ ਆ ਤੇ ਪੇਸ਼ੈਂਟ ਦਾ ਮਾਈਂਡ, ਕਿਉਂਕਿ ਜਦੋਂ ਪੇਸ਼ੈਂਟ ਸਾਡੇ ਕੋਲ ਫਸਟ ਟਾਈਮ ਆਉਂਦਾ ਹਸਪੀਟਲ 'ਚ ਤੇ ਨਾ ਪੜ੍ਹ ਕੇ ਹੀ ਕੈਂਸਰ, ਕਈ ਪੇਸ਼ੈਂਟ ਨੂੰ ਨਹੀਂ ਦੱਸਿਆ ਜਾਂਦਾ ਕਿ ਸਾਨੂੰ ਕੈਂਸਰ ਆ। ਈਵਨ ਕਿ ਸਾਨੂੰ ਕਈ ਅਟੈਂਡੈਂਟ ਵੀ ਕਹਿੰਦੇ ਆ ਕਿ ਕੌਨਫੀਡੈਂਸ਼ੀਅਲ ਰੱਖਿਓ, ਪਰ ਉਹ ਨਾਲ ਦੇ ਕਲੀਗਸ ਵਾਲੇ ਪੇਸ਼ੈਂਟ ਪੁੱਛ ਲੈਂਦੇ ਆ ਕਿ ਮੈਨੂੰ ਕੈਂਸਰ ਆ, ਤਾਂ ਕਾਫੀ ਜ਼ਿਆਦਾ ਸਾਈਕੋਲੋਜੀਕਲ ਪੇਸ਼ੈਂਟ ਡਿਸਟਰਬ ਹੋ ਜਾਂਦਾ। ਤਾਂ ਸਾਡੇ ਸਾਰੇ ਸਟਾਫ ਦੀ ਸਾਰੀ ਟੀਮ ਦੀ ਜ਼ਿੰਮੇਵਾਰੀ ਬਣਦੀ ਆ ਕਿ ਅਸੀਂ ਪੇਸ਼ੈਂਟ ਨੂੰ ਪੋਲਾਈਟਲੀ ਉਹਨੂੰ ਕਮਿਊਨੀਕੇਸ਼ਨ ਵਧੀਆ ਕਰਕੇ ਉਹਨੂੰ ਦੱਸੀਏ। ਮੰਨ ਲਓ ਜਦੋਂ ਆਪਾਂ ਸਾਰੇ ਮੇਰੇ ਬੱਚੇ ਬੈਠੇ ਆ ਤੇ ਜਦੋਂ ਵੀ ਆਪਾਂ ਪੇਸ਼ੈਂਟ ਨੂੰ ਐਨਜੀਓ ਲਾਉਂਦੇ ਆ ਤੇ ਉਹਨਾਂ ਨੂੰ ਉਹਦਾ ਮਾਈਂਡ ਡਿਵਰਟ ਕਰਨ ਵਾਸਤੇ ਉਹਨਾਂ ਨੂੰ ਗੱਲਾਂ ਕਰੋ, ਗੱਲ ਦੇ ਨਾਲ ਗੱਲਾਂ ਕਰੋ ਨਾ, ਕੋਈ ਗੱਲ ਪੁੱਛ ਲਓ ਉਹਨੂੰ, ਗੱਲਾਂ 'ਚ ਲਗਾ ਲੋਗੇ ਉਹਦਾ ਮਾਈਂਡ ਡਿਵਰਟ ਹੋ ਜਾਏਗਾ। ਤੁਸੀਂ ਐਨਜੀਓ ਲਗਾ ਕੇ ਪੇਸ਼ੈਂਟ ਨੂੰ ਪਤਾ ਨਹੀਂ ਲੱਗੇਗਾ। ਇਹ ਮੇਰਾ ਖੁਦ ਦਾ ਐਕਸਪੀਰੀਅੰਸ ਆ। ਤਾਂ ਉਹਨਾਂ ਨੂੰ ਪੇਸ਼ੈਂਟ ਨੂੰ ਪਤਾ ਨਹੀਂ ਲੱਗੇਗਾ ਪੇਸ਼ੈਂਟ ਨੂੰ ਐਨਜੀਓ ਲੱਗ ਰਿਹਾ ਵਾ। ਸੋ ਪੇਸ਼ੈਂਟ ਦੇ ਨਾਲ ਕੈਂਸਰ ਪੇਸ਼ੈਂਟ ਨੂੰ ਲੋੜ ਹੁੰਦੀ ਸਾਈਕੋਥੈਰੇਪੀ ਦੀ, ਮੋਸਟ ਜ਼ਿਆਦਾ ਲੋੜ ਹੁੰਦੀ ਆ, ਤੇ ਪੇਸ਼ੈਂਟ ਦੇ ਨਾਲ ਪਲੀਟ ਪੋਲਾਈਟਲੀ, ਠੀਕ ਹੈ ਨਾ। Employment issues. Cancer and its treatment leads to adverse effect on work status, performance and job satisfactions. Some may left with disability, unemployment, delay in return to work. Cancer-related fatigue. Cancer-related fatigue is a distressing, persisting subjective sense of physical, emotional, and or cognitive tiredness and exhaustion related to cancer treatment that is not proportional to recent activity and interference with usual functions. ਕੋਈ ਮਤਲਬ ਕੈਂਸਰ ਪੇਸ਼ੈਂਟ ਵੇਖੋ ਵੈਸੇ ਸਾਈਕੋਲੋਜੀਕਲ ਤੇ ਡਿਸਟਰਬ ਹੁੰਦਾ ਹੀ ਆ। ਜਦੋਂ ਸਾਈਕੋਲੋਜੀਕਲ ਡਿਸਟਰਬ ਨੈਚੁਰਲੀ ਫਟੀਗ ਵੀ ਪੇਸ਼ੈਂਟ ਨੂੰ ਹੋਏਗੀ। ਤੇ ਇਹ ਸਾਰੀਆਂ ਚੀਜ਼ਾਂ ਆਪਾਂ ਉਹਨਾਂ ਨੂੰ ਸਾਈਕੋਥੈਰੇਪੀ ਦੇ ਕੇ, ਮੇਰੇ ਖਿਆਲ ਨਾਲ ਕੈਂਸਰ ਦੇ ਵਿੱਚ ਸਭ ਤੋਂ ਜ਼ਿਆਦਾ ਬੈਸਟ ਜਿਹੜਾ ਹੈਗਾ ਉਸ ਪੇਸ਼ੈਂਟ ਨੂੰ ਸਾਈਕੋਥੈਰੇਪੀ ਦੇਣਾ ਹੈ। ਟ੍ਰੀਟਮੈਂਟ ਚਲੋ ਚੱਲਣਾ ਹੀ ਚੱਲਣਾ, ਪਰ ਨਾਲ ਸਾਈਕੋਥੈਰੇਪੀ ਸਾਡਾ ਬਹੁਤ ਵਧੀਆ ਰੋਲ ਅਦਾ ਕਰ ਸਕਦੇ ਆਪਾਂ। ਇਹ ਡੇ ਟੂ ਡੇ ਚੈਲੰਜਸ, ਟ੍ਰੀਟਮੈਂਟ ਫॉर ਮੈਨੀ ਟਾਈਪਸ ਆਫ ਕੈਂਸਰ ਵਰ ਮੋਰ ਸੀਵੀਅਰ ਦੈਨ ਟੂਡੇ। ਲੇਟ ਇਫੈਕਟਸ ਆਫ ਟ੍ਰੀਟਮੈਂਟਸ ਕੈਨ ਇਫੈਕਟ ਡੇ ਟੂ ਡੇ ਲਾਈਫ ਐਕਟੀਵਿਟੀਜ਼, ਚੇਂਜਿਸ ਇਨ ਦ ਰਿਲੇਸ਼ਨਸ਼ਿਪ ਵਿਦ ਲਵਡ ਵਨ, ਫਰੈਂਡਸ ਔਰ ਕੋ-ਵਰਕਰ, low self-esteem, difficulty communication concern to other, financial stress. ਇਹ ਵੀ ਇੱਕ ਬਹੁਤ ਵੱਡੇ ਚੈਲੰਜ ਹੈ ਕਿ ਕਈ ਪੇਸ਼ੈਂਟ ਵਿਚਾਰੇ ਸ਼ਰਮ ਦੇ ਮਾਰੇ ਦੱਸਦੇ ਹੀ ਨਹੀਂ ਆ ਕਿ ਸਾਨੂੰ ਕੈਂਸਰ ਆ। ਜੇ ਮੈਂ ਦੱਸਤਾ ਤਾਂ ਪਤਾ ਨਹੀਂ ਮੈਨੂੰ ਆਈਸੋਲੇਟ ਨਾ ਕਰ ਦੇਣ, ਮੇਰੇ ਨਾਲ ਬੋਲਣ ਨਾ, ਮਤਲਬ ਕਾਫੀ ਜ਼ਿਆਦਾ ਚੈਲੰਜਸ ਹੁੰਦੀਆਂ ਨੇ ਜਦੋਂ ਪੇਸ਼ੈਂਟ ਨੂੰ ਡਾਇਗਨੋਜ਼ ਹੁੰਦਾ ਕੈਂਸਰ ਦਾ। ਹਾਊ ਟੂ ਮੈਨੇਜ ਟ੍ਰੀਟਮੈਂਟ ਸਾਈਡ ਇਫੈਕਟ ਨੂੰ ਆਪਾਂ ਕਿਵੇਂ ਮੈਨੇਜ ਕਰ ਸਕਦੇ ਹਾਂ। ਹੈਲਦੀ ਲਾਈਫ ਸਟਾਈਲ, ਥੋੜੀ ਜਿਹੀ ਹਲਕੀਆਂ ਜਿਹੀ ਐਕਸਰਸਾਈਜ਼ ਬਾਰੇ ਐਡਵਾਈਜ਼ ਕਰੋ ਪੇਸ਼ੈਂਟਸ ਨੂੰ। ਅਚੀਵ ਐ ਮੇਨਟੇਨ ਗੁੱਡ ਹੈਲਥੀ ਬੋਡੀ ਵੇਟ, ਡੇਲੀ ਫਿਜ਼ੀਕਲ ਐਕਟੀਵਿਟੀ ਕਰੇ, ਜਿਸ ਤਰ੍ਹਾਂ ਥੋੜਾ ਜਿਹਾ ਸੈਰ ਵਗੈਰਾ, ਮਾਰਨਿੰਗ ਵਾਕ ਕਰ ਲੈਣ, ਥੋੜਾ ਤੁਰ ਫਿਰ ਲੈਣ। ਅਵੋਇਡ ਅਲਕੋਹਲ ਐਂਡ ਤੰਬਾਕੂ ਪ੍ਰੋਡਕਟਸ, ਮੇਨਟੇਨ ਏ ਹੈਲਦੀ ਡਾਈਟ ਇਨ ਵੈਜੀਟੇਬਲ, ਫਰੂਟਸ ਐਂਡ ਪਲੈਂਟੀ ਆਫ ਫਲੂਇਡਸ। Nutrition principles, daily intake of fruits, vegetables, unrefined grains. Limit red meat intake to 18 ounces, below of 500 grams per week, and avoid processed meat. Eat at least 50% plant seeds based. Avoid alcohol intake, monitor weight weekly. ਤੁਹਾਨੂੰ ਵੀ ਪਤਾ ਕਿ ਆਪਾਂ ਪੇਸ਼ੈਂਟ ਜਦੋਂ ਵੀ ਸਾਡੇ ਕੋਲ ਆਉਂਦੇ ਆ ਉਹਦਾ ਜਿਹੜਾ weight ਹੈ ਉਹ ਮੋਨੀਟਰ ਕਰਕੇ ਹੀ ਸਾਰੀ ਜੋ ਵੀ ਕੀਮੋਥੈਰੇਪੀ ਪਲਾਨਿੰਗ ਹੈ ਰੇਡੀਓਥੈਰੇਪੀ ਹੈ ਸਾਰਾ ਜੋ ਵੀ ਟ੍ਰੀਟਮੈਂਟ ਉਹਦਾ weight ਦੇ ਕਰਕੇ ਹੀ weight ਹਾਈਟ ਕਰਕੇ ਹੀ ਆਪਾਂ ਸਾਰਾ ਟ੍ਰੀਟ ਕਰਦੇ ਆ monitor weight weekly in taking vitamin supplements. Intervention related to fatigue, adequate level of physical activity, behavioral therapy, physical therapist consultations. Treatment of menopausal symptoms, hormonal therapy, estrogen and progesterones, non-hormonal therapies, antidepressant drugs, gynecomastia treatment of in males, prophylactic radiations, tamoxifen and reduction mammoplasty. Pain management, analgesic ਦੇ ਸਕਦੇ ਆਪਾਂ antidepressant medicine ਦੇ ਸਕਦੇ ਆ anticonvulsant ਦੇ ਸਕਦੇ opioid ਸਾਈਕੋਲੋਜੀਕਲ ਸਪੋਰਟਸ ਬਾਰ ਮੇਰੇ ਕਲੀਗਸ ਨੇ ਪਹਿਲੇ ਹੀ ਕਿਹਾ ਕਿ ਮੇਨ ਕੰਮ ਜਿਹੜਾ ਵਾ ਸਾਈਕੋਲੋਜੀਕਲ ਸਪੋਰਟ ਹੀ ਆ ਪੇਸ਼ੈਂਟ ਨੂੰ ਜਿਹੜੀ ਆਪਾਂ ਜੇ ਇਹਨਾਂ ਨਾਲ ਜਿੱਦਾਂ ਕੱਲ ਡਾਕਟਰ ਡੈਂਟਲ ਦੇ ਸਰਜਨ ਜੀ ਨੇ ਕਿਹਾ ਸੀ ਕਿ ਪੇਸ਼ੈਂਟ ਨੂੰ ਇੱਕ ਹੀਲਿੰਗ ਟੱਚ ਦੇ ਨਾਲ ਹੀ ਪੇਸ਼ੈਂਟ ਨੂੰ ਪਤਾ ਲੱਗ ਜਾਂਦਾ ਕਿ ਮਤਲਬ ਕਿ ਮੈਨੂੰ ਮੈਂ ਸਹੀ ਜਗ੍ਹਾ ਤੇ ਆ ਗਿਆ ਵੀ ਇੱਥੇ ਸਾਰੇ ਜਾਣੇ ਵਧੀਆ ਸਟਾਫ ਹੈ ਸਾਰਾ ਮਤਲਬ ਫੈਮਿਲੀਅਰ ਮਾਹੌਲ ਪੇਸ਼ੈਂਟ ਨੂੰ ਦੇਣਾ ਆਪਾਂ ਸਾਰਿਆਂ ਨੇ pain palliative care in refractory pain. Thank you so much.
Thank you so much, ma'am, for sharing such a wonderful views of yours. And yes, it's very true that कि पेशेंट बहुत ज़्यादा डरते हैं. इवन अगर पेशेंट नहीं भी है ना, कोई पूछ रहा है घर में या फिर विलेजेस में, तो वो नेम भी नहीं लेते, इतना डरते हैं. Yes, it's a cancer. No, they said कि उसको तो दूसरा हो गया था. To use that names. So this is very important to give the psychological support and to use the media for the for awareing the patients and awareing the whole peoples. So the next candidate of our is Mrs. Ramandeep Kaur, staff nurse at Advanced Care Institute at Bathinda. So ma'am has experience at the present Advanced Care Institute as in the various fields like radiotherapy, OPD, operation theatre, OPD for the breast cancer patients. She attended so many workshops come CEE at various institutes. She conducted lectures on genetic counseling. She has given the lectures to the community health officers and also to the cancer patients on the World Cancer Day. Ma'am is involved in the organization various events such as Breast Cancer Awareness Months, and she was also appreciated as the best nursing staff on Nursing Day this year. Ma'am is a member of Cancer Nivaran Society as a treasurer and lifetime member of the ONI, as well as she is the Patient Welfare Committee member in ONI Punjab. So please welcome ma'am.
So good evening, everyone. My today's topic is understanding cancer as a caregiver. So I will just discuss with you just practical things with you people, because you are probably all students of SGRD or some other nursing colleges, है ना? तो practical जो हमारा experience है वो आपके लिए ज़्यादा beneficial होगा instead of talking about just knowledge or book written material. So understand, cancer caregiver can be a professional as well as the family member. So we will discuss both sides, family member as well as professional caregiver, but we'll discuss both simultaneously on a single slide. So these are the few questions that arise in the mind of cancer patient and their family members when they, बेटा please बात मत करना, ठीक है? करनी है तो बाहर चले जाओ, कोई बात नहीं, कोई इशू नहीं, चाहे खाली हम बोल देंगे, पर अच्छा नहीं लगता जब आगे सामने सारे बात कर रहे होते हैं. तो क्या है कि कौन कौन सी क्वेश्चंस हैं जो उनके माइंड में आज सेटअप होता है, ठीक है, जब फर्स्ट टाइम वो विजिट करते हैं, इधर विद द रेडियोलॉजिकल इन्वेस्टिगेशंस और विद द एफएनएसी और बायोप्सीज. So why it happens to their loved one only? They never did any bad thing in their life. They are very spiritual. So how cancer can come in their life? What type of cancer it is, and how to disclose the diagnosis with the patient. Most of the patient's attendant don't want to disclose the diagnosis with their patient. They always said, please keep it confidentially. We will later on discuss with the patient. But I think being professional worker, it's our responsibility to disclose the news, because we can disclose the news in a very professional manner. We can counsel the patient very effectively rather than their own family member. Although they will know that they are having cancer as well, when we will start chemotherapy, they will meet the patients having hair fall. They will meet other patients who are having radiotherapy. They will ultimately came to know that they are also the cancer patient like other people. Now, next thing is they will ask you about staging and what are the treatment options for them, how much money or expenditure it will take. Nowadays, as ma'am told you, that CMRF and Ayushman schemes are there, so most of the patients get benefit from that schemes, and I think it's almost free of cost for those patients. And what is the duration of treatment? Duration of treatment cannot be told by anyone. It all depends upon individual to individual. So how effective the treatment will be, and what kind of lifestyle do the patients need. So after having cancer-like disease, they need to change their lifestyle totally, from diet, and they have to be active even during chemotherapy, during radiotherapy, even post-surgical also. As much as they are active in their lifestyle and taking good diet, they will do better than other patients who are on sedentary lifestyle. The next thing is the first phase that they came to face is denial versus acceptance. Denial either while accepting the diagnosis, either they denial for undergoing any procedure like biopsies, FNAC. They don't want to go through these procedures that are painful. Next thing is, few of the patients don't want to take treatment because cancer treatment is not like other hypertension and diabetes. It is having their own advantages as well as side effects are also there along with the advantages. So they need to accept those side effects. But they are all almost temporary. Very few side effects are there that remain permanent in their life. So although no cancer care team can predict the outcome, it can, that means any for third stage, if the patient came on the third stage, it can move to the fourth stage even very early within 6 months, or it can take 4-5 years also. So it all depends upon the individual, how they how their body responds to the treatment, as well as how the disease progress after the treatment also. So it's all their right either to accept the treatment or to neglect the treatment. We must appreciate the patient, what they ever decide. First thing is to counsel them for the treatment, but if still they don't want to continue treatment, you must let them come for the palliative management at least. So these are the certain misconceptions to refuse the treatment. So number one is cancer itself is a death sentence. Why to choose the prolonged treatment? As Dr. Maheshwari said, that cancer itself is a death sentence, so it's better to choose the suicide than for the treatment itself. My lump or sore is not painful at all. So you can see the pic of the patient having CA lip. So probably he was having a sore or in his lips or oral cavity that was progressed to this much extent. He never disclosed it with any of the healthcare team member. He took medication, but that was a desi medication. That was all herbal products that he consumed. So as per him, he was correct. He was taking treatment, but he was in wrong hands. He was in wrong hands. Whether patient took any cancer treatment is, he can take treatment from private institutes, whether he is taking from any government institute, but worldwide treatment is same. The thing is whether he go to safe hands or the wrong hands. This is the main thing. So even he never came back to our hospital again. ठीक है, तो ये सिर्फ मैगेट्स उसके लिए आता था. मैगेट्स जब हो गए, सब ठीक हो गया, तो पेशेंट को लगा कि नहीं देसी मेडिकेशन बेटर है, क्योंकि इस स्टेज में जब पेशेंट 3rd और 4th स्टेज में आएगा ना बच्चा, तो उसका क्या होगा, ट्रीटमेंट क्या है, ज़्यादा लंबा चलेगा, लेकिन लाइफ क्या है, छोटी मिलेगी, कम मिलेगी। और जो पेशेंट्स हैं अर्ली स्टेज में आएंगे, 1 और 2 में आएंगे, उनका ट्रीटमेंट क्या है, ईजी होगा, लेसर कीमोथेरेपीज होंगी, सर्जरी जो है ज़्यादा रेडिकल नहीं करनी पड़ेगी, उसमें हो सकते हैं रेडियोथेरेपी देनी पड़े एडजुवेंट, और हो सकता है ना देनी पड़े, या फिर सिंपल एक डायरेक्टली कीमोथेरेपी या एक रेडियोथेरेपी सेशन से ही पेशेंट का डिसीज़ जो है ख़त्म हो सकता है। लेकिन जितना लेट पेशेंट आएगा, पेशेंट को एडवाइस करना चाहिए उतना ही आपका जो है जो कांटेक्ट है हॉस्पिटल के साथ, जो आपका स्टेजिंग है 3rd to 4th होने के चांसेस उतने ही ज़्यादा बढ़ जाते हैं। नेक्स्ट थिंग इज इन्वेजिव प्रोसीजर्स लाइक बायोप्सी और सर्जरी कैन स्प्रेड माई डिसीज टू अदर ऑर्गन्स। तो पेशेंट को हमेशा ये होता है, देखना कभी भी आप ओपीडी में देखना, बायोप्सी करवाई, सुई लगाती, तो मतलब कि मेरी डिसीज स्प्रेड हो गई, ठीक है, मैंने बायोप्सी नहीं करवानी, हमने ट्रीटमेंट इसलिए नहीं बताया क्योंकि हमारी सर्जरी कर देंगे तो वो हमारे ब्लड में स्प्रेड हो जाएगा, ठीक है। सो ये मेन रीज़न है जिसकी वजह से पेशेंट ट्रीटमेंट नहीं करवाने आते। हाउ माई पेशेंट कैन टॉलरेट द कीमोथेरेपी, ऑल देयर आर वेरी फ्यू पेशेंट्स who are admitted with the chemotoxicity. Almost all of the patients can tolerate the chemotherapy very well, or very few side effects can be seen in the patient, and that can be managed on OPD basis itself. Next thing is, like other communicable diseases, it can be transmitted to my other family members. तो ये जो डर है ना, स्पेशली जो ग्रैंड मदर्स होती हैं, ग्रैंड फादर्स होती हैं, उनके साथ ये बिहेवियर ज़्यादा किया जाता है कि उनको लगता है कि मैंने ग्रैंड चिल्ड्रंस को उठा लिया तो ये स्प्रेड हो जाएगा, या जो कीमोथेरेपी मुझे दी गई है वो कीमोथेरेपी शायद बच्चे अगर मेरे पास बैठेंगे तो उनको भी मिल रही है, मिशन हो रही होगी कोई रेडियोथेरेपी की मेरे में से, या रेडियोथेरेपी की जिसकी वजह से उनको भी हो सकता है। नेक्स्ट इज बीइंग इनएक्टिव एंड गुड डाइट कैन कंट्रोल माई डिसीज। सो दे बिलीव कि हम जितना बेड रेस्ट करते रहेंगे उतना हमारा अच्छा है। मोस्टली सब पेशेंट्स की एक ही वरी होती है, मैम इससे हम काम ही नहीं करवाएंगे, आप बताओ सही 2 साल नहीं ये काम करेगी, ये बेड पर ही रहेगी, बट अल्टीमेटली इट कैन लीड टू एड ऑन सम कोमॉर्बिडिटीज़, ओबेसिटी हो सकती है, हाइपरटेंशन हो सकता है, डायबिटीज़ मेलाइटिस हो सकता है। तो ये जो है आपको काउंसल करना पड़ेगा कि नहीं, वो उसको काम करने दो, वो जितना एक्टिवली काम करेगी, जितना उसको रेस्ट चाहिए, रेस्ट एंड काम सब अल्टरनेटिवली चलने दो, डाइट तभी अच्छी उसको लगेगी। नेक्स्ट थिंग इज जस्ट फॉर डायग्नोजिंग एंड ट्रीटमेंट प्लानिंग इज वेस्टेज ऑफ टाइम। तो उनको लगता है कुछ जो आप अभी नहीं देखा होगा ओपीडी में, तो बायोप्सिस के बाद भी हमें कुछ टाइम लगता है IHC कंडक्ट करने में, या पेट स्कैन, जैसे कि यहाँ पर बोला, यहाँ पर भी नहीं है, हमारे पास भी नहीं है पेट स्कैन की फैसिलिटी। तो पेट स्कैन में क्या है कि लंबा टाइम लग जाता है पेशेंट को, तो 15 एंड इवन 1 मंथ, तब जब पेशेंट को पता लग जाता है ना कि मेरे को कैंसर का डायग्नोसिस, दे कांट वेट फॉर अ सिंगल डे, they need treatment on the same day, they want to start the treatment on the same day, but that is not possible at all. Without knowing their exact staging, without knowing their exact variety, you can't start the treatment. So meanwhile they try to share the things with the untrained persons like babas, मैक्लॉडगंज चले गए, 1 साल वहाँ पर वेस्ट, एक बार मेडिसिन ले ली, उसने 6 महीने की भेज दी, तो आप वहीं पर लगे रहते हैं। और जब वो ट्रीटमेंट के लिए आते हैं तो वो बोन मेड्स के साथ आते हैं, लिवर मेड्स के साथ आते हैं, तो उसके बाद फिर उनको लगता है कि अब ये हमारी होप है, अब हॉस्पिटल स्टाफ को कुछ करना चाहिए, अब ये क्यों नहीं हमें फर्स्ट स्टेज तक लेकर जा रहे। लेकिन फॉल्ट किसका था, शायद पेशेंट का था, या हमने उनके साथ अच्छी तरह से कम्युनिकेट नहीं किया कि नहीं आपको मीनवाइल वेट करना है, वेट करना आपके लिए ज़रूरी है। और कुछ फॉल्ट उनका है जिनकी हम फेक एडवर्टाइजमेंट आम तौर पे पढ़ रहे हैं। नॉर्मली देखते हो टीवी पे फलाना बाबा जी आ गए, जय बाबे दी देखते हो ना सुबह हमेशा एडवर्टाइजमेंट पे, तो वो एडवर्टाइजमेंट कहीं ना कहीं हमारी गवर्नमेंट की भी गलती है, जो एडवर्टाइजमेंट उन पे ज़्यादा फोकस कर रही हैं। नेक्स्ट थिंग, एज ग्रुप 80+ डायग्नोज विद कैंसर कांट टॉलरेट द ट्रीटमेंट, दे आर नियर टू नेचुरल डेथ। सो आप नीचे देख रहे हो कि इमेज ये 90+ वुमेन थी, तो इसको ये तब लेकर आए हैं जब पेशेंट की फाउल स्मेल आने लगी कि अब हम नहीं देख सकते हैं, तो इनकी डॉटर इन लॉ कहते हैं कि मैम आज ले आए पेशेंट, ऑपरेट ही कर दो बस। तब पेशेंट कैसे, जब फाउल स्मेल आ गई अब हम नहीं संभालेंगे, अब आप संभालो। तो ऐसे में क्या है कि उनको ये लगता है कि शायद माता जी साल ही हो, 2 साल ही हो, हु नोज हाउ मच वी कैन लिव, ठीक है, हमारी उम्र तो भगवान ने लेकर भेजी है ना, जितनी है वो तो हमें निकालनी पड़ेगी। तो लेकिन पेशेंट को लगता है कि ओल्ड एज है तो उनको ट्रीटमेंट देना ज़रूरी नहीं है। ऑल्दो मेरे एक्सपीरियंस के अकॉर्डिंगली 100+ ईयर के भी जो पेशेंट्स आए हैं जिनके IHCs अच्छी आई हैं, 5 ईयर से ज़्यादा सर्वाइवल है। इवन विद सिंपल एनेस्ट्रोजोल भी उनका कम्प्लीटली जो डिसीज़ है कुछ पूरा गुड रिस्पॉन्स है, कोई ब्रेस्ट में लीजन नहीं है, कुछ नहीं है, तो दे आर डूइंग गुड। सो ये क्या है, तो उनका अच्छा डिसीजन था कि वेदर शी इज़ ऑफ 100 ईयर और 98 ईयर, she also is it's her right to go for the treatment. Next thing are the issues post acceptance of treatment. Now slowly if they accept the treatment diagnosis, there are still certain issues during the treatment itself. So first is the chemotherapy. So concerns क्या होंगे chemotherapy के लिए? What kind of medications they will give? What is chemotherapy? तो chemotherapy सबको ये लगता है कि एक डायरेक्ट इंजेक्शन ही लगाने हैं और पता नहीं क्या चीज़ होगी। तो जब उनको बोलते हैं कि नहीं नहीं ड्रिप में लगेगा, तो उनको इसी से ना इतना साइकोलॉजिकल सपोर्ट मिलता है कि अच्छा ड्रिप में जाएगी, स्लोली जाएगी, ऐसे कोई बड़ा सा इंजेक्शन तो नहीं लग रहा, कुछ ऐसे तो नहीं है। सो ये जो क्यूरीज होती हैं ये यूजुअली प्रेजेंट होती हैं। व्हाट साइड इफेक्ट्स कैन आई एक्सपेक्ट फ्रॉम कीमोथेरेपी मेडिकेशंस? विल आई लूज माई हेयर? तो मैं नीचे लिखा है एटलीस्ट योर हेयर्स विल ग्रो बैक। तो एक डॉक्टर है जो उसके खुद की बाल्डनेस है, तो उसको बता रहा है कि यू कैन गेट योर हेयर्स बैक एटलीस्ट, है ना। तो वो पक्का आते हैं, बस सिर्फ ये कि टेक्सचर भी चेंज हो सकता है, कर्ली हो सकते हैं। तो नेक्स्ट थिंग इज विल पेशेंट बी मेडिकेटेड फॉर साइड इफेक्ट्स? डेफिनेटली पोस्ट कीमोथेरेपी हर एक पेशेंट को ट्रीटमेंट दिया जाता है। डू वी नीड टू ब्रिंग आर पेशेंट डेली टू द हॉस्पिटल? आई थिंक ये रेजिमेंट्स ही होते हैं जो वीकली होते हैं या 21 डेज का होता है, मंथली होता है, तो ये नीड नहीं होती कि डेली आने के लिए। हाउ लॉन्ग आर पेशेंट नीड्स कीमोथेरेपी? इट ऑल डिपेंड्स अपॉन द डिसीज प्रोग्रेशन and how the patient is responding to the treatment. It is necessary to eat before, is it necessary to eat before chemotherapy? तो पेशेंट हमारे पास ज़्यादातर NPO आ जाते हैं, कहते हैं हमने खाना नहीं खाया क्योंकि कीमोथेरेपी लगनी है। तो ये भी पूछना ज़रूरी है। देखो बेटा, वो तो बिल्कुल ही ऐसे पेशेंट हैं कि इनको कुछ नहीं पता, आपने ये सोचना उनको कुछ नहीं पता, सब कुछ आपने जो इनपुट दे दी ना वही वो लेकर चलेंगे। अगर आप उनको बोल दोगे ना सर्जरी के बाद नहाना है, तो वो नहाएंगे, नहीं तो वो 15 दिन आपके वेट करेंगे जो आपने बताया नहीं था कि हम नहाए नहीं। जब आप डील करोगे ना पेशेंट्स के साथ, तब आपको पता चलेगा कि हाँ ये प्रॉब्लम भी है, वाकई वो हमारे पास टोटली डिपेंडेंट है हमारे ऊपर। तो इज़ इट नेसेसरी, शुड आई टेक माई रेगुलर मेडिकेशन? डेफिनेटली अगर किसी पेशेंट को हाइपरटेंशन और डायबिटीज़ है तो वो रेगुलर मेडिकेशन कंटिन्यू करनी है। आर देयर एनी मेडिकेशंस आई शुड अवॉइड? तो जो एस्प्रिन मेडिसिन होती हैं लाइक जिनसे प्लेटलेट डाउन होता है, जो प्लेटलेट क्या होते हैं क्लॉट्स के एग्रीगेशन में हेल्प करते हैं, ठीक है। तो अगर ये डाउन हो रहे हैं और ऊपर से कीमोथेरेपी दे रहे हैं उसमें भी डाउन हो रहे हैं, तो दैट कैन कॉज ब्लीडिंग फ्रॉम एनी साइट ऑफ द बॉडी। वो शुड वी कॉल? तो हमें अपने हॉस्पिटल प्रोटोकॉल के अकॉर्डिंगली उनको हॉस्पिटल नंबर ज़रूर देना चाहिए। तो दिस इज़ द प्री एंड इंट्रा कीमोथेरेपी असेसमेंट जो नर्सिंग प्रोफेशनल की तरफ से होनी चाहिए कि एक असेसमेंट बहुत ज़रूरी है, ठीक है। तो इसमें क्या है कि आपको हेल्थ असेसमेंट, जनरल कंडीशन, उनकी जो डाइटरी पैटर्न है, जो एलर्जी के, और अगर उनको कीमोथेरेपी स्पेशली कोई हिस्ट्री है कैंसर की अगर पेशेंट में, तो कौन कौन से ड्रग लग चुके हैं पेशेंट के, बिकॉज वी डोंट हैव टू रिपीट दोज ड्रग्स, इट कैन कॉज कीमोटॉक्सिसिटी इन देम। और उसके बाद इंट्रा या ऑन गोइंग हेल्थ असेसमेंट कैरी ऑन करते रहना चाहिए कि व्हाट काइंड ऑफ साइड इफेक्ट्स आर शोन इन द पेशेंट ड्यूरिंग प्रीवियस साइकिल एंड व्हाट वर द इन्वेस्टिगेशंस। अगर कंटिन्यूसली पेशेंट के ब्लड HB डाउन ही जा रहा है, तो दैट मीन्स हम कहीं ना कहीं स्किप कर रहे हैं। अगर हमारे पास सपोज कोई पेशेंट वो है, हमने CT स्कैन करवा लिया चेस्ट एब्डोमेन का, तो उसके बाद या अल्ट्रासाउंड ही करवा कर सब कुछ शुरू कर दिया कि पेट नहीं अफोर्डेबिलिटी है, अगर उसके HB 6655 रह रहा है, तो क्या रीज़न हो सकता है? HB अगर कम है, कुछ आइडिया है? हो सकता है उसको बोन मैट्स हो, ठीक है, जिसकी वजह से हम ट्रीटमेंट दे रहे हैं बट वो ऑलरेडी स्टेज 4 पे, तो उसको रूल आउट करना ज़रूरी है। तो इसलिए असेसमेंट एक मोस्ट इम्पॉर्टेंट पार्ट है नर्सिंग के पॉइंट ऑफ व्यू से और इवन डॉक्टर्स के पॉइंट ऑफ व्यू से, कि असेस करोगे तो ये ड्यूरिंग डायग्नोसिस, ड्यूरिंग ट्रीटमेंट हम जो है पेशेंट को ट्रीट आउट कर सकते हैं। ये जो है ये मैंने अपनी तरफ से बनाया था पेशेंट्स के लिए। तो ये असेसमेंट क्यों ज़रूरी है? कुछ पेशेंट्स क्या हैं कि ओरल मेडिकेशन पर ही होते हैं, ठीक है। ओरल मेडिकेशन ये ब्रेस्ट कैंसर पेशेंट्स जो कि कैप्सिटाबिन और लिपेटानिब पे था, तो ये कैप्सिटाबिन का साइड इफेक्ट है, HFS सिंड्रोम बोलते हैं। HFS सिंड्रोम क्या है? जो फाइन कैपिलरीज होती हैं आपके पाम्स की, सोल की, वहाँ से कीमोथेरेपी क्या इन्फिल्ट्रेट कर देती है। तो देख रहे हो आप इसका कलर डिस्कलरेशन देख रहे हो, ये पेनफुल भी था, ठीक है। तो उसके नेल्स भी खराब हो गए थे, पेशेंट चल नहीं सकता है इस चीज़ में। तो हम यूजुअली क्या है HFS क्रीम सबको मैं पर्सनली बोलती थी कि लेनी है, याद भी करवाते थे। तो पेशेंट्स का क्या हुआ कि पेशेंट को लगता था कि ऐसी क्रीम दे दी, मेरे लिए तो ट्रीटमेंट तो मेडिसिन नहीं करना है ना, तो क्रीम ऐसी छोड़ देते थे कि ये छोड़ दो, एक चीज़ तो कम होगी, क्योंकि डेली 20 तक टैबलेट्स लेनी, अपनी बीपी की भी, है ना, देन ब्लड शुगर मॉनिटर भी करना है पेशेंट में, फिर 4-5 टैबलेट्स कैप्सिटाबिन के लेनी है और 5-6 टैबलेट्स लिपेटानिब की लेनी है। तो एक बहुत बड़ा बर्डन है ये उस पेशेंट के लिए, बार बार रिमाइंड करना। तो ये पेशेंट्स की जो ये कॉम्प्लिकेशंस लेकर आए, फिर हमने क्या किया, एक चार्ट बनाया इससे, ताकि पेशेंट को थोड़ा ईजी हो जाए। तो ये किस वजह से हुआ, क्योंकि असेस किया तो हमें पता चला कि क्या प्रॉब्लम्स आ रही हैं, तो उसका एक सोल्यूशन निकालने की ट्राई किया। नेक्स्ट थिंग इज गाइडिंग पेशेंट्स एंड फैमिली अबाउट द कीमोथेरेपी। सो उनको ये सबसे इम्पॉर्टेंट है जो हम निगलेक्ट करते हैं, दैट इज़ द डेंटल चेकअप। सो आपने नोटिस किया होगा कि पेशेंट्स मोस्टली ड्यूरिंग कीमोथेरेपी बताते हैं आई एम हैविंग डेंटल केरीज, मेरे एक टीथ लूज था, मैंने निकलवाया नहीं। तो ड्यूरिंग कीमोथेरेपी आप कोई भी डेंटल का जो भी प्रोसीजर है नहीं कंडक्ट कर सकते, क्योंकि वो हीलिंग जो है डिले हो जाएगी, इवन ड्यूरिंग कीमोथेरेपी, ड्यूरिंग रेडियोथेरेपी एज वेल। तो सबसे जो मेन इंपॉर्टेंट होता है कि आप उनको बोलो कि पैप स्मीयर की रिपोर्ट्स भी रॉन्ग आएंगी जब कीमोथेरेपी चल रहा है। तो ये कीमोथेरेपी स्टार्ट करने से पहले ही एक डेंटल चेकअप और एक पैप स्मीयर करवा लेना चाहिए। देन दे कैन अरेंज देयर विग बिफोर हेयर लॉस। व्हाई? बिकॉज देयर हेयर कलर कैन मैच, they can match their hair color and texture before administering the chemotherapy. So next thing is we have to discuss the route of administration. Route of administration can be IV, oral, subcutaneous, intrathecal and the intracavitary. So IV में basically आजकल तो कीमोपोर्ट ही चल रहे हैं, आई थिंक जो एडवांस हॉस्पिटल्स हैं तो उसमें कीमोपोर्ट्स होते हैं। रीज़न क्या है? IV लाइन से एक्स्ट्रा वेसेशन हो जाती है, तो एक और प्रॉब्लम है पेशेंट के लिए कि उनको एक फिर सर्जिकल प्रोसीजर के लिए जाना पड़ता है जब एक्स्ट्रा वेसेशन हो जाती है। एक्स्ट्रा वेसेशन पता है ना, 4th ईयर के हो? हाँ, तो ओरल क्या है कि जैसे मैं आपको बताया था मल्टीपल टैबलेट्स लेनी है, सो दे कैन स्किप द टैबलेट्स। नेक्स्ट थिंग ये कि सबक्यूटेनियस और इंट्राथीकल, सबक्यूटेनियस में पेशेंट्स के घर पर भी लेकर जाते हैं मेडिकेशन, ऑल दे नीड की रिमाइंडर होना चाहिए कि 28 डेज बाद है या 21 डेज बाद है। नो इंट्राकेविटरी क्या है कि आप पोर्ट से या ट्यूबिंग से पेशेंट को कीमोथेरेपी देते हैं, इवन ड्यूरिंग सर्जरी भी दे सकते हैं। तो हमने कुछ पेशेंट्स को हमने पोस्ट सर्जरी उस टाइम पर भी कीमोथेरेपी एडमिनिस्टर की हुई है। नेक्स्ट इज द यू हैव टू टेल द पेशेंट रिगार्डिंग योर शेड्यूल ऑफ द कीमोथेरेपी, how many days they need to visit the hospitals post chemotherapy. And next thing is we have to discuss the side effects, intermediate, early or the delayed. Need to tell the expected medical interventions they have to take. तो अब इसमें immediate जो urgent medical जो वही डिस्कस करूँगी। urgent जो medical interventions किस किस में लेनी पड़ेंगी? If the patient is having low platelet count, oral ulcers that are not healing at all, bleeding from any site, either rectal, pervaginal, this is the emergency case, they have to come to the hospital. If fever is there, 100+ fever is there, they need to visit the hospital. Persistent stools or the vomiting is there, that means the patient can dehydrate and he can expire at home also. Next thing is we need to tell the frequency of blood tests and what kind of symptoms they need to discuss with the health professionals. So this is what I think every hospital is providing their own protocols, their own summarization to the patient, so that they can have a list of things to do at their homes to prevent from the vomiting, diarrhea itself. This one is the next topic is the surgery. So during surgery, we need to take informed consent even before chemotherapy as well as before surgery also. So there are various diagnostic evaluations can be done by biopsies, एक्सीजनल, इंसीजनल एंड द निडल बायोप्सी। सो आप पिक्स देख रहे हो, लास्ट में 4 निडल बायोप्सीज हैं जो कि ब्रेस्ट या एक्सिलरी मास हो, कोई माउथ में लीजन हो तो उस टाइम की कर सकते हो। नेक्स्ट थिंग इज एक इंसीजनल, जिसमें सिर्फ एक इंसीजन लगा के फ्यू बिट्स ऑफ द ट्यूमर टिश्यूज आर एक्साइज्ड। ओके, नेक्स्ट एक्सीजनल बायोप्सी में क्या है कि आप होल जो टिश्यू है, अगर 2 पेशेंट्स, कोई भी पेशेंट है, सपोज ब्रेस्ट की एग्जाम्पल दूँ तो एक FNAC आ रही है जिसमें फ्यू सेल्स ऑफ टिपी सीन्स, तो उसमें डाउटफुल डाल दिया कि हाँ ये कैंसर हो भी सकता है, एक है बिनाइन है, तो उसमें आप पेशेंट को घर नहीं भेज सकते हो कि हाँ तेरी एक FNAC बिल्कुल नॉर्मल है, दूसरी में शायद डाउट है तो उसको रखे रखो। तो उस केसेस में क्या हो जाता है कि एक्सीजन बायोप्सी करनी ज़रूरी हो जाती है रूल आउट करने के लिए। नेक्स्ट थिंग इज प्राइमरी और द क्यूरेटिव ट्रीटमेंट। सर्जरी कैन बी डन एज अपफ्रंट, पोस्ट NACT एंड द पोस्ट RT, और इवन इट कैन बी डन एज अ प्रोफिलेक्टिक। प्रोफिलेक्टिक कर सकते हैं हम, जैसे किसी पेशेंट को ट्रीटमेंट चेंज करना है, अगर टैबलेट टेमोक्सिफिन से एस्ट्राजोल पे करना है तो उसके हम प्रोफिलेक्टिकली हम उसके बायोलेटरल ओफ्रेक्टमी कर देते हैं। फिर रिकंस्ट्रक्टिव प्रोसीजर जो होते हैं जैसे ड्यूरिंग सर्जरी और फॉलो प्रोसीजर, हेड एंड नेक के केसेस हैं तो उनमें रिकंस्ट्रक्शन कर सकते हैं, पोस्ट MRM कर सकते हैं रिकंस्ट्रक्शन। पैलिएटिव सर्जरी मीन्स जिनके जो हमारे पास स्टेज 4 में आए, या तो उनका बर्डन रिड्यूस करने के लिए करेंगे पैलिएटिव सर्जरी, या उनको जैसे सी एसोफेगस का है विद मल्टीपल मेट्स तो उनके FJ कर देते हैं, फीडिंग जिजोनोस्टमी कर देते हैं। सो इट्स अ पार्ट ऑफ पैलिएटिव सर्जरी ओनली कि हाँ इतना करवा लो ताकि तुम्हें रिलीफ मिल जाए। नेक्स्ट इज स्पोर्टिव इज लाइक इन्फ्यूजन, ये इन्फ्यूजन पोर्ट्स जो होते हैं, कीमो पोर्ट्स होते हैं, वो डालना। तो पोस्ट सर्जरी कॉन्सिक्वेंसेज क्या हो सकते हैं पेशेंट के, उनकी जब हम पेशेंट को अगर जाते हैं हमारे पास कोई पेशेंट आए तो उसको बोल दे सर्जरी करवानी है बट इसके इतने इतने डिसएडवांटेजेस या कॉन्सिक्वेंसेज निकलेंगे, तो कोई पेशेंट नहीं सर्जरी करवाएगा अगर उनको बोलें कि हाँ तुम्हारी क्लॉस्टमी शायद परमानेंट ही हो। अगर उनको बोल दे परमानेंट क्लॉस्टमी के साथ रहना पड़ेगा तो वो कभी एग्री नहीं करेंगे कि हाँ हमारी सर्जरी कर दो। उनको पहले समझाना पड़ेगा, एक एग्जाम्पल सेटअप करनी पड़ेगी। एम्पुटेशन करनी है तो एग्जाम्पल सेटअप करनी पड़ेगी। कॉमन हेल्थ गेम्स में देखते हो ना कि अब तो डिसेबल्ड भी कितना अच्छा प्ले करते हैं, इनफैक्ट हमारे से अच्छे हैं वो स्पोर्ट्स में। तो पेशेंट्स को बताना पड़ेगा कि हाँ अच्छे जो हीरो एक्टर्स हैं उनकी एग्जांपल्स देनी पड़ेगी, जो बड़े लोग उनकी एग्जांपल दो। तो इसमें क्या है कि लॉस ऑफ वॉइस कैन बी सीन पेशेंट्स हैविंग सीए टंग, या किसी की ट्रैकियोस्टमी कर दी और हमने कंसेंट में लिए ही नहीं कि हाँ आपकी वॉइस भी जाएगी उसके साथ जब हम ट्रैकियोस्टमी करेंगे। तो ये जो चीज़ें हैं आपको पेशेंट को काउंसलिंग भी करनी होगी बताने के साथ साथ कि ये जो ट्रैकियोस्टमी आउट होगी उसके बाद हम आपको धीरे धीरे ट्रेन करेंगे ताकि आपकी जो वॉइस है वो आप नॉर्मली कैसे बोल सकते हो। मैं आपको एग्जांपल बताऊंगी। सो DVTs एंड ब्लड क्लॉट्स कैन बी सीन इन रिकंस्ट्रक्टिव सर्जरीज लाइक फ्री फ्लैप। तो DVTs बेसिकली उनमें होता है जो पेशेंट्स हिलते ही नहीं है, देखा होगा आपने। तो पेशेंट्स को ये काउंसल करना ज़रूरी है कि आप अपने DVTs के प्रिवेंट करने के लिए आपको एटलीस्ट लेग एक्सरसाइजेस करनी होंगी और नेक्स्ट डे आपको बेड से उठना होगा तो थोड़ा थोड़ा वॉक करना ज़रूरी है। सो निमोनिया और जो पेशेंट्स को निमोनिया से प्रिवेंट करने के लिए क्या होता है, ये स्पायरोमीटर दिखाया मैंने आपको। तो ये प्री ऑपरेटिवली ही ब्रीदिंग एक्सरसाइज स्टार्ट कर देनी चाहिए एंड पोस्ट ऑपरेटिव भी स्पायरोमीटर यूज़ करना चाहिए। नेक्स्ट इज दे मे नीड ट्रैकियोस्टमी, वी नीड टू टेक कंसेंट इवन ड्यूरिंग इंटुबेशन ना। हेड एंड नेक के केसेस में क्या होता है कि सडनली प्लान चेंज होता है कि नहीं हो रही इंटुबेशन तो ट्रैकियोस्टमी कर दो, बट वो पेशेंट को बताना ज़रूरी होता है कि हाँ अगर तुम्हारा सर्जरी हुई तो ट्रैकियोस्टमी भी करनी पड़ेगी। नेक्स्ट इज डिसफिगरमेंट ऑफ फेस। तो ये देख रहे हैं नीचे कमांडो वाला पेशेंट दिखाया मैंने, तो ये हेड एंड नेक का केस था। तो जो हेड एंड नेक के पेशेंट्स होते हैं उनकी सबसे ज़्यादा दिक्कत किस में आती है, डिसफिगरमेंट ऑफ फेस। इवन पेशेंट को साइकोसिस भी हो सकता है जब वो एक्चुअल में आपका अपना फेस देखते हैं ना पोस्ट सर्जरी। तो दिस इज़ वेरी एम्बैरेसिंग फॉर देम कि हाँ उनका फेस जो है टोटली चेंज हो गया, उनका जो स्वेलोइंग का मेथड है वो चेंज हो चुका है, दे कांट स्पीक प्रॉपरली। तो यही होता है कि हम आप पेशेंट को बताएं कि जितना जल्दी आओगे उतना ही रेडिकल सर्जरी कम होगी, उतना ही आपको ईजी होगा पेशेंट के लिए ट्रीटमेंट के लिए। तो इनफर्टिलिटी इश्यूज़ जो हैं वो तो आजकल मैनेज हो ही सकते हैं, सर ने बताया क्रायो प्रिजर्वेशन की वजह से। तो इनफर्टिलिटी इश्यूज़ यंग पेशेंट्स में डिस्कस करने बहुत ज़रूरी हैं बिकॉज वो इलीगल हो जाता है अगर हम 30 ईयर में बायोलेटरल ओफ्रेक्टमी कर दें और उनको एक ही फीमेल चाइल्ड था। तो ये जो चीज़ें हैं वो पेशेंट के साथ डिस्कस करनी बहुत ज़रूरी है। नेक्स्ट इज साइकोलॉजिकल मोबिलिटी। सो दिस कैन बी सीन इन पोस्ट MRM, पोस्ट एम्पुटेशंस, ठीक है, एंड इवन इन रिकंस्ट्रक्टिव सर्जरीज लाइक कमांडोज। सो दीज आर द प्रोसेसेस दैट वी आर डिस्ट्रीब्यूटिंग सिंस 2018। तो ये हमने पेशेंट को देखा कि पेशेंट के लिए एक सिलिकॉन का प्रोसेसेस अरेंज करना इजी नहीं है, ना ही कोई पेशेंट विलिंग है, क्योंकि MRM में डिसीजंस कौन लेता है, ज़्यादातर हस्बैंड आते हैं निकाल दो जी ब्रेस्ट, कोई बात नहीं। कोई भी पेशेंट फीमेल से नहीं पूछता है, कोई भी स्टाफ की आपकी क्या चॉइस है, आप रखना चाहते हो, ब्रेस्ट प्रिजर्व करना चाहते हो कि नहीं, बिकॉज नाउ डेज यू कैन प्रिजर्व द ब्रेस्ट वेरी इजीली विद ऑन्को मेमोप्लास्टी सर्जरीज, यू कैन प्रिजर्व द ब्रेस्ट। तो उसके लिए ये UK से मंगवाए थे हमने ताकि पेशेंट्स को थोड़ा दीज आर फ्री ऑफ कॉस्ट, वी कैन डिस्ट्रीब्यूट टू ईच पेशेंट्स, दे कैन यूज इट। सी नाउ शी कैन गो एनीवेयर विद दीज प्रोसेसेस एंड शी कैन फील कॉन्फिडेंट। ऑल द मतलब कि ये इतना ज़रूर वो नहीं कर सकते हम, साइकोलॉजिकली उसको है कि मेरा ऑर्गन लॉस हुए, बट स्टिल जो अपीयरेंस वाइज है तो उसको साइकोलॉजिकली ये अच्छा लगता है कि वो पार्टीज अटेंड कर सकता है, बाहर अंदर जा सकता है। तो ये एक बिग सपोर्ट है पेशेंट के लिए। नेक्स्ट थिंग इज जो मैम ने रखा था कि जो डिवाइसेस हैं वो यूज़ कर सकते हैं, क्रायो प्रिजर्वेशन सर्जरीज कर सकते हैं, ये इलेक्ट्रो डिवाइसेस हैं कुछ, क्योंकि इम्प्लांट्स अगेन कॉस्टली हैं, तो पेशेंट इलेक्ट्रोफेरेंक्स ये हार्डली 12,000 की कॉस्ट है कि पेशेंट बहुत अच्छे ईजिली से अपनी जो मैसेज है कन्वे कर सकते हैं इंस्टेड ऑफ राइटिंग, स्पेशली इन केस ऑफ सी वोकल कॉर्ड्स और पेशेंट हु आर हैविंग प्रोलॉन्ग ट्रिक्योस्टमी. So these are the things that you can manage. Pneumatic bandages and the crepe bandages can be used to reduce the lymphodemas, or prostheses can be used in case of the amputations. Now radiotherapy itself, next topic is the radiotherapy. Radiotherapy itself is a stigma for the patient. Radiotherapy सेका है तो मतलब कि patient जल सकता है. ये you need to explain कि it's like a X-ray, but the dose is 10,000 times much more higher than the X-ray beam. Otherwise, it all needs hardly few minutes, 1 or 2 minutes to do the procedure. So yes, it is safe and really effective. Most of the cancer patients are treated with radiotherapy alone. It's very effective treatment, but a few issues are still there, like infertility issues can be seen, and in patients like head and neck, xerostomia, stomatitis can be seen. So next thing is you need to explain the goal and benefits of the radiation to the patient, just like chemotherapy. Next thing is preparation for the uncertainty. So preparation for uncertainty is needed because patient can, disease can progress at any time. All the patient had taken the whole treatment, but after 2 or 3 years, they got some new form of cancer, they got metastasis. So it can happen at any time. So we need to prepare the patient after treatment also, that you need to follow, be on follow-up treatment. You need to visit our hospital. And so that we can immediately caught the metastasis as early. Next thing is the palliative phase. Palliative phase is the certain misconceptions are there for palliative phase. People think that it is for the dying people only, but no, we can start the palliative care itself from the beginning of the treatment, because palliative जो care members होते हैं, they not only furnish the demands of the patient, but they also take care of the family members as well. So instead of they not only provide the pain, they not only do the pain management and provide the oxygen therapy or the wound management, but we can proceed for the palliative radiotherapy, hormonal therapy, chemo, surgery as well. RFA procedures can also be done. So radiotherapy, these procedures are done basically to relieve the pain or to relieve the other issues, like patient having bone mets in the spine can have severe pain. So in that case, you need to give the palliative radiotherapy, or that patient can have the numbness in the lower feet, that patient can got paralysis. So in such cases, palliative radiotherapy is a very beneficial thing. So this one is the CanKid group, CanKids and 2 groups, CanSport, both groups are working in our institute. CanKids helps the patients who are children's basically. They provide everything. They provide treatment free of cost. They provide diet. They provide accommodation and transportation facilities to the children's. Next thing is the CanSport. They provide the painkillers. They provide even diapers, a Ryle tube, how to teach the patient's attendant to give Ryle's tube feed, even how to tackle the minor things at the home. So next thing is the caregiver burnout. Now, along with the patient, caregiver who is providing care to the patient sees lot of changes in them, because हमने क्या किया, patient आया, उसको diagnose हुआ cancer, तो हमने जबरदस्ती जो है patient का attendant है वो हमारी एक चेन बन जाता है हेल्थ केयर टीम मेंबर का, हम सब कुछ उसको एक्सप्लेन करने लग जाते हैं, अब तुमने ये करवाना है, तो उसको भी एक्सेप्ट करने का टाइम नहीं मिलता है कि एक उनकी जो घर के फ्रेम में है एक पेशेंट कैंसर का डायग्नोज हो चुका है और उसको अब अपनी सब जॉब से लीव लेनी है, उसको अपने बच्चे छोड़ने पड़ेंगे अपने पेरेंट्स को देखने के लिए, तो उसके जो लाइफ है वो सारी क्या एकदम हैफाजर्ड हो जाती है कि उसको कोई शेड्यूल जो है पूरा टोटली चेंज हो जाता है. सो दैट स्ट्रेस कैन बी वर्सन विद टाइम. So caregiver burnout symptoms are the disturbed sleep, irritability, isolation, severe mood swings can be seen in them. They usually ignore their own medical appointments. They don't take their own antihypertensive medicines. They don't like to go for hospital for more visits for themselves also, because they are already undertaking their care of their own patient. So ये बहुत difficult task है. जब हम patient का attendant का देखोगे ना, आप caregivers का, तो उनका हाल अच्छा नहीं होता. वो पेशेंट का देखना, वो बोलते हैं हम 2-2 घंटे बाद अपने पेशेंट को ये दे रहे हैं, वो दे रहे हैं, बट वो खुद अपनी डाइट जो है टोटली इग्नोर कर चुके होते हैं. तो उनको करना है, काउंसल करना है पेशेंट एंड प्लस केयर गिवर को, ताकि वो अर्ली वार्निंग साइंस एक्सेप्ट करें, देखें अपने आप में एक बिल्डिंग, एक सपोर्ट, एक सोशल नेटवर्क डेवलप करें, शेयर करें अपनी फैमिली के साथ, अपने रिलेटिव्स के साथ कि हाँ कि उनके घर में कैंसर का पेशेंट है, क्या कुछ टाइम के लिए वो उसकी टेक केयर कर सकते हैं. देन दे कैन शेयर, डिस्कस द थिंग्स विद द सोशल ग्रुप, साइकेट्रिस्ट, विद द नर्सेज एज वेल, to so that they cannot be diagnosed themselves as with the psychiatric issues. So you need to tell them that they have to focus on the positive thing. Whatever they did for the patient was the best they have given to the patient. That was they always feel कि हमने पूरा टाइम 1 साल लगा दिए, 2 साल लगा दिए, लेकिन हमारा पेशेंट फिर भी मेटास्टाइज हो गया. तो आपको उनको सपोर्ट करना चाहिए साइकोलॉजिकली कि जो भी आपने किया अपनी तरफ से आपने पूरा किया, आप पूरा हर विजिट पे आते रहे हो. वट एवर यू डिड वॉज द बेस्ट, यू आर द बेस्ट ऑन योर with whatever was given by you. So thank you.
Thank you so much, Ramandeep ma'am, for sharing such a wonderful views. So the next speaker for the next session, that is current barriers to the effective cancer care, is Miss Mandeep Kaur, who is currently working as a nursing officer at SGH Khanna. She had done MSc in Oncology Nursing, and she have almost 8 years of sound experience in oncology field. Ma'am has good experience in organizing national, international workshops, have participated in paper presentations related to the oncology field, and she has attended first workshop on the role of nurse in breast cancer care at PGIMER, Chandigarh. Ma'am has published 1 national and 1 international paper, and she is also a lifetime member of ONA. Ma'am, this stage is yours.
Good evening, everyone. This is Mandeep. I am currently working at SDH Khanna, that is Subdivisional Hospital Khanna. My topic of presentation is current barriers to effective cancer care. I am the last presenter. This is, I think, a good news to you. First of all, what oncology nurse is. Oncology nurse is a nurse who is basically specialized in care for cancer patients. These type of nurses require advanced certifications and clinical experiences in oncology. Second definition is of barrier. What a barrier mean? Barrier is a circumstance or obstacle that keeps people or things apart or prevents communication and progress. The main topic of my presentation is what are the barriers to effective cancer care. There are many barriers to effective cancer care which hinders the care of cancer patients. And for the proper care of cancer, we need to identify these types of barriers. We can divide these barriers into 3 types. First one are the barriers which are related to patient. Second, barriers are related to system. Third one is related to healthcare team members. We can discuss one by one. First barriers are which is related to the patient. First thing is the denial of diagnosis. As all the presenter explained this denial in a very explanation way. First one is denial of diagnosis. As the patient always said to us that why me? मुझे क्यों हो गया कैंसर, ठीक है. लाइक पेशेंट्स आर ऑलवेज सेइंग दैट व्हाई मी, आई एम नॉट डूइंग एनीथिंग. लाइक एक बार की बात है, एक पेशेंट था, उसको ब्लड कैंसर डायग्नोज हुआ. तो उसने क्या बोला कि मुझे क्यों हो गया ब्लड कैंसर, मैं तो 18 ईयर्स का हूँ, मैंने तो कभी शराब नहीं पी, मैंने कोई नशा नहीं किया, मुझे क्यों हुआ, ठीक है. मैं तो इंटरनेशनल प्लेयर हूँ कबड्डी का, मैं तो हर चीज़ एक्टिविटी भी करता हूँ. तो इट इज़ वेरी कॉमन, वी कैन सी इन द कैंसर पेशेंट, denial of diagnosis. Second one is fear of adverse effects of treatment options. As Ramandeep ma'am already explained us about detail in what type of side effects patients are having. Fear is very common in the patients. Like जैसे एक बार एक पेशेंट थी, उसने हमें कहा कि मैम मेरी ना बेटी की शादी है, आप अभी मुझे कीमोथेरेपी मत देना. क्यों ना देना, कीमोथेरेपी से क्या होगा कि मेरे बाल झड़ जाएंगे, ठीक है, थोड़ी देर के बाद मुझे कीमोथेरेपी आप लगा देना. तो पेशेंट्स में फियर बहुत ही कॉमन है, क्योंकि बहुत सारे साइड इफेक्ट्स होते हैं, क्योंकि ट्रीटमेंट ऑप्शंस बहुत सारी हैं. रेडियोथेरेपी है, कीमोथेरेपी है, बोन मैरो ट्रांसप्लांटेशन है, सर्जरी है, हर एक की अपनी अपनी साइड इफेक्ट्स हैं. नेक्स्ट इज द हाई कॉस्ट ऑफ ट्रीटमेंट. जब मैं ये स्लाइड्स बना रही थी तो मैंने बहुत सारे हॉस्पिटल पे फ़ोन करके पूछा कि कहाँ किस किस हॉस्पिटल में कितना कितना प्राइस है. तो जो प्राइवेट हॉस्पिटल्स हैं वहाँ पर जो इवन रेडियोथेरेपी की कॉस्ट है वो भी लैक्स में है, ठीक है, 1 लाख to 2 लाख 3 लाख. Like in PGI, the treatment which is treatment related radiotherapy cost is 7,500 per session. और जो palliative है उसकी 2,500 है. मीन्स इट वेरीज. और हर एक ट्रीटमेंट जो है इसका, जैसे बोन मैरो ट्रांसप्लांटेशन है, वो भी बहुत ज़्यादा कॉस्टली है, लाइक मोर देन 10 lakhs रुपीज़ इन PGI ऑल्सो. नेक्स्ट इज फियर ऑफ एलिनेशन ऑफ फैमिली मेम्बर्स. जब पेशेंट्स का इलाज होता है, जैसे बोन मैरो ट्रांसप्लांटेशन होनी है पेशेंट की, तो हम क्या करते हैं, पेशेंट के साथ मिनिमल नंबर ऑफ विजिटर्स अलाउ करते हैं. भी पेशेंट के साथ सिर्फ एक ही बंदा रहेगा. क्यों रहेगा? क्योंकि उसको कोई इन्फेक्शन ना हो. तो पेशेंट क्या है, पेशेंट को अपने मम्मी पापा को भी मिलना है, अपने फैमिली मेम्बर्स को भी मिलना है. तो उनमें ये एलिनेशन का जो पॉइंट है ये बहुत ज़्यादा हमने कॉमनली देखा है. जो छोटे बच्चे हैं, मान लो उसकी मम्मी ही रह रही है पेशेंट के साथ, तो वो अपने फादर को मिस करता है कि प्लीज़ मेरे फादर को भी यहाँ बुला लो इलाज के दौरान. नेक्स्ट विच इज़ कॉमन, दैट इज़ कम्युनिकेशन बैरियर. वी हैव सीन दैट पेशेंट को ये बताना कि आपको 4th स्टेज का कैंसर है, that is very difficult for us also. Like even डॉक्टर्स के लिए भी बहुत मुश्किल हो जाता है पेशेंट को बताना. पर ये बताना भी ज़रूरी है, क्योंकि अगर हम नहीं बताएंगे तो पेशेंट किसी और सोर्सेज से पता करेगा कि मुझे बीमारी क्या है, मैं क्यों हूँ हॉस्पिटल में, ठीक है. नेक्स्ट आर द बैरियर्स विच आर रिलेटेड टू आवर सिस्टम. फर्स्ट ऑफ ऑल प्रॉब्लम्स इन द अवेलेबिलिटी ऑफ ट्रीटमेंट्स. बहुत सारे पेशेंट्स बहुत दूर दूर से इलाज करवाने आते हैं हॉस्पिटल्स में, और बहुत सारे हॉस्पिटल्स में, जैसे मुझे अभी पता चला कि कई हॉस्पिटल्स में पेट स्कैन अवेलेबल नहीं है, यहाँ पर भी नहीं है. तो जो अगर पेशेंट को ट्रीटमेंट की अवेलेबिलिटी नहीं होगी, तो ऑलरेडी पेशेंट को कैंसर है जो कि क्या है, डिप्रेशन का सोर्स है. अगर उसको आगे ट्रीटमेंट की अवेलेबिलिटी भी नहीं मिलेगी तो वो और डिप्रेशन में चला जाएगा. तो दैट इज़ अ सिस्टम रिलेटेड प्रॉब्लम. सो ऑल दोज ट्रीटमेंट मोडेलिटीज शुड बी, or diagnostic modality should also be present in each and every hospital. Next are the lack of resources. Like sometimes क्या होता है कि जब हम हॉस्पिटल में काम करते हैं तो बहुत सारी चीज़ें हमारे पास नहीं होती. जैसे बायोमेडिकल जो कीमोथेरेपी हुड्स हैं, बहुत सारे हॉस्पिटल्स में नहीं होंगी. तो दैट इज़ इम्पॉर्टेंट थिंग कि जो रिसोर्सेज है वो पूरे होने चाहिए हॉस्पिटल्स में. नेक्स्ट इज स्टैंडर्डाइज प्रैक्टिकल टूल. स्टैंडर्डाइज प्रैक्टिकल टूल मीन्स पेशेंट जो है, बहुत सारी ट्रीटमेंट ऑप्शंस हैं, बहुत सारे उसके साइड इफ़ेक्ट्स हैं, बट उन जो साइड इफ़ेक्ट्स हैं उनको असेस करने के लिए हमारे पास क्या होना चाहिए, टूल्स होने चाहिए. जैसे फटीग का लेवल असेस करने के लिए, उनका जो न्यूट्रिशन है, अंडर नरिश्ड हो गए पेशेंट्स, उनको असेस करने के लिए, और बहुत सारे अदर जो भी उनको साइड इफ़ेक्ट्स हो रहे हैं उनको उनके बारे में उनको असेस करने के लिए टूल्स अवेलेबल होने चाहिए। नो डाउट टूल्स हैं, बट वो अवेलेबल होने चाहिए हॉस्पिटल्स में। क्योंकि एक बार क्या हुआ था, हमने न्यूट्रोपीनिया में एक पेशेंट था, वो उसने क्या कहता उसका सारा ट्रीटमेंट फिनिश हो चुका था, कीमोथेरेपी। ही वाज डायग्नोस्ड विद ALL, दैट इज़ अ ब्लड कैंसर ऑफ ब्लड कैंसर। उसको क्या हुआ, उस पेशेंट ने बोला कि मुझे तो घर जाना है, वो लामा लेके घर चला गया। जब वो गया घर तो वो बहुत सारी और इन्फेक्शंस लेके हमारे पास आया, ठीक है। और उसके बाद क्या हुआ, उस पेशेंट की डेथ हो गई। क्यों हुई डेथ? क्योंकि पेशेंट जो था उसको पता ही नहीं था कि ये सब चीज़ें भी हो सकती हैं। जितने बैरियर्स मैंने पहले डिस्कस किए हैं, अगर वो पेशेंट को हम प्रॉपरली बताएंगे क्या क्या साइड इफ़ेक्ट हो सकते हैं, क्या क्या चीज़ें उनको आगे जाके हो सकती हैं, तो वो पेशेंट मतलब सुनेंगे आपकी बात। कुछ पेशेंट नहीं भी सुनते, तो उनको भी हमने देखना होता है। लैक ऑफ इन सर्विस एजुकेशन प्रोग्राम्स, अगर हॉस्पिटल्स में इन सर्विस एजुकेशन प्रोग्राम्स प्रॉपरली कॉन्टिन्यूशन में होंगे तो क्या होगा, सबकी जो नॉलेज है वो इंक्रीज होएगी। नेक्स्ट आर द बैरियर्स विच आर रिलेटेड टू हेल्थ केयर टीम। फर्स्ट ऑफ ऑल, नॉट बीइंग श्योर ऑफ देयर डायग्नोसिस एंड प्रोग्नोसिस। जैसे पेशेंट हमसे सबसे पहले ये क्वेश्चन करते हैं कि ठीक है मुझे कैंसर हो गया है, एक्सेप्ट कर लिया पेशेंट ने, बट मैं कितना टाइम जीऊँगा? 6 महीने, 7 महीने, कितना टाइम? ठीक है, बट हम उसका आंसर नहीं दे पाते एग्जैक्टली भी हाँ आप 6 महीने ही जियोगे। जैसे जब मैं BSc फर्स्ट ईयर में थी तो एक मुझे CA प्रोस्टेट का पेशेंट मिला जो स्टेज 4 कैंसर था उसको, बट वो उसमें पेशेंट जो था वो बहुत ही ज़्यादा मोटिवेटेड पेशेंट था। उसने कहा कुछ नहीं होया जी, ठीक है मैं हो जाना, ठीक है सही, ठीक है। और जब मैं BSc 4th ईयर में थी मुझे वो पेशेंट फिर से मिला। 4th ईयर मतलब 4 साल उसके 4th स्टेज में भी सही चले गए, ठीक है। ब्रेकिंग द बैड न्यूज़, मतलब पेशेंट को कैंसर है ये बताएगा कौन और कैसे बताएंगे हम पेशेंट्स को? जब हम PGI में थे, जब मैं मास्टर्स कर रही थी PGI से, तो वहाँ पर जब हमारी बोन मैरो ट्रांसप्लांटेशन यूनिट में ड्यूटी लगती थी तो वहाँ एक डॉक्टर थे, वो बहुत अच्छे तरीके से सब पेशेंट्स को बताते थे। कुछ पेशेंट्स के रिलेटिव बोल देते थे कि हमने नहीं बताना है जी, हमारे साडे घरदियां नूं ना दस्सिओ भी सानू कैंसर है। पर वो डॉक्टर बोलते थे कि इट इज़ द राइट ऑफ द पेशेंट, कि हमें बताना है, कि पेशेंट को पता होना चाहिए कि उसे कैंसर है। तो बहुत अच्छे तरीके से भी हाँ जी आपको ये प्रॉब्लम है, ये ऐसी बीमारी नहीं है कि जिसका इलाज नहीं हो सकता, ठीक है, इसमें ये इलाज होगा और हम यहीं पर हैं और हम आपके साथ हैं। अगर आपको कोई भी क्वेरी है हम आपको बताएंगे। नेक्स्ट इज द लैक ऑफ स्किल्स, इट इज़ ऑल्सो अ कॉमन बैरियर। लाइक अगर किसी को पता ही नहीं है कि पेशेंट न्यूट्रोपिनिया होता क्या है तो उसकी केयर कैसे होगी। अगर किसी को ये पता ही नहीं कि एब्सोल्यूट न्यूट्रोफिल काउंट कैसे काउंट करते हैं और पेशेंट को न्यूट्रोपिनिया वार्ड में रखना है, आइसोलेशन वार्ड में रखना है, तो वो पॉसिबल नहीं है। तो इसलिए इन सर्विस एजुकेशन प्रोग्राम्स का होना बहुत ज़रूरी है। नर्सेज वर्कलोड, इस टॉपिक के बारे में बताने की किसी को भी ज़रूरत नहीं है कि कितना वर्कलोड है। जैसे हम हॉस्पिटल में काम करते हैं, एमरजेंसी में हूँ मैं आजकल करंटली, तो एक शिफ्ट में जितने भी पेशेंट आ रहे हैं तो हम नहीं देखने हैं, 10 आ रहे हैं, 20 आ रहे हैं, 50 आ रहे हैं, क्योंकि जो कैंसर पेशेंट है उसके लिए उनको डील करने के लिए हमें बहुत सारा टाइम चाहिए। उनके बहुत सारे एस्पेक्ट्स हैं, वो चाहता है कि उसके मतलब 100 क्वेश्चंस होते हैं उनके, मुझे क्या है, क्यों है ऐसा, मुझे क्यों हो गया, ये फैलेगा तो नहीं, इसका इलाज कैसे होगा, कब तक ठीक हो जाऊंगा मैं। नेक्स्ट इज नर्सिंग लीडरशिप। नर्सिंग लीडरशिप का होना बहुत ज़रूरी है, क्योंकि जैसे व्हेन आई वाज इन TMH मुंबई, तो हमने वहाँ देखा था कि वहाँ बहुत सारी नर्सिस थी जो लाइक एज अ लीडर्स काम करती थी। PICC लाइंस वहाँ पर खुद नर्सिस डालती हैं, ट्रोमा केयर नर्सिस हैं, ब्रेस्ट केयर नर्सिस हैं, बहुत तरह की नर्सिस हैं जो वहाँ पर काम करती हैं। तो नर्सिस लीडर का होना ज़रूरी है, बट हर जगह अवेलेबल नहीं है। This is a study. What are the current barriers to effective cancer care coordination? A qualitative study. Like ये स्टडी हुई थी ये जानने के लिए कितने बैरियर्स हैं, मतलब जो मैंने अब तक बताए हैं वही सारे बैरियर्स हैं जो देयर लिस्ट ऑफ बैरियर्स. This study has identified a number of barriers to coordination of cancer care, development and evaluation of intervention based on the findings. Actually, ये केस मैंने डाला था. Case is of a patient. When he was diagnosed, he was 18-year-old. Patient ने आना था, बट वो पेशेंट आ नहीं पाया. क्यों नहीं आ पाया? क्योंकि वो अब्रॉड चला गया. अभी वो पेशेंट था, उसको 8 years बैक उसको ना कैंसर डायग्नोज हुआ था ALCL 2014 में. ALCL दैट इज एनाप्लास्टिक लार्ज सेल लिम्फोमा. वो भी मैक्लॉडगंज गया था, जो जैसे मैम ने बताया, वहाँ पर उसने इलाज कराया. बट उसने अपना जो इलाज है प्रॉपरली ट्रीटमेंट लिया, कीमोथेरेपी हुई उसकी रेडिएशन थेरेपी हुई, उसकी सर्जरी भी हुई, और अब वो बिल्कुल ठीक है. वो सारे बैरियर्स इस पेशेंट में मैंने देखे शुरू से अब तक, बट वो अब प्रॉपरली ठीक है. उसने आना था बट वो पूरी तरह से ठीक है, एंड ही वेंट टू अब्रॉड कैनेडा. नेक्स्ट आर द इम्पैक्ट ऑफ दीज बैरियर्स अमंग कैंसर पेशेंट रिलेटेड. व्हाट इज द इम्पैक्ट पेशेंट्स पर क्या होगा अगर पेशेंट को ये सारे बैरियर्स फेस करने पड़ेंगे तो क्या होगा? एंजाइटी होगी, डिप्रेशन होगा, सोशल आइसोलेशन होगी, डर होगा, फियर होगा, फाइनेंशियल बर्डन बढ़ेगा. कहीं उसने वो सारा पैसा अपने फ्यूचर में लगाना था और कहीं वो अपने इलाज पर लगा रहा है. क्योंकि इंडिया में दैट इज़ अ डेवलपिंग कंट्री, पेशेंट को नो डाउट बहुत सारी स्कीम्स आ गई हैं, बट फिर भी बहुत लोग हैं जो इन स्कीम्स के अंडर नहीं आते, वो अपना इलाज खुद करवाते हैं. सिस्टम रिलेटेड डिक्रीज इन द क्वालिटी केयर. अगर हमारे पास सिस्टम नहीं है, सामान नहीं है, तो हम पेशेंट का इलाज कैसे करेंगे? इंक्रीज ससेप्टेबिलिटी टू इन्फेक्शन. पेशेंट्स आर अनसेटिस्फाइड. इफ देर इज we have lack of resources, lack of skills also. And healthcare team related impacts. There is a communication gap between patient and the team that leads to frustration and also lack of knowledge. This is study which is done by me. Effectiveness of intervention package on the level of anxiety, depression, fatigue and treatment related knowledge among cervical cancer patients. जब मैंने ये स्टडी की, मैंने देखा कि पेशेंट को सबसे ज़्यादा सिर्फ बात करनी होती है कि कोई उन्हें सुने. तो इस स्टडी में मैंने 60 पेशेंट्स लिए थे 2 ग्रुप्स में. 30 जिनको मैंने ट्रीटमेंट दिया, 30 जिनको रूटीन केयर मिल रही थी. ठीक है, तो मैंने सर्वाइकल कैंसर के पेशेंट्स पर ये स्टडी की थी. तो उनका एंजाइटी लेवल, डिप्रेशन लेवल और फटीग लेवल देखा, और उनको कितनी नॉलेज है, ट्रीटमेंट रिलेटेड नॉलेज एंड प्रैक्टिसेस. तो हमने क्या किया, जो इनको हमने एक इंटरवेंशनल पैकेज बनाया जिसमें हमने उनको JPMR दी. जैसे मैम ने बताया था कि पेशेंट को क्या होता है, सबसे ज़्यादा फटीग होती है. तो फटीग को रिड्यूस करने के लिए हम JPMR दे सकते हैं, डेट इज जैकबसन प्रोग्रेसिव मसल रिलैक्सेशन टेक्निक, और काउंसलिंग और होम केयर टेक्निक्स कैन बी इनकॉर्पोरेटेड इन दैट. और मैंने एक बुकलेट बनाई थी जो पेशेंट को डिस्ट्रीब्यूट की थी. और अगर हम काउंसलिंग, JPMR प्लस उनको सारी इंफॉर्मेशन दे देंगे तो क्या होगा? सिग्निफिकेंट डिक्रीज इन द लेवल ऑफ एंजाइटी, डिप्रेशन और फटीग. ठीक है, दैट इज ऑल अबाउट माई प्रेजेंटेशन. थैंक यू वेरी मच.
Thank you so much, ma'am. So this was all about the patient care experiences, not only for the patients, but all the team members who involved in the treatment of cancer patients and who helped these patients throughout their journey of the cancer treatment. So at last, now the stage is open for the discussion or question and inquiry. Speaker.
Here is an important announcement for all the students. There will be an online quiz competition tomorrow at 10 a.m. There will be a 20 MCQs for 20 minutes. All third year students or a final year students from SGRD college and student delegates from other college can participate. Link to download app will be shared today evening on WhatsApp group and winners will be awarded in the valedictory session. Thank you.
Now I would request Principal Ma'am, please come on the stage and give honors to our speakers and moderator, Miss Kamal, please ma'am. Please come on the stage, ma'am. I request Sir Dr. Sushil K. Meshwari, Professor, Baba Farid University and Health Sciences, Faridkot, please join the stage. And I request Dr. Amandeep Kaur Bajwa, ma'am, please join the stage. I request our moderator, Miss Komalpreet Kaur, Assistant Professor, Adesh University, Bathinda, please come on the stage and receive your honor. A big round of applause for ma'am. Thank you, ma'am. Now I request Miss Pavandeep Kaur, NS, GGSMH Faridkot, please join the stage and receive your honor. Thank you, ma'am. Next, I would like to invite Miss Neer Kamal, ma'am. Please come on the stage. He is Nursing Superintendent, SGRD, Amritsar. And please, ma'am, receive your honor. Please, a big round of applause for ma'am. Thank you so much, ma'am. I request Miss Ramandeep Kaur, NS, ACI Bathinda. Please, ma'am, come on the stage and receive your honor. Thank you, ma'am. Next, I would like to invite Miss Mandeep Kaur, MSc Oncology Nursing, PGI. Please, ma'am, come on the stage and receive your token of love. Thank you, ma'am. Next, I would like to invite the presentation paper judges. First is Dr. Rita Lakhani. Next, I would like to invite Mr. Naveen Kumar. Please receive your honor. Next, Dr. Reena Jesser. Please, ma'am, join the stage. On the behalf of Mr. Naveen Kumar, she will receive the honor. Thank you, ma'am. Next, I would like to invite the judges of poster presentation. Mr. Gopal Singh Charan, please, sir, come on the stage and receive your honor. Last but not the least, Dr. Amandeep Kaur Bajwa, ma'am, please receive your token of love. Thank you, ma'am. Thank you, sir. Please, students, wait a moment. Please be seated. Silence, please. I request Principal Ma'am and Sir Sushil K. Maheshwari, Professor Freedcourt, please come on the stage. Now I request Mr. Naveen Kumar, please come on the stage and receive your honor. Thank you, sir. Now I request Dr. Rita Lakhani, Principal U. Peter College of Nursing, Maharashtra. Ma'am, please come on the stage and receive token of love. Please give a bigger round of applause. Thank you, ma'am. Next, I would like to invite Dr. Reena Jairus. Please come on the stage and receive your token of love. And I request ma'am, Dr. Sukhbir Kaur, please join the stage. Thank you, ma'am. Life does not require that we be the best, only that we try our best. So, friends, try your best for success. Try to be as efficient as possible. I wish you all the very best. Thank you for your patience. Thank you, everyone.